Okay.
Madhu, should I start?
Yes, sir. Please go ahead.
Dear friends, I cordially welcome all the members of the State Ophthalmic Society to this virtual Ophthalmology Conclave 2023. In this year, this is the 5th program as a part of monthly educative initiatives from APOS. This online program had 5 sessions aimed to meet the needs of practicing ophthalmologists in day-to-day practice, covering all the specialties. As the president of APOS, I especially thank Dr. Chang, the universal man from USA, for taking his time from his busy schedule to deliver the first APOS global leaders in ophthalmology oration. I am very happy to see a record number of registration, more than 1,500 registrations for this particular webinar. And thanks to all the international and national faculty for their willingness to participate in this webinar. I congratulate the APOS Secretary, Dr. C.V. Gopal Raju, and the Scientific Committee Chairman, Dr. Madhu Udaraju, and his dynamic Scientific Committee team for designing this excellent program. And I hand over this over to the proceedings to them. Thank you.
Sir. Gopal Raju, sir.
Good morning, all of you. And first of all, I thank the executive committee for allowing us to conduct the midterm conference on a virtual platform. This is what we learned from the COVID. It's the potential of the virtual the meetings, and this is the main reason why we could able to reach persons like David Chang and other global leaders to follow the future conferences. I welcome all the national faculty and thank all of them for participating and sparing their valuable time to participate in our conference, and also welcome all the members, and especially I congratulate Madhu and his dynamic young team, scientific committee team, for excellent planning of this session. All the best, Madhu. Thank you very much.
Thank you, sir. Without further delay, I think I have the honor of introducing today's global leaders in ophthalmology oration by Dr. David Chang. And I don't think he needs any introduction, but just for the sake of proprietary, Dr. David Chang is widely recognized as one of the top 10 cataract surgeons in the world. He graduated with distinction from the Harvard College and earned his medical degree there. And later he completed his ophthalmology residency from UCSF and went on to become a clinical professor there. And he has been teaching cataract surgery for more than 4 decades now. And he is the 3rd ophthalmologist to ever receive the Charlotte Bear Award, honoring the outstanding clinical faculty members of UCSF Medical School. And he is recognized worldwide, and almost every country and every continent, the highest recognition that can be given to an ophthalmologist he has achieved, like the Binkhorst Medal in America, the Ridley Medal in Europe, the Award of Excellence in Canada, and the Rayner Medal for UK, the DOC Innovator Medal for Germany, the Limb Medal for APS-CRS, and so on and so forth. And even the most important thing, he has given more than 40 named lectures, and he has written more than 5 textbooks and contributed to several chapters regarding this phacosurgery and IOLs. But most of this, what we don't know is all these proceedings that he gets through these books or consultation fee, he directly gives it to the humanitarian work in the area of cataract blindness. And it is very heartwarming to know that he has started a humanitarian award in the ASCRS Foundation, being its chairman. And this award every year is given to the humanitarian organization that fights global blindness. And almost it also carries a prize of $50,000 along with this award. With his wife Victoria, he has created this wonderful initiative. So not only in academics, but also he is playing his huge role in preventing needless blindness in developing countries. And all of us know he has been working very closely with the Arvind Eye Care system in India. And we are really, really fortunate. Thank you, sir. Thank you so much. It is an honor to have you with us. Without much delay, I'll hand over the stage to him for the lecture we all have been eagerly waiting for. Thank you, sir.
Well, great. Well, good morning, and thank you for that very nice introduction. It's great to be joining you virtually. And I am going to be speaking over the next 45 minutes about something that we always face, and sometimes we cannot anticipate it, phacoazonulopathy. And the approach I'm going to take is, rather than show you the most difficult cases, I want to give you practical tips that everyone doing phaco can use. And in order to do this, I'm going to show edited pieces of what I call my best teaching videos. And these are cases that taught me and I want to use to teach you. So I have no financial interest in any device that we're going to show. So what makes pseudoexfoliation, for example, more difficult is, of course, we have to preserve the capsule in the bag, but also we have to avoid late dislocation of the bag and the IOL. And let me just see if that's here. Let's see if my videos are freezing here. Let's see. All right, here we go. And so here's, an example of a late bag IOL dislocation. This, of course, we started seeing once we moved to a capsulorhexis routinely. Now, what makes weak zonules such a challenge is they throw many different obstacles at us. We know the pupil may be small with pseudoexfoliation. It's harder to control the CCC. It can be more difficult to rotate the nucleus. Those fragile zonules are more easily broken, increasing the chance of a zonulodialysis. And finally, something we don't often think about or aren't taught, that posterior capsule is not taut, and that gets us into trouble. So the 6 tips I'm going to leave you with today are, it's okay to make a small CCC just so that you complete it, but then enlarge it at the end of the case. I think it's invaluable to use capsule retractors, and these are actually better than iris hooks. Always pause to reinflate the bag with a dispersive OVD for the last pieces when you have really significant zonulopathy. Learn to and be quick to use biaxial INA. Delay the CTR if you can until after the cortex is removed. And if you have diffuse zonulopathy, think about a 3-piece IOL in the sulcus if you're concerned about long-term stability. These are on the left are sort of my pearls for complex cases. And on the right, these are books from Slack. This is 70 chapters of many different authors on IOL fixation techniques with a bad capsular bag. So my first tip is, how do you avoid this capsular phimosis that you see on the right? Well, you almost have to think of the capsulorhexis as being a sphincter. It wants to contract and the diameter will shrink postoperatively. So in order to prevent that from happening, you can make an oblique radial cut and re-tear it. And with pseudoexfoliation, I actually go way out to the edge of the IOL. I'm not really worried about overlap because you're removing lens epithelial cells. The larger the diameter, the less likely it will be to contract. So here's a case of pseudoexfoliation. So when you see this bad phimosis, such as in the images on the right, that is an indication of 12 clock hours of weak zonules. And so they're not able to counter the contracting force of that CCC. So think of the CCC as a sphincter. You know, here, I really go out to the edge of the IOL. Now, this may not be something everyone's comfortable with, but you just don't want to leave it small, because then you're going to increase that contractile force. If you've got weak zonules, it'll actually stretch them out, and then it gets smaller, and then it stretches the zonules more, and then you get this vicious cycle where the capsulotomy opening gets so small. So you could also make just some partial radial cuts in the rexus. You don't have to go way out peripherally, but just don't leave it small is the key. Now here's a case where I don't have a CTR, and I put in a 3-piece monofocal, and this capsulotomy, which was round to begin with, became oval. And so what does that mean? It means that normally, you know, there's pressure from the two haptics along, probably along this axis, and the zonules 90 degrees away are not strong enough, and so the rexus moves inward. In other words, the push from the haptics is distorting the rexus. So I've decided I better put in a CTR. And so watch what happens when I put the CTR in. I have to aim the injector way to the left so the CTR opens to my right. And you'll see that the capsulotomy that was oval becomes round. And why this video is nice is it shows you the method of action of the capsule tension ring. It exerts push in all 12 clock hours pretty much equally. So it's really distributing all the force evenly across all 360 degrees, okay? Whereas prior to when I was putting this in, the force was where the haptics are, and the zonules 90 degrees away are not able to keep the capsulotomy round. So think about this. That's really what the CTR is doing. It's expanding that. Now look right here. Right there, you see a little halo sign, okay? And that halo sign is an indication of one of two things. It either means the needle is dull or the anterior capsule is lax. In other words, if there's not enough stretch peripherally from the zonules, then that anterior capsule is not taut, and it'll indent before we can incise it. So here you see the bleb on the left. This is pseudoexfoliation with glaucoma. So any hint of zonulopathy with pseudoexfoliation, I think we want to put in a CTR. And if I'm doing a monofocal, I'll use a 3-piece because the haptics do press out there and they give you a little more additional push onto the capsular fornix. So just remember this right there, that halo sign that's showing the anterior capsule being indented can be a sign of zonulopathy. I think most of us now have been taught the capsule tear-out rescue maneuver, which is the brilliant kind of insight that was given to us by Brian Little of the UK. And these were images from his original paper that he kindly shared with me. I'll show you my own case here. You know, you're pulling the flap along, and then you get to this point where, you know, it doesn't seem to want to follow you. It wants to veer out toward the periphery. And you know that you're losing control of it. And if you were to continue pulling, you would lose control. So Brian Little says, pull backward. And what that does is it puts it on stretch. Then while you have it on stretch, you can turn it to the left. And once you've now redirected it, you can flip it over and continue again. And you may have heard the analogy of a dog leash. So if this is the leash and this is the dog, and you feel like the dog wants to go away from the direction you want, what do? We tighten the dog leash. We put a lot of tension on it like this. And then once it's taut, we can control the dog better by turning the dog, in this case, left, so that we regain control. So let's watch a case. This is not zonulopathy. It's a white lens and there's cortex behind the nucleus that wants to push the nucleus forward. So right there, I felt I was losing it. So here's the Brian Little Rex's tear out maneuver. And I have to sort of regrasp. Basically, if you shorten the leash, you have more control over the dog. I think that's a really good analogy. There it's going to start. Oh, right there, it's kind of going out again. So I have to pull backward this way, and then I can control where the dog is going, and I'm turning it inward and then regaining control of it. Now, in this case, it was zonulopathy. Let me pause here. Right up here is where the tear is. And as I was tearing counterclockwise, it started to veer out. So I've stopped. I put in more viscoelastic. Now, to do the little maneuver, I have to pull toward the top of the screen, which is a little awkward. And I'm actually really peripheral. The pupil's very large. And look at the tension I have to put on that. And you see there's some folds here. Again, this is a sign of zonulopathy. This area isn't taut. And what happens when you tear into an area of weak zonules, it starts to veer outward. So that's a sign of zonulopathy. So with a lot of pressure there, I completed it. Let me show you what it looks like when the nucleus is gone so you can see the path that we took. And that's the tear out rescue maneuver. I use this every time, every day I'm in surgery. Now, look at this. This is a little bit of a halo right here. So is that a sign of zonulopathy? Well, actually, this is a teenager, and it's the same thing, and it's not a dull needle, but in this case, it's not zonulopathy. It's that the anterior capsule is very thin, it's very elastic, and so it's not taut. It stretches. So here I make the rexus small so I have time to recover, and I have to use the Brian Little capsule rescue tear out maneuver, capsule tear out rescue maneuver in order to gain control. And once I put the lens implant, like we said, we don't want to leave. Sorry here. So that is how we kind of gain control of it. So this is why it's hard to do a capsulotomy in a pediatric patient, because of that elasticity. Now, this is a different patient. And look right there. You see the elasticity here. I call this pseudoelasticity because this patient's in their 80s. And normally when you tear with the flap, the peripheral capsule, think about it, never moves. It should never move, and that's why we have control. And why does it not move? Because the zonules are fixating it and pinning it down. And so that allows us to tear. So if you grab the flap and you see the peripheral capsule with wrinkles or folds or it moves, that tells you that in this area, the zonules are weak. So watch that right here. See how it's moving? And so I have to do what? I have to use that capsule tear out rescue maneuver to gain control of it. And then I can complete the capsulotomy. So it behaves just like that pediatric patient. So I call it pseudoelasticity because the capsule isn't elastic. It behaves as though it was, but the cause is the lack of peripheral zonular tension anchoring that peripheral capsule. Okay, here's another case, pseudoexfoliation. I was proud. I got the nucleus out. And then as I started pulling the cortex out, I suddenly realized I had aspirated the anterior capsule and created a nasal zonular dialysis with my INA. And so I'm thinking, was I just careless? And the problem is that if your zonules are weak, it's a lot easier to create a zonular dialysis. All right, so what would you do here? You see the rexus is over here. I've got a little bit of, I know I've got some type of zonulopathy. What would you do in this case? So, some people in the audience will usually say maybe try a CTR. So I figured, maybe I have 4 clock hours. So I'm inserting it and I'm using my hook to bend it because I know that I've got a dialysis. So watch what happens. I bend it and I advance it with the injector. And what we end up seeing is the equator of the capsular bag. And my gosh, there's no zonules at all here. We are dealing with maybe 8 clock hours of zonulopathy. Look at this here. So now I'm thinking, I don't think I caused that much. I think this patient had weak zonules. I didn't do my INA carefully enough. And we often kind of aspirate the anterior capsule on the undersurface, but the zonules keep it from being torn loose. In this case, if there are no zonules or they're really bad, if you inadvertently grab the anterior capsule, you just create a massive dialysis. All right, so now I've got the CTR in, and what do you think is going to happen? Well, if you have like an 8 clock hour dialysis, look what happens when I do the cortex. I'm pulling here, the cortex is trapped by the CTR, and the entire bag is moving. Wait a minute, I'm pulling over here. Why is the bag moving over here? Because the CTR is transmitting all of this forces from my maneuvers to all 12 clock hours. So instead of helping me, it's actually damaging or stressing all the zonules, and I'm struggling because it's trapped the cortex. So it's not only made it worse, but it's probably causing me to do more damage to the zonules. So it makes sense if you have 3 bad clock hours and 9 good clock hours of zonules. But as you get to a situation where you have a lot of clock hours, a CTR is a problem. So hence, I'm wishing I hadn't put it in. So this is, again, a good video to understand. You see how the whole bag is moving, and I'm just pulling on the cortex at that spot. So I eventually put in capsule retractors, and that's the only way to get the cortex out. But remember that video when you're thinking about, should I put a CTR in with bad zonulopathy? What could you do? Well, I could have used this Henderson CTR from Morcher, which doesn't trap the cortex as much. But using capsule retractors, this is one of the earlier generations from Dick McCool, who really popularized this. This is giving tension to the capsular bag. The tips do not trap the cortex. And so you're putting counter traction on the bag that's missing from the lack of the zonules. You see on the left, I am able to remove the cortex a little bit more easily. All right, now this is a case of pseudoexfoliation. You can see I had to put capsular dye in. It's a brunescent lens, and I'm feeling really good because I did my chop, I've gotten it out, capsule's intact, and this is the easiest part because they're just a couple of little fragments. I'm cautious, I'm going to put my chopper underneath, okay, and then I just need to aspirate the last little fragment. So watch carefully. There they go. I'm on epinuclear set. Oh, right there. I grabbed the cortex. So did you see that? Let's watch that on replay. I'm protecting it right there. I grabbed the posterior capsule. Okay. So did we get lucky? No, we have a rent. Hopefully you can see right here where I grabbed it. And why? I mean, I've done so many phaco cases. Why did it happen here that it jumped up there? It's because the zonules are so bad that they are not putting the posterior capsule on stretch. If it's not on stretch, it's like flapping in the wind, like a sail on a sailboat that isn't taut. And as it's flapping around, any little bit of minor post-occlusion surge will immediately draw it forward. So settings that would be normally safe for a typical lens aren't safe enough here because the posterior capsule is different and it is not taut at all. So what should I have done? Well, what I should have done is stopped and put in a dispersive viscoelastic, not just to push the piece forward, but actually fill the capsular bag. Now that's a lot of viscoelastic. Why fill the bag? Because now I'm not only distancing the posterior capsule from the nucleus, but I'm putting the posterior capsule on stretch. Instead of having the zonules tugging on it peripherally, what the zonules are doing instead, the zonules are bad. So I'm going to stretch the bag from within. And once it's on stretch, it's taut and it won't sort of fly up toward the phaco tip. So I'm doing more, as I said, than just putting that distance. And we use a dispersive because it stays where you put it. If I was to use Heal-On, it would all come out the minute I press on position 2. But there you see how it keeps it back. Now, here's a case that I showed a little bit of earlier. I learned my lesson. I'm not going to make that mistake again. I'm going to put a dispersive in there, get that last piece out, and then look at what happens when I use the cortex. I'm going to use, I think, biaxial INA. And what happens, I see the bag moving, and I see the posterior capsule here as though it was really adherent to the cortex. And I used to think that why is the cortex so sticky that the capsule sticks to it so much? But really the problem isn't that. The problem is there's no counter traction because the zonules are so bad. So normally the reason cortex separates from the posterior capsule is because the posterior capsule is pinned and immobilized by the zonules. And when it's not there, look at what happens when I put the dispersive in. That cortex separates now. It's much easier to remove. Okay, so here, see how the capsule wants to come right up to the INA tip. And even though I'm doing this carefully with biaxial INA and I can kind of avoid aspirating the bag, you have to understand what the cause of this problem is. So now, if I inject my dispersive, watch how it stretches the capsule. Neither the viscoelastic nor the capsule retractors are going to trap the cortex. And so once I get a hold of it, I can pull it free and loose, and then I'll put in the CTR, after the cortex is removed. And after the CTR goes in, I remove the capsule retractors because they stabilize the bag. Here's a pseudoexfoliation case. You see the little halo. You see the bag is moving. So and you see wrinkles here when I tear the rexes because the peripheral capsule isn't taut. So this is an old case from about 2000 and maybe 2008, 2007. And I'm doing I'm happy I can do vertical chop to minimize pressure on the lens and the bag and the zonules. And I carefully pull these pieces out. So I'm feeling pretty good. Now, I should think about putting in viscoelastic here. I didn't know this back then. So you see how the posterior capsule travels with the cortex right up to the tip. So I have to be super careful not to aspirate the posterior capsule. Would have been, in hindsight, better to put a dispersive viscoelastic in. But eventually, by holding my breath and getting this out, okay, we're all right. You can see the bleb on the right. And then I say, now I'm going to put the CTR in because I learned my lesson. Don't put the CTR in until the cortex is out. Use the capsule retractors to serve as artificial zonules that support it. And I told you I like doing a 3-piece acrylic, even if there's a CTR, because there's pressure from the haptics expanding the bag. I said that think about the CCC as being a sphincter, and if I make it a little bit larger, it won't contract. I could have made some just little relaxing incisions, but the nice thing here is, I get a better red reflex. There's no convexity because the nucleus is gone, and I complete it, and I'm feeling pretty good. I did all the little lessons that I showed you, but then I kind of made a mistake. And what do you think that was? I was just curious about how the zonules are. So I started to shake the eye, and look what happens. Oh my gosh, the bag is jiggling. Everything is moving. Now what do? I mean, here's the choices. We could leave it alone. Maybe we could suture. I put in a CTR to the sclera, but we got this bleb there. I don't want to create a huge subconjunctival hemorrhage. We could suture the haptic to the iris, maybe. maybe we could move the lens to the sulcus and then suture the haptics to the iris, or I could just take it all out and put an ACIOL in, but then the patient has glaucoma. So usually a lot of people say leave it alone. So I don't want to leave it alone. If that patient came in 5 years later and said their vision was variable and I saw that, I'd probably take them to the OR and try to fix it. So I think I'm going to move it to the sulcus. And then if I need to, there I can suture the haptics to the iris. So if I want to go from the bag to the sulcus, I have to first go from the bag to the anterior chamber. Why? Because the haptics are angulated so that the optic is posterior. So it's impossible to accurately place the haptics if you're going from the bag to the sulcus. Whereas in the anterior chamber, I can sort of release one haptic at a time into that space, because I don't want to have one in the bag and one out. And then I can dial it in with better visualization. And now I'm in the sulcus. And so the question is, can I leave it there? Could I suture? Do I need to suture those haptics to the iris or to the sclera? So now the question is, would you jiggle the eye? Some of you would say, yes, let's see what happens. Some of it would say, no, I don't want to jiggle the eye. I shouldn't have done that in the first time. And some of you wouldn't jiggle the eye, but you want to see what happens if someone like me jiggled the eye. So that's what I'm going to show you now. And when we jiggle this eye, lo and behold, something amazing we see, that lens doesn't move. Well, why do I call this one of my best teaching cases? It's an old case from 2007, but it taught me so much, because without a randomized trial, without a series of 100 eyes, I have shown you the same eye and the same lens and what happens when we put it in these two different locations. And there's a dramatic difference. And the conclusion has to be that when you have this additional 2-point fixation of the haptic against the ciliary body, it braces the lens during this saccadic movement, okay? And so that's what's missing if the whole lens is in the bag. Well, you say, do you really believe that? Look, here's another case. I'm wiggling the eye and the whole bag is jiggling in this eye with diffuse zonulopathy. So I remember that first case. Let me do this again. Let's see what happens if we just take it out of the bag and move it to the sulcus, remembering that we first have to bring it into the anterior chamber and then one haptic at a time, sort of place it like this. You see there, it's in the bag. And, really, if the rhexis was not too large, I would capture the optic. See, I've buttonholed it there. It's a little elliptical. And now when I jiggle the eye, it doesn't move. So there's another case to show you that having those two haptics against the ciliary body braces things. So now I do this a lot and have done it a lot since 2007. Now I want to show you something else. Here's a zonnular dialysis. And when you inject the CTR, you should not feel resistance. And what happens is right about here, see, I'm feeling resistance, and also like a bow and arrow bow, this is bending. And when I feel that bending, I have to avoid the temptation to just keep pushing and realize that it's caught on something, maybe a fold in the capsule. I'm sorry, let's go back here. Maybe it's caught on something and I have to stop and, take some more time and bring it out. So if you feel that resistance, if you feel it bowing, you better be safe sometimes. So what do? I put a little more viscoelastic in because maybe it wasn't there. And, here's the problem area, right? That's why the hooks are all in that area in this traumatic cataract. So this time I kind of hook the eyelet and I kind of get past the problem area, and now I can feed it in, right? So we got the large, I had a zonnular dialysis. I succeeded. I've got everything out. What lens am I going to put in? I could put in a single piece in the bag. We got a CTR, but I've learned from those other cases, I'm going to put in a 3-piece acrylic. And in this case, because the dialysis is on the nasal side, I'm going to orient the haptics 90 degrees away, and I'm going to capture the optic so that this lens won't rotate. Because if it did rotate, and before I capture it, I go back and take out a little viscoelastic behind the lens, because when I buttonhole it, it's going to seal the rexus, and any viscoelastic there will be trapped, can't get out. Now, the reason I want to capture the optic is it prevents the rexus from contracting. It gives good centration, but it prevents rotation, right? Because that last traumatic case, if that lens rotated, then the haptic would find its way through the zonular dialysis. Oh, and we don't have to change the power for the IOL because the optic is in the bag. So I'm going to try to put all of this together now in a case of pseudoexfoliation. There is the little halo, a little movement. Oh, wow, the whole bag is starting to move here. So I know I've got diffuse zonulopathy with pseudoexfoliation. So I'm going to switch to my forceps. I'm not going to worry about having the perfect size here, because if I go too large, I risk losing the rexus. I'll deal with enlarging it later. Now, after hydrodissecting, a lot of times you have trouble rotating, and you again have to avoid the temptation to rotate more forcefully. The reason you're not able to rotate the nucleus is the zonules are not able to anchor the capsular bag. So the capsular bag wants to turn with the nucleus. So I've learned that, and when I see diffuse zonulopathy like this, rather than try to rotate it, I know I'm going to put in capsule retractors to play it safe. So I'm going to put those in first. And the ones that many of us are using now are from Microsurgical Technologies. And this is my modification. They call it the Chang modification. And it just is a different design that's a double-stranded loop. And we closed off the tip so a CTR cannot accidentally thread through it later on. So they come 4 to a pack, and I'll often use 4 with diffuse zonulopathy. So it's doing a couple things. It's anchoring the bag to the sclera. It's supporting it in the AP direction. It's also making it harder for me to aspirate the capsule with the IA tip or the phaco tip, like I showed you. See how easily it rotates? And so it's less likely to aspirate the bag because it's kind of restraining it from being pulled by the phaco tip or the INA tip. I like to use horizontal chop if it's not too dense, as you see here. And that means I'm pushing the full instrument against the phaco tip rather than putting any force on the capsular bag. We'll aspirate it out here, and we're able to try to now I remember the other lesson, that other great teaching video, that I got to put the dispersive in so that I keep the bag from flying up to the phaco tip. And there it comes, and the bag stays back. And I do like INA because I can get better access to the subincisional cortex. And I can, if there's a dialysis, dissociate irrigation aspiration. We replace the retractor. And remember that the dispersive makes it easier to remove the cortex when the bag is floppy and not anchored well. And again, I haven't put the CTR in because of those other experiences that taught me to delay that until the end. Now, if I know I'm going to capture the optic, put the lens in the sulcus, why put a CTR in? I do think that when the capsule retractors are gone, the zonules are not there, you do want to sort of prevent contracture. And although the optic capture can do that, sometimes you cannot capture the optic. So I just think it's safer to put this entire thing on stretch, and kind of it relieves any additional movement or stress on the remaining zonules from the contracting rexus. I mentioned I made the rexus small just to make sure I had it complete. So now I'm going to secondarily enlarge it because I do want to capture the optic. And if the rexus is too small, that's going to make it difficult. So I'm going to enlarge here, and then I'm going to actually expand and widen the space where the haptic is going to go so that I can place it in the sulcus. And once I do that, I might as well orient the lens with the haptics at 3 and 9. Why? Because the saccadic movements are in the horizontal plane. And so that kind of does the best job of bracing the mass of the lens in the bag against that inertial displacement of the movement. I've learned to take out a little of the viscoelastic behind the IOL. Don't have to be too aggressive, because once I push the optic back and capture it, it's going to trap any, you don't want to trap a ton of viscoelastic there, because that'll keep the lens optic forward. You'll have a myopic shift, and you'll have to do a YAG capsulotomy to release the trapped, posterior capsulotomy to release the trapped viscoelastic. So with a small pupil, a little hard to see, but now I can confirm by peeking that I have captured the optic. I got my zonules at 3 and 9, and this is kind of the case that puts all of these little lessons together. You know, you saw me do all of the lessons that we learned there. All right, so this is another situation. I've got pseudoexfoliation. I've got some too much phacodenesis. So what I do here is I've learned that when in doubt, be prepared to convert to a ECCE. So here I've just moved away superiorly. I've abandoned my temporal clear corneal incision. Because I converted early, I am able to maintain the posterior capsule and then suture this up. I leave the temporal clear corneal incision over here unsutured. Here are 2 more cases. On the bottom, it's just a super dense lens with iris prolapse. On the top, you can see there's a lot of movement of the lens. They're both mature lenses. And in both cases, maybe I could have gone on, maybe I could have gone away with it. But I think the odds are better for the patient with these brunescent lenses if I convert. On the bottom right, I'm using the manual small incision technique that Aravind has taught so many of us. And I think being in India, you have the advantage of more people doing this and more opportunities to learn this. And the United States, residents don't even learn to do an extra cap now. So on the upper left, I'm just doing the traditional convert to an extra cap. I use this to teach residents. So we'll make a limbal incision. In both cases, I have abandoned the temporal clear corneal incision and moved superiorly. So I have fresh tissue to make a good incision. You're not so worried about astigmatism in these brunescent, mature hand motion cataracts anyway. So I think it's very important to not only have this skill, but to utilize it. And there's no shame in saying, oh, you know, the really good surgeons do phaco on all of these. That's really, I don't think that's necessarily true. I think they do, if you do phaco on all these, because you don't know the alternatives. So to the extent I'm a good phaco surgeon, I am very quick to convert to an extra cap, because you know, normally your PC rupture rate should be under 2%. So that means even if you break the capsule, in 19 out of 20 times, you're able to do these cases without breaking the capsule. That's a 5% PC rupture rate, and that may be too high. And you're going to lose a lot of endothelial cells. So, you know, this is just, I think, an important point that I feel we don't do this enough. It's a great procedure for these really complex cases. And both of these patients did really well without protracted corneal edema and retained lens, right? I think that, you know, think about when to convert. It could be you have the chamber's too shallow, ultrabrunescent, but it's the combination with weak zonules. You can anticipate by doing this with capsule retractors. I think I do have time because we started 5 minutes later. I'll just show one more. These are older cases, but here again, I've got a zonular dialysis. The left-hand side of the nucleus is tipping. So like you, sometimes I'll start with phaco, and I've got to recognize, okay, I could put in capsule retractors, but this thing is tipping back. I don't think this is a good idea. I think we want to get the nucleus out. And if it's tipping back, I've got a zonular dialysis, and I'm going to have to do a vitrectomy, but I can get a better chance. I'll just deliver the lens and then do my vitrectomy. Now, there's so many different ways to fixate an IOL without a capsular bag, but when you've got an incision this big and it's unexpected, I think an anterior chamber lens that's well-sized makes perfect sense. You're going to spend less time with the eye, vitrectomized eye, reduce your chances of suprachoroidal hemorrhage. And again, it's very hard to do scleral fixation or any of these techniques when you have a soft eye, such as one with a big incision post-vitrectomy. And so I think this is a case where I'm seeing a lot of excessive movement of the lens. It looks like it disappears to the left-hand side under the iris. So I don't like how that's looking. That tells me I got a zonular dialysis. So I'm going to try to prolapse this forward, get it into the anterior chamber, abandon my temporal clear-corneal incision, take out the superior iris retractor, convert to an extra cap, and let's first and foremost not get retained nucleus. You can see, even though I chopped and got some of it out, it's pretty large. So we do the vitrectomy, and there's no posterior capsule. Here's an anterior chamber lens to go. So we talked about this. So I think I want to just review what we learned today. And I hope the cases that I selected have kind of taught you the way they taught me when I was the one doing them. It's okay to have the rexus small initially. Of course, it'd be nice to have it really large and spacious, but when you have zonulopathy, it's very hard to control that rexus. And one way you can increase your chances of completing it, if you're worried, is to make the diameter a little smaller. It gives you a little room to recover, but you can't leave it small. You have to be able to go back and secondarily enlarge it. I showed you the benefit of capsule retractors, and I use them early, even before rotating the nucleus, if the capsulotomy maneuver step teaches me that I've got diffuse zonulopathy. You can see pseudoexfoliation slit lamp. It's not till you perform the anterior capsulotomy that you really have a sense of how good or bad the zonules are. If you only learned one thing, you learned to reinflate the bag with dispersive viscoelastic before aspirating that final piece with diffuse zonulopathy. Bimanual INA is safer because you don't have to turn the port posteriorly very often because you can switch hands. And if you have a zonular dialysis or trauma, you can dissociate the irrigation aspiration, keep the irrigation in the anterior to the iris, knowing that your aspiration has to go behind the iris. Delay the CTR. I showed you that one case where putting in the CTR with the cortex there caused all sorts of problems. And then I think one of the best pearls, because I just don't think anyone else talks about it. I published this in my books, and I have done well over 100 cases since 2007 with the three-piece in the sulcus. And sure, you can use Ahmed segments, you can use sutured Sione rings. My experience is that people that aren't doing these cases all the time either don't have them, they haven't done the cases very often, it's very daunting. So here is something where everybody can put a three-piece lens in the sulcus and look just fine. So what are we trying to do? We're trying to avoid this late bag IOL dislocation. So when I have pseudoexfoliation, if there's truly no zonulopathy and it looks fine, I make the rexus larger at the end, or you can make little relaxing incisions again, mitigating the contractile sphincter-like force. I do, if you're not going to put a CTR in, I do like a 3-piece because at least the compressive force of the haptics are, expanding the capsular bag. If you have any hint at all of zonulopathy, or I think if you're going to do a toric lens or an EDOF lens, I would put a CTR in those cases. It makes it easier. In the first instance, it puts less stress on the zonules because the capsule won't contract. And if I'm going to do an EDOF or a premium lens, if I have a CTR, it'll make it easier for me or someone else to suture it if it ever subluxates. I don't put multifocal IOLs in because it's just so hard if that lens becomes loose to suture fixate it. And then finally, when you're in there and you see the bag is really loose, you want to think about, how am I going to rely on something other than just the zonules to fixate the lens? So you can suture a Sienna or Mal, you can ring, you can add an Ahmed segment, or use my little tip of a 3-piece IOL in the sulcus and capture. So I'm going to, my 45 minutes are up, and I'm going to end there because we want to leave plenty of time for the discussion. And thank you very much for this opportunity to give this lecture.
Thank you, sir. Thank you so much. Wonderful videos as always. Now I request Meenu Mathan sir to initiate the panel discussion. Meenu sir, you are here.
Yes, Madhu, thank you. But initially, I would like to thank Dr. Chang for going in such a systematic way and a basic teaching to advanced teaching, to covering all parts. So I had written down so many points, and I have very few now left to ask because almost everything got covered in this one. I would like to just start off with the initial 2 cases which you had shown about the retraction of the rhexis margin while it tries to run out. Does the speed of pulling it back centrally matter, or do we do it very slowly? Sometimes I've seen that when you try to do it slowly, it tends to go further out into the periphery. So what do you suggest, sir?
Well, that's a really good question. It's really how to do the Brian Little's maneuver. And I think you want to make sure you have a good grasp of the capsule. And then depending on how bad the zonules are, it may be easy to do it or difficult. But I don't think it's so much the speed. It's very deliberate movements, and it's the force. It's the force that you need. So if the zonules aren't too bad, it's not too far out, you don't need a lot of force. Like those mature white lenses that I showed where it wants to veer out, you don't need much. And then the second one I showed where the zonules are weak, you actually have to put a lot of force, and you go, is this really a good idea? Because I'm committed. I can't just do it a little bit. It's committed. So it's not so much the speed, but the fact that you're committing yourself with a lot of force. And sometimes that can be uncomfortable, and you have to have a couple of wins like that to build your confidence that it actually works. But it really is, it is such an important understanding. Phaco is all physics. We think of it as our hands skillful and so forth, and yes, we need to have steady hands, but what really makes you look good or not look so good isn't just the steadiness of your hands, it's understanding physics. And all of the lessons that we talked about today are physics. And these are the cases, zonulopathy, where understanding the physics of what's going on is critical, because those are the principles that guide us.
Thank you, sir. Just one more. Can I ask one more?
Yeah, please go ahead.
The aspiration flow rate, when you showed that the bag has to be inflated with dispersive viscoelastic, after that, do you come down on the aspiration flow rate, or maybe even the vacuum also, to reduce the aspiration of the dispersive viscoelastic, which you have already used to inflate the bag while taking out the last few small pieces?
Yeah, that's a very good question. So I have 2 settings on my INA. I have one for cortex, and then I have another one for viscoelastic where I use higher flow because I want to wash it out. So if I just simply use my normal cortex settings, the dispersive really stays there. And I know that because in another case, when I filled the eye with dispersive viscoelastic and I try to use my INA settings, I can't get it out. So I have to go to a viscoelastic setting using a very high flow rate to get the viscoelastic out. So you don't really have to lower the bottle or lower the aspiration. You want to use your normal settings because in essence, you are still dealing with the same cortex and the same forces. I think the idea of changing the settings is when people are doing a case and they haven't inflated the bag with viscoelastic, and they're going, oh my God, the bag is flying up and down at me and it's jumping in there, and not understanding the physics. The only thing you have is, well, I got to change the settings somehow. Maybe I got to lower the vacuum. Maybe it's coming because the vacuum's too high. But it's not that the vacuum's too high. It's that the capsule isn't held, taut, and stretched by the zonules.
So even for the last nuclear pieces, the case when you showed that you got the poster capsule.
Well, the last nuclear place, I'm always using my epinuclear setting. So if I'm doing a routine case and I have a dense lens and I just have that last little piece, I'll usually go to my epinuclear setting, and it basically cuts my vacuum down to something like 200, very low vacuum. Because why? I'm worried about post-occlusion surge, and there's no need for high vacuum for gripping or so forth. So most of us, for our epinucleus, will use a low setting. We don't need to have a high grip, and we're not moving the nucleus around. And we know that because it's safe. And when we use that setting over and over and over again, and we don't see the capsule fly up to us, so we know to trust that setting. And that's why you go in with a false sense of security. I'm on my epinuclear setting. I'm home free. I know it's always safe. And whoop, the bag flew up. What happened? Was the setting wrong? No, it's a different case where the capsule isn't taut.
So what is the physics behind the rexus not phimosing when you have the optic captured within the rexus? We have 2 points where it is stretched, but the rest are free. What is the physics behind this stopping?
Yeah, but because you have those 2 points and the optic is there, that rexus cannot decrease in diameter. It cannot close down in its diameter. So that is one way to prevent capsule contraction is optic capture,
Thank you, sir. And do you have a direction of a placement of capsular tension ring? When you have a dialysis, would you introduce it into the dialysis, or do you have a specific direction?
Some people do. I don't think it matters. I actually showed the case where I was using the video to show, the pitfalls of CTR was when I was injecting it into the direction of dialysis. And that's because the dialysis was nasal. I had no choice. And so I actually think that injecting the lens toward the dialysis is a little riskier because you're going right into an area where the capsule isn't pulled, the fornix isn't pulled out. This is what we don't see with the iris blocking our view. So we don't have the fornix kind of expanded by the zonules there. So if I had a choice, I'd inject into an area of good zonules and then let the ring continue to travel along.
Yeah.
Thank you very much, sir. Thank you.
Thank you, sir. Sandeep, you want to add? Dr. Sandeep is also a prolific phacosurgeon, sir.
Yeah,
He does a
no.
lot of these cases.
I hope you'll add, instead of just having me do all the talking, please add your pearls and your insights as well. We have a lot of experts tonight.
Good morning, sir. What is your take about the capsular phimosis in retinitis pigmentosa cases where you have very dense capsular phimosis? So what I do is I do a very good anti-capsular polishing. So the polishing itself, reduces the epithelial cells and the contraction does not happen. Even PXF, I know it is little difficult to polish the anterior capsule if the zonules are too weak. But if you can do that, phimosis can be prevented. What is your take, sir?
Well, I do agree because, you know, the phimosis is really a cellular reaction. It's the lens epithelial cells. So if you had a way to kill all the lens epithelial cells, and for a while people were pursuing that as a way to prevent PCO, then it wouldn't happen. The problem is that, well, two things. One, you should use a curette. Some people are used to vacuuming the anterior capsule under surface as a way to, you know, clean off the epithelial cells. And you don't want to be doing that if you have weak zonules, because the normal forces that keep the capsule from being pulled loose aren't there, and you may cause a dialysis. So for me, I'm not really big on vacuuming, you know, anyway. There's something called, you know, the dead bag syndrome. And so I think it's always been a little controversial as to how important that is. You know, people have done it for PCO prevention. But yes, I mean, I think that would be one factor. You're basically trying to decrease the contractile force. And so it's a cellular force, so you take the cells away. You could make sphincterotomies in essence, or you can increase the diameter. The cellular reaction is worse the more when you have contact with a silicone optic. We know that. And it's probably worse when you have contact with the optic. So just getting the edge of the rexus off of the optic, I find, and I think it's more than just the larger diameter, I think it's the fact that it's not touching the optic, it really reduces that force.
Correct, sir. I totally agree with you, because you're reducing the size of the capsule itself by cutting off the edge, so that the phimosis, the strength of the phimosis actually comes down. But when you are doing, I mean, if with a single piece lens, I mean, it's very good for a 3-piece lens. With a single piece lens, don't you think these hydrophobic lenses are not as biocompatible as the hydrophilic lenses? Or some patients where we implant a hydrophilic lens because the patient cannot afford hydrophobic lenses, the contractions are going to be quite large, even with a small capsule left behind.
Yeah, that's interesting. You know, in the United States, we have up until recently just not had hydrophilic lenses. So our experience is silicone or hydrophobic acrylic. So that's good to know.
Thank you, Sandeep. I think, sir, Sunil, sir, you want to add? Sunil Sangraj, sir.
Hello, Dr. Chang. So nice to listen to your presentation. I just want to, you know, I was just listening to your presentation. I just want to tell my take and hopefully get your thoughts on it. So basically, you know, I hear this a lot that you place the CTR as late as possible. But my take, you know, many times when we land in surgery and suddenly it's an unanticipated subluxation of the lens. And then what I have seen is after the hydrodissection, if you place the CTR and then you place iris hooks or capsular hooks, usually I place iris hooks. So now my CTR gives the horizontal support or the circumferential support, which will prevent your capsular bag from coming up. And your iris hooks on the capsular rexus edge gives that vertical support. So basically you have an open sac, which is very well stabilized, and you can then very safely do rotation in all your procedures. I completely agree. And that's why I said you do the CTR after the hydrodissection, not before. Not before, because then the cortex aspiration becomes extremely difficult. Even then, yes, as you said, the cortex aspiration can be difficult. But then if you take your cannula and sweep along the circumference of the CTR, you can get out the cortex without causing too much zonular dialysis. And the second point, that was so nice to hear about the 3-piece IOL, placing it into the sulcus, because this is what I do. And I find it's extremely stable. The other thing that of course, not always possible to do, is to capture the optic of that 3-piece IOL within the rexus. Because what I think is now you're actually supporting something that is unstable with a stable IOL. Whereas in the other way around, when you put an IOL into an unstable bag, it's not a very great idea. It doesn't follow physics, as you said. And
Well, yeah, let's just do the last point. I agree. And, you know, it's, if you've got 2-point fixation in the sulcus, we know that with no capsular bag and just sutures, that works, you know. And so here, you don't need the sutures because the bag kind of prevents it from falling back. And yet, you know, it's kind of occupying that space like the springs. So I think it's a very, very powerful thing. And, you know, again, I show that video a lot because to me, it's more convincing than a study. It's hard to do studies where you isolate just one variable, you know, and it's also hard to follow people long enough. You're right. If I have certainly had to do situations where I needed the CTR while the cortex was there, sometimes even the nucleus, you know, and you want to stabilize it. And, you know, you do create, so I try to create a plane with a dispersive, and you kind of lift the capsule up and you're trying to create a little bit of an open space, and you just try to thread the CTR anteriorly so it doesn't go down too deeply, and it works, and the cortex comes right out. In so many cases, though, not all, but in so many cases, just the capsule retractors seem to be enough, and then you have the luxury of really not having to do that, because putting a CTR in while the nucleus is there and not trapping the cortex, keeping it very anterior, is an advanced maneuver, and it's tricky. So I would say that in principle, if the capsule retractors do everything you need, then delay the CTR. But there are situations, and if you're really able to do that, I agree. If you're able to put the CTR in and not trap the cortex, then it's not doing any harm.
Thank you, sir. Next, we have Dr. Rajesh. Please go ahead, sir.
Yeah, thank you very much, Dr. Chang, for showing your excellent, wonderful videos. I have one question. How many clock hours of zonular dialysis you will still consider CTR than going for a secondary scleral fixated IOL?
Yeah, I think that, you know, I think you have to, if I was just going in the bag, certainly 3, 4 is awfully good. I think beyond 4, you're worried a little bit about, you know, certainly 6 or more, it's not stable. So you need some type of support, and that's why people would put a sutured segment of some type. And the nice thing about the Ahmed segment is you can put the CTR in, and if it doesn't look stable, you can add that, and it's easy to put in because it's small, and then use a scleral suture. If you're going to fixate with the lens in the sulcus with optic capture, you actually can, you know, then it kind of takes all of that out of place. There are situations when the zonules are so weak, you put the 3-piece in the sulcus and you can't capture the optic, because if you were to push down just to capture it, you're going to push the whole bag away. It's that tenuous. So you have to know that you can't do that all the time. And those then are the cases where sometimes you put it in the sulcus and the 3-piece can still subluxate, you know, find a little opening in the zonules. But, you know, you can go back and throw in a suture to hold it to the iris. You can still suture, even if you suture 1 haptic to the iris using a mechanical type of method, you will prevent it from rotating, you know, and the rest of the bag, the existing zonules, will support it from falling posteriorly.
Would you consider putting a CTR before starting your phacoemulsification with the nucleus in the bag?
Yeah,
Yeah.
that's what
I think that's what we were talking about earlier, that there are sort of some occasions where that might be necessary. But I would say for most cases, I think that's the exception, because for most cases, just the capsule retractors by themselves do the job.
All right.
So when you're
Thank you.
able to put in the capsular rings, it's better to delay the CTR. That's what he was emphasizing on.
Right.
Yeah. Thank you. Ashok, would you like to add to the discussion? Next, Meher, please be ready.
Very nice videos and points that were learned from your talk, David. So I just want to add. So I really like the time you spent on completing the rexes in a perfect way. I think if we expect zonular dialysis, the first thing we have to ensure is how to make the rexes complete. Complete means 100% perfect. Because if you leave a small tag or something, then using CTR, everything goes out of the way. Capsule hooks and everything. And coming to the rotation, sometimes, I mean, even normal cases, we get a little less rotation. So, and then I take a chance. Shall I try doing a chop once or twice? Then if it doesn't work, then I think of switching to small incision cataract surgery, manual small incision cataract surgery. But I had times in which the moment I entered, I mean, I had the nucleus sinking down just because of the first stroke I made. So I think over time we learn how to judge a case based on the patient's age, pseudo exfoliation, of the cataracts and everything. And this one other point which I would like to add is I had recently had a problem with the CTR insertions. I don't use an injector. I do manually inject CTR. So it didn't go into the, it was going into the bag, but when the trailing thing went in, it jumped out and it was into the sulcus. So I was trying to pull it out into the sulcus and trying to again put it into the bag. I made the mistake. Then I realized I had to take this whole CTR out of the eye and then start injecting fresh. Only then you will achieve the CTR effects. So these were few learnings which I thought I will just add. And if you don't mind, I'll just share this thing which I use it for this thing, teaching our postgraduates. So there are a few factors. I teach them like a hammock concept of the lens zonular complex with the factors affecting the capsular capsular bag as well as the zonules. And also, so this I assume as a thing which on the left side you have a very clear cut case, and on the right side you have a very complex hard nucleus, heavy nucleus with the weak zonules. The pupil also becomes small. So these things make me judge to choose which procedure to go ahead with, either to choose phaco or an SICS. Thank you.
Very
Oh,
practical.
That's very good. Yeah,
Yeah,
and thanks for sharing those insights.
Yeah.
That was very funny. There was one comment from Dr. Talk, and what's the PCO rate when you put the lens in sulcus without the capture? It's definitely higher because you don't have generate the square edge effect of kinking the posterior capsule. So you are going to have a higher YAG rate, but we're just happy to have the lens stable in those cases.
Yeah. Meher?
Wonderful videos and discussion. Thank you, Dr. Chang. We, especially in India, here have SICS to fall back upon when we consider phaco, when we think that phaco is too difficult or it causes super sticks on the journals. So what grade of cataract would you consider is too difficult to continue with in the presence of zonular dialysis? And like we have SICS, what do you do? What is your alternative method?
I had trouble hearing if there was a question.
Yeah. He's asking which grade of cataract would you prefer to do an SICS and not a phaco in zonulopathy?
Yeah, well, I think that it's really a combination of all the risk factors. If this it's like you could give points, and you get points for this, points for that. When you add it up, when there's too many points, that is too many risk factors, you better do that. So one of the risk factors is your experience. One of the risk factors is the brunescence of the lens for sure. Other risk factors might include Fuchs dystrophy. The zonulopathy is a big one, right? Because they often go together, and that's a really bad combination. The other might be small pupil size. So whenever you feel that the risk of PC rupture and retained lens and significant endothelial cell trauma and loss is getting too high, and you can lower those risks by doing a manual extra cap. I always do the test. If this were my eye, what would I want? And if I had that bruness in a lens, I'm probably not the person that is going to want a multifocal or premium lens. And I just want to see well, and I must have been scared to not do it, or it could have been for access or insurance or cost, but whatever. What would I want in my eye? I think particularly if the surgeon wasn't really experienced in phaco on these really brunescent lenses, I prefer you do a manual extra cap, because if I waited an extra 10 years to get my surgery done, I can wait an extra 2 months for my refraction to stabilize.
I've heard Dr. Chang say it is SICS is sutureless ECC. So what he says, ECC is, so we have the advantage of using a sutureless ECC as our SICS.
Yeah, that's true, sir.
Thank you, Dr. Chang.
Yeah, thank you, sir. Thank you so much. Any other questions from Vishnu, sir? I think your questions are already answered.
Yeah.
Do you want to add something?
Dr. Chang, what is your strategy in spirophakia, where still some amount of granule attachment is there? Spirophakia cases.
Yeah, I mean, a spirophakia is a little bit like a diffuse zonulopathy. And, maybe that's why the lens is becoming spherical. So you have to expect zonulopathy. Obviously, you have to, flatten the convexity. It's harder to do the rhexis. So it's a little bit kind of another exaggeration of the problems and different version of the problems with pseudoexfoliation. So there can be very, very difficult cases. I think with all of these, to me, again, what would I want as a patient? I'd want someone to tell me that, my chances of a good anatomic outcome go way up if I do the cataract before it gets really advanced. That's the one risk factor that you can avoid, is not to let it get there. And I think we're much better at that. But when I was starting training and early career, a lot of people say, oh, you got a risky eye. Don't have surgery until you really can't wait any longer. And of course, I don't think that was good advice to still do nowadays.
No,
we have all the
better.
tools, we have all the understanding,
Yeah.
Yeah. Why wait until we triple the risk of complications?
Yeah.
Thank you.
Madhu, I think there were 2 points which he had mentioned about doing these kind of cases under a block, and also having an ACIOL standby and not hesitating on placing an ACIOL. Prepare the ACIOL well, take the measurements, have the right sized IOL, have the right sized sizing of the IOL and the measurements beforehand, and a vitrectomy well done and a PI. And that stress points, the alternative of SICS, if we have it, it should be taken. And doing all cases of phaco, as he has rightly mentioned, some it is because the alternative is they are not equipped with the alternative. But if we have the optic alternative, we should be. Sir, your
Yeah.
talk, Chang sir, your ACIOL stress, I would like to hear once more again.
Yeah, no, anterior chamber lenses, of course, I'm an older surgeon, so I put in so many early in my career, and with the proper model, the proper design. So most of historically, the problems with ACIOLs were bad design. We know all about that. The next set of problems is people not using the right size, although again, a few eyes are too large, a few eyes are too small. They work very well in most sizes. So it's a lost skill set. And I don't I think one of the things that I notice at meetings and so forth is, there's a little bit of I want to be very careful here. I think people overstate the they make it sort of they really denigrate ACIOLs like they denigrate extra caps. And I just don't think certainly the outcomes don't tell you otherwise. I mean, those of you who are doing SICS, you know that that's a safer procedure. And if you were forced to do phaco, you would have a higher a complication rate. And for many surgeons, there just aren't enough of these cases that everyone can be super good at doing a Yamane technique, or whatever the technique is. Whereas an anterior chamber lens is pretty straightforward and it's over quickly. And I think it really matters how good you are at working on, when the eye is soft and it's been vitrectomized, it's much harder to do these techniques. So I think that people unfairly criticize AC lenses. And I just have the benefit of so many that I did 30 years ago. 20 years ago, and they do beautifully because it's the right size. And when you already have a big incision because you converted, or or if I'm explanting a lens, that's a dislocated bag eye, well, I just take the whole thing out and slide an AC lens in, do a vitrectomy, and it's very clean. And then finally just realize that when you have done a vitrectomy and you have a larger incision, that's the one that's going to have a suprachoroidal hemorrhage. And you just don't want to be taking all day there. Not to mention, you're already exhausted because it was a complicated case, or you're a little shaken because it was an unanticipated complication. And, you don't want to sort of unnecessarily make it more difficult because you feel you have to do a Yamane technique or something, and otherwise everyone will criticize you. So anyway, I always try to show an AC lens. I always try to show an extra cap so that, people don't think there's a stigma against doing that. Every study, no one's been able to show in a large study, they're all retrospective, that there's a huge difference between ACIOLs and some, sutured or some other method of fixating PCIOLs. They're all complicated eyes anyway. And so I don't think anyone has to apologize for doing an ACIOL. And when people say, oh, I think it's a terrible procedure because I've seen this happen, I've seen this happen, that's just anecdotal and that's not scientific. And it's just like someone saying, oh, I've seen complications, terrible complications when people tried a Yamane technique. And so I would never do it, therefore. That's also anecdotal. So anyway, I hope that gives a little balance.
Yeah.
I'm interested in what our esteemed panel would do as well in terms of ACIOLs.
The problem, Dr. Chang, what we find here is now ACIOLs, the companies, there are hardly any companies making them. So we don't at least in India. So
more of iris class.
We don't get very good, designing very good quality. Anecdotally, yes, I have not done a study, but anecdotally, we do see with our ACIOs a little more reaction, a little more. So we have all moved, and now we are all moving to this retropupillary iris fixated lenses,
Iris.
Yeah.
which
No,
is
that's actually, I'm glad you brought that up because you have that, we don't.
yeah.
You don't. And I think that is definitely within the skill set of people. And again, you already have a big incision. I think that's a great technique. I wish we had those.
And as you mentioned that, all these techniques working in a soft eye is difficult. It takes some experience, some skill.
Yeah.
Yeah, Orolab makes it. Orolab makes it. It is still there, Sunil. Buy from Orolab. Orolab
Orolab still
and
makes
APOS,
it, and
APOS yeah.
okay, and they make it in different sizes.
Yes. 12, 12.5, 13.
Very good.
Thank you, sir. Thank you so much. I think Sachinand Raju, sir, are you there online?
Yes.
Yeah, please
Dr.
go
Chang,
ahead, sir. Yeah.
I think everybody has covered on the topic so well that left with nothing, except that I am interested to know about the residual correction you are the first person to do in US, the light-assisted lenses. Sir, are you still doing that?
The light adjustable lens, correct? Yes.
Yeah, light adjustable.
No, yeah, there've been it's a fantastic technology because you basically can change the prescription, and you have 3 adjustments that you can do. So it's increasingly being adopted here in the United States. It's expensive, it's time intensive, so it's hard to do it on everyone. But for the patients that are higher risk for refractive errors and surprises who really care about it, they're increasingly they're very willing to pay extra for it and make the extra trips. So it's not only post LASIK PRK, but certainly post RK. It's people with keratoconus. It's a adjustable toric lens, correct 3 diopters of astigmatism. So people that have really variable topography from EBMD or kind of corneal issues, the people that love monovision and just really swear by that. But it's also, I don't know, I think you have patients like this as well. We have patients that are very exacting, they're very compulsive, they're very indecisive, they just cannot decide, and they're really tough to deal with, and they have so much anxiety. And so we do the adjustable lens on them and basically tell them, you'll be able to try it and then decide if you don't like it, we can change it, and so
how many times would you
it's a really good complement to the other lenses we have, because there are so many people that we know there's a much higher risk of them being dissatisfied.
Sir, how many times could you adjust these lenses?
3
times. Okay.
3
Thank
times.
you.
But
Thank you.
if you have 3 diopters of astigmatism, you're not going to get it all in one shot. You may need 2 adjustments just for that. So it's not, you kind of you don't want the patient to think of it like contact lenses. Well, let's try this, let's try that. But you when you want one eye closer, what's the sweet spot where it's close enough, but I didn't give up too much distance and binocularity? And that's why we're good at it with contact lenses. We can find that, because all of us, if we were doing a mini monovision, we'd probably many of us would choose different amounts of myopia in our second eye. If we could try it with a contact, and so there is no perfect outcome where we know in advance it's going to be perfect for everybody. So it's a really, really powerful technology for that reason.
Yeah, thank you so much, sir. I
Sir,
think
sir, one more question. One more question. One more question, sir. You started the case as a toric implantation, and then you recognize that there is a diffuse johnulopathy. Still, do you go ahead with the implantation with a toric IOL?
So, we didn't spend a lot of time on it. I think that if you think the bag will be stable through some combination of your CTR, then I think a monofocal toric is okay. I even think the EDOF, because they are a little more forgiving of residual refractive error, decentration. I just don't put a multifocal in anyone with zonulopathy or, special circumstances, of course. I think that, for severe zonulopathy, well, now you got to weigh. You got to weigh the risk of a misaligned toric lens versus treating it with, glasses, contact lenses, LASIK,
Surface ablation.
keratotomy. We have so many ways to deal with that. So it's very much a case-by-case situation.
Yeah. Thank you so much, sir. Thank you for your time. I think we'll have the final comments from Gopal Raju, sir, and vote of thanks by Shiv Prasad, sir.
Madhu, one comment.
Okay, thank you very much. Yeah, go ahead, Vishnu.
Gopal has one comment, but the best take-home message is consider that as your eye and choose the right technique. That is I thought that is the best take-home message from Dr. Chang, sir.
Definitely. Yeah.
Okay, thank you very much, sir.
Thank you, Dr. David Chang. That was an excellent teaching the session, and use learning from you directly right from the mouth. So thank you very much for sparing your valuable time. And also thank other panelists who have added value to that. So thank you very much.
Yeah. Thank you, sir. Thank you so much. And thank you for giving our first Global Leaders in Ophthalmology GLOW lecture. You have added value to the oration, sir.
Well, thank you. And it's been an honor, and it's so great to have, thank you for so much time to get into this topic in great depth. And it was great seeing everybody.
Thank you. Thank you. I think now we'll go to the next session. Dr. Sudhakar Potti, sir, and Madhavi, madam. Are you there?
Yes.
Yeah, can you please take over the session and start, madam?
Good night, Dr. Chang. So you can exit.
Yeah.
Good morning, everyone. At the outset, I would like to thank the organizers of VOC, Dr. Gopal Raju sir and Dr. Madhu Raju, for giving us this very interesting session. First, I would request our chairman for this session, Dr. Potti Sudhakar sir, to give his opening remarks. Over to you, Dr. Sudhakar.
Good morning, everybody. Am I audible?
Yes, you are. Okay.
So we have a mixed kind of session, that is both cornea and refractive. We'll start with it's there, and some of the topics are very important for everybody, and some perhaps only for people who are into the refractive part. So we'll, without wasting too much time ado, because there's a long day ahead, we'll start with Dr. Rajesh Sinha, who is going to speak about DM detachment. Can be a horrifying experience for any cataract surgeon, which means all general ophthalmologists. So we'll look at Dr. Rajesh to give a kind of generalized quick fix and for everybody, and of course show us a few of those mind-boggling complex detachments too.
Thank you, sir.
Yeah, just a moment before Dr. Sinha can start his talk. This session has 6 talks of 10 minutes each, and followed by a half-an-hour discussion with the expert panel. So I request all the speakers to stick on to their time. Now over to you, Dr. Rajesh Sinha.
Yeah, thank you, sir. At the outset, I would like to thank Dr. Gopal Raju and Dr. Madhu for giving me the opportunity. Descemet's membrane detachment is something which is quite commonly seen after cataract surgery, and but a lot of such detachments are innocuous, and they settle on its own. You don't have to do anything. These are small detachments. But if there is extensive detachment in such a scenario, spontaneous resolution is unlikely. because there's a collection of fluid in the supradesmate space, and this results in gradual compromise of the endothelial function, results in corneal decompensation, scarring, vascularization, etc. The major causes, one of the most important causes, use of blunt instruments to enter the eye. And sometimes when we reuse these instruments, they become blunt and they cause detachment of desmoid membrane. And sometimes excessive wound manipulation or the direct touch of the instrument, all these things, even wound hydration has resulted in detachment of desmoid membrane. So if there is a desmoid membrane detachment, the patient will come to you with a blurred vision, photophobia, watering. When you examine, the patient will have corneal haze, and there's a general tendency that you immediately start with the hypertonic saline, but it doesn't work. And if it doesn't work, then you start examining. So the message I would like to give is that whenever there's a corneal edema in the post-op period, one should very nicely and thoroughly examine the patient on slit lamp and see if there's presence of any membrane like this present behind this section of the cornea. And that will give an indication of a desmoid membrane detachment. In hazy media where slit lamp examination does not give you a very conclusive result, in such a case, by ASOCT only, you are able to discern that there is presence of desmoid membrane detachment. Anterior segment OCT helps you not only to detect anterior desmoid membrane detachment, but also gives you the idea of the extent of desmoid membrane detachment. And even if the cornea is edematous, you can see it clearly and you can plan management because you get to know that which area is attached and which area is detached. DMD can be classified into planar and non-planar depending upon the height of desmoid membrane detachment. If the height is less than 1 millimeter, it is planar. If it's more than 1 millimeter, it is non-planar. Just an example of a peripheral planar detachment, an example of central planar detachment. Large central planar detachment. I'm sorry for the background noise. Actually, I'm at an airport. This is an example of a large central non-planar DMD. This classification we did after studying all sorts of DMDs. And this was one study done along with Dr. Harminder Dua. What prompted us to do the study was what we found out that there are some detachments which are very taut. And some detachments, you see, these are very taut and some are wavy. So whether there's fibrosis in these taut detachments or it is just is something else. And that gave us the incentive to work on these detachments. And we could, after doing all those studies, we could figure out and we could classify DMD into 3 types. Type 1 is detachment of both DM and DL, that is Dua's layer, and both are attached to each other. Type 2 is detachment of desmoid membrane from the pre-desmotic layer, and type 3 is a mixed detachment. So this is an example of a type 1 wherein Dua's layer and the desmoid membrane both are detached, but the 2 layers are attached to each other, and that gives a taut detachment. Another example of a type 1 detachment, another example of a type 1 detachment, again a type 1 detachment. This is a wavy undulating membrane. So this is a detachment of only desmoid membrane and Dua's layer is intact. It's not detached. So that is type 2. This is again an example of type 2 desmoid membrane detachment. This is an example of mixed type of detachment. You can see here there is a undulating membrane beneath which there is a taut membrane. So this is a mixed type of a detachment, which is type 3 desmoid membrane detachment. So whatever be the detachment, whatever type of detachment is this, the best thing is to do desmodopexy as early as possible, because if we delay in intervention, it can result in decompensation of the cornea. And the most important thing that we have to do is to cause a tamponade by air or gas. And intraoperatively, if we detect, like in this particular case, if we detect intraoperatively, there's a small DM detachment. So you make another port. I think this port is a little closer. It should have been made somewhere here so that you are absolutely away from the detached desmaze and remove the viscoelastic. So sometimes in the end, you see that there is a DM detachment. So you have to manage accordingly. Like for viscoelastic removal, this was done, but somehow I still feel that the opening should have been somewhere here. And then you may inject air. Intracameral air helps in superior detachment, unscroll detachment, and peripheral detachment. Gas is specially required in inferior detachments, or you have a scrolled edge, or sometimes it's a long-standing detachment. And in such cases, even you have to give a venting incision to drain the fluid that has collected in the supradesmatic space. And in an unscrolled detachment, you can just inject gas or air from clear area. In a scroll detachment, you have to inject the gas opposite to the scroll so that it unscrolls the scrolling of the membrane. And as I said, venting incision is required in some cases wherein it's a long-standing detachment with collection of fluid in the supradesmatic space. So this is an example of a detachment in this area. So you can go from here. This is the inferior part, so it is easier to go from here. So you can inject gas, and that creates a tamponade. Intraoperative OCT helps you a lot, not only to evaluate the extent of detachment. As you can see here, I can scroll the cursor. You can move the cube and see the extent of detachment all around. And it also helps us to inject gas. So that is also something, because intraoperative OCT will give you an idea that this area, you don't have a detached desmaze. So you can make a port there and inject gas from that area. So these are some of the examples. Intraoperatively, you get to know that the desmaze membrane has attached. And postoperatively, the most important thing that you have to be careful about is IOP monitoring. And if you are injecting gas and making it full, most of the times you inject air, wait for some time, and maybe you get, if you have made it full, that is how it helps, then you may burp after maybe 10 minutes. But if it's a long-standing detachment and you have to leave the gas for some time, I prefer doing a very small inferior PI so that it doesn't cause a pupillary block. So in conclusion, desmaze membrane detachment is a fairly common condition, but most of them are innocuous. These are small detachments. When many times you see it happens at the side port incision or the main incision, and when you hydrate and the pressure inside the anterior chamber increases, then in that case it settles by its own and it attaches. In the post-operative period, if there is a persistent corneal edema, one should have the highest degree of suspicion. And most importantly, anterior segment OCT helps in diagnosing as well as detecting the extent of detachment. Some of the detachments, they do require gas, and long-standing detachment do require venting incision as well. I'll just end by giving one example that I was sent a patient wherein there was viscoelastic injected. While the surgeon was injecting viscoelastic, he injected the viscoelastic over the desmaze membrane. He had not entered the anterior chamber fully. And then there was a desmaze detachment. In such a scenario, even a superior venting incision doesn't help because the viscoelastic is stuck in that area very badly. So you have to make an inferior posterior desmatotomy. So you have to make a small desmatotomy through which you can aspirate out the viscoelastic. So that is what is very important in such cases. You have to ensure on the table that it is attached. Otherwise, any speck of viscoelastic, if it is retained, then it will not allow the desmaze to attach. Thank you very much for your patient listening, and any question or suggestion, I'll be happy to answer.
Thank you so much, Dr. Rajesh
Thank you,
Sinha.
Rajesh. Would how long after post-op surgery would you recommend the general surgeon to suspect a DM detachment if he has not noticed it already on table itself, and he thinks it's part of the SK of the phacoemulsification, and it is, so how long would you wait for it to naturally dissolve before, subjecting the patient, especially if you don't have an access to an OCT, to straight away look for the detachment?
See, first of all, in any case which has a post-op corneal edema, one should very thoroughly examine the patient on slit lamp to look for Descemet's detachment. One should have that degree of suspicion that if there is a corneal edema and you know about the case that you did not use too much of phaco power and still the patient is having edema, then the first thing that one should rule out on slit lamp on day one itself is the Descemet's membrane detachment. Now, sometimes what happens that patient can be referred to you, or you have used a little bit extra power, phaco power, and you think that probably it is because of that. Then in 3-4 days time, if it's not resolving, and I would ask the patient, obviously I will see all the patient on slit lamp on day one if there's any edema. That is one. But if it's missed, then if the edema is not resolving in 3 days time, then 3 to 4 days time, then in that case, if somebody is not able to detect on slit lamp, then anterior segment OCT should be done. The patient can be referred to someone who has the anterior segment OCT, and that can be seen by ASOC.
Is there any role of, especially in recurrent detachments, to do full thickness suturing?
Yes, there is a role of full thickness suturing, which is required in extremely rare scenarios. It's very uncommonly you require a full thickness suturing. But yes, if it's not resolving, particularly if there is the fluid that has collected is thick, or there is some amount of viscoelastic. In all these scenarios, what happens that it doesn't attach? Then in such cases, one can resort to use of full thickness sutures.
If the DM is if the DM is torn, then
no. If the DM is torn, then you can just inject gas and it will attach. So that's not an issue because fluid will come out. If it's scrolled, if it's torn and scrolled, then you have to be careful. Then you have to inject it from absolutely opposite side so that it unscrolls and attaches. So if it's a small Descemet's tear also, or descetotomy there, then if you inject gas, whatever fluid has collected, whatever is there, it will come into its chamber and the Descemet attaches itself. Only problem is that if it's a long-standing detachment, then in such a case, it's a problem. Then you have to inject gas, you have to do venting incision in order to clear the fluid. So all these extra manipulation is required, and occasionally full thickness sutures, as Dr. Sudhakar was telling, all these things are required in such scenarios.
Yeah.
Sir, so Dr. Arif here.
Yeah.
Sir, in case if you find out there's a large inferior DMD, almost like half of the cornea is involved, you have seen it intraoperatively. And you don't have access to gas, then if you are using air desmotopexy, then how long would you wait for the on table for the DM to be attached, like, or any other special precautions that you want to take?
If it's a large attachment on the table you have detected and you are injecting gas. So the only problem is that obviously you have to make it absolutely full. So if by you can wait for 8 to 10 minutes and then you may burn. Another thing you can do is that through the side port, you can take the vitrector and go inferiorly and make a very small PI. Because if it's a very large detachment, you have to fill the anterior chamber with the air. So after 3-4 hours, little bit of air will get absorbed, and that inferior PI will help in preventing pupillary block. So this is something that this is extra precaution that one can take.
Okay, thank you, sir.
Rajesh, question here. See, you were talking about when the Descemet's membrane scrolls up. Can you hear me?
Yeah.
Yeah, you talked about when the Descemet membrane scrolls up, inject the gas from the opposite side.
Yes.
Sometimes that may not work. What about like a DMAC? You know, tapping it and then unscrolling it and then using the gas.
Yes. Another thing you can do, apart from tapping, what you can do is that the area where it has scrolled and it is denuded of desmaze, in that area you can make a full thickness tab. So the moment fluid gets drained from there, what will happen that the desmaze membrane will unscroll. It will move. If you stab on one side, fluid will get drained. So it will act as a demake only. It will act like that only. Fluid gets drained and suddenly the scrolled membrane, it unscrolls a little bit and then you inject gas and it attaches very well. So that is also that can be done. It's a good idea.
Sorry to interrupt, but we need to move on because we have another 5 more talks to go. We'll allot 5 minutes after each talk because the initial thing was after the talk, all the talks are over. At the end, we would have a half-an-hour discussion. But probably this makes more sense because after each topic, if we can give allot 5 minutes for discussion, that would be fine. So 3 to 4 questions can be answered. So thanks a lot, Dr. Rajesh Sinha, sir. That was a very interesting topic and of utmost importance to our cataract surgeon. Thank you so much for making it so simple. And now there's been a slight change in the schedule. The next talk is actually the presbyopia correction by Dr. Krishna Prasad Kudlu, but that has been rescheduled. And Dr. Chitra ma'am is going to talk on clear lens extraction. It's a topic of interest for refractive surgeons and cataract surgeons alike. And Chitra ma'am needs no introduction. This is the most dynamic and hardworking lady we've been seeing for the last 3 years, webinar after webinar, CME after CME. Over to you, madam.
Thank you very much. I'm so obliged to the Andhra Pradesh State Ophthalmic Society, every single member for inviting me for this program. And it's an association for many years, and I'm so happy I'm here today. I'm sorry for this request I had made because I was also in another meeting, physical meeting, which I had to be part of. So my due is to talk on clear lens exchange. Now, when we talk about clear lens exchange or refractive lens exchange, there are different ways of presbyopia lens exchange. What we realize is we are not treating a pathology here. We are not treating a cataract here, but here the need is to improve the visual performance. Now, are we justified in doing it is the very first question which should come to our mind. But with the present day optical biometers, the IOL power calculation formula, the 4th generation and beyond, the kind of understanding we have of the surgical principles of doing an appropriate surgery and the way we are all driven towards target emmetropia, maybe we can look at it in a very small subset of cases. Now, who are these cases? Now, if it is a low emmetrope and a presbyo, and he's very keen, you are not going to ask him just like you would ask a cataract surgery to be done in a patient with a moderate cataract. Here, it is the patient who is coming and asking you. So he would need to be extensively counseled about the choice of IOL, for which we have lenses, we have enhanced monofocal, we have EDOF lenses, we have trifocals, we have continuous range of vision, we have all the battery of lenses. We have to be clear that we have analyzed our results and we know we can hit target emmetropia, but we need to make him cognizant that it is an intraoperative procedure. There could be some risks without frightening him off. The other subset is a high refractive error, which cannot be corrected by laser vision correction or ICL. And I would not go for this. This would be the very last option which I would suggest for him for a very high myope, for the reasons I'll explain later. And we have to also make them cognizant there is loss of accommodation and there is risk in extremes of architecture. So taking you through case 1. In this particular case, it's a low refractive error which the patient has, but he is stuck with some loss of intermediate vision and near vision, and he is very keen on going in for the surgical procedure. Then what you realize here, if you have access to this eye trace machine, how it helps is, if the DLF or the dysfunctional lens index, which is noted in the eye trace, is less than 0.5, you know that there is some kind of a visual blur which is there. If you look at the letter E, the point spread function, in this particular patient, the DLF was about 3.26 and 2.97, you understand that there is one other factor, that is some kind of a lens changes have set in a very minuscule manner, which is causing a loss of contrast and scatter and night driving issues, which is what is making him come back to you again and again. But again, it could also be a patient like this who has the dysfunctional lenses which nearly looks normal, like below 5, you start wondering, but there is some amount of scatter in the C when you look at the point spread function, but he also actually had an early cataract and a higher astigmatism. So then we need to go after this small astigmatism too. And this patient was taken up on the laser cataract platform, and an astigmatic keratotomy was also done because we have to justify it in every possible way to give him clear vision for all ranges of distance. Now, on a femtocataract platform, you can go for a honeycomb pattern or a grid pattern. Just a gentle hydro is all that is needed because some pneumodissection is done. If you look carefully, I am not using any ultrasound. I'm just prising the part apart, and there is no stress on the zonules. They're just as if these pies are ready to be eaten up. And you can see that the grid pattern has also brought in that amount of softening. So it is just like not even some alva or a sweet like that, which is getting cut. And then you are just injecting the lens inside. So it's a least traumatic procedure. There is no problem at all for the eye. The phaco-parameters are kept so optimally, and there is no AC shallowing, and in no time, and it's a practically unedited video, and the surgery is done. Now you could also do, and this is how the patient ends up with the most optimal vision for distance, intermediate, and near. You could, instead of going in for that grid pattern, you could have sextants, like you have done, like a 6 chops, which you have done. And if you have a Varion overlay, that makes it even more brilliant. And then you have to, all you have to do is just lift up this free floating rexis, and you can do a hydro delamination, that is, go in the area of where there is these grooves, inject just a little fluid. And then once you have done this, you find that that itself has caused, you can even inject viscoelastic instead of fluid if you want. And then after debulking the superficial cortex and epinucleus, therein again, you can see that in absolutely no time, you started eating up the nuclear fragments. And this kind of very sure surgical procedures which are possible on a femtocataract platform makes it something, the very ideal tool when you're looking at a clear lens extraction. But that doesn't mean that we do not have a femtocataract platform, that we avoid them. But then there is this particular way of doing it. After making a nice round rexis, a little smaller rexis, not too large, just a gentle hydro, and these are near very soft cataracts. You can go on to the flip mode if you have, or the Centurion, and you can just eat up that endonucleus. And then it is all about just stripping the cortex and placing the lens appropriately, ensuring that the lens is well centered, that the first and the last Purkinje reflex are on line, and all those minuscule attention to detail which is needed when you're doing a premium cataract surgery. Now, if the next scenario could be a high myope, high hyperope, he has opted for a clear lens exchange. Now, there are certain challenges in a small eye. When it is a small eye, one thing you know is that the dynamics of the human eye is such that in small eyes, some eyes could be normal anterior chamber depth, and some eyes could have a shallow anterior chamber depth. So there is one underlying difficulty in predicting the effective lens position. In a small eye, because the hyperopic eye, you may be using high part IOL, say, to 40 or similar. So then, even if there is a small change in effective lens position, it could lead to a large refractive surprise. So you have to be very much involved with your optometrist to see that the absolute right formula was selected. Of course, today we have the choice of customized lenses and piggyback lenses to compensate in case there has been an error because of the architecture of these small eyes. Now, in this particular case, the difference between the different formulas was 5 diopters and 10 diopters in the other eye. And the patient was advised surgery, was completely distressed with his very thick glasses, and a very careful cataract surgery was done. I'm not going into it. he actually had a 40 diopter implanted in both eyes. In the right eye, it was 6.6. Left eye, it was a surprise of 6 diopters. And when we are using, doing a hyperopic correction, you have to multiply it at 1.5. For a myope, it's 1.2. And then it shows that you need to place a +9 diopter. Piggyback IOL is what would be a solution for him. And a sulcoflex lens was done. Now, the advantage of these lenses is, one, it's a different material from the primary lens. The primary lens here was a hydrophobic lens. You need these lenses, sulcoflex piggyback lens, come with a larger optic. They have undulating haptic, which rests well in the sulcus. And you have to position the haptic in such a manner that it is at right angles to where the original lens is placed in the bag. And the next question you would ask, it is a small eye, how can you place 2 lenses? But let's understand, you have removed the cataractous lenses, which itself occupies a large volume in the eye. And by removal of that, placing these ultra-thin lenses is not the challenge. The post-operatively, you could see there was an adequate void of these lenses, and which was fine. And that kind of posterior concavity is needed between the 2 lenses, and that would ensure that there's no interlenticular opacification, which was noticed earlier on. The case 3 is those very risky areas which you would rarely walk. A high myope, wherein he didn't have adequate anterior chamber depth for the phakic IOL implant. You can never do a laser vision correction for such high myopes. So he was extremely interested in a prelex. Now, incidentally, this patient, of course, you need to do a thorough retinal examination, but incidentally, he was lucky that he had a posterior vitreous detachment in both eyes, which was an advantage for doing a cataract surgery. You needed to do a B-scan. You need to rule out any posterior staphylomas which are there, or understand that what could be the challenges in biometry in these eyes. Use the latest generation formula, because these latest formulas are of great help for these extremes of eyes. Short eyes are large eyes, and you cannot compromise in these clear lens exchange cases. Now, what are the challenges surgically? These are deep eyes, long anterior chamber depth, could be a larger cornea. So when you're making your rexes, you might err to make it a little larger, which you should not, because you might end up with a optic capture. You need to keep your IOP ramp high so that there is no sudden fluctuation when the phacoprobe enters the eye. You could go in with your infusion off. You should be prepared that there could be a reverse pupillary block rarely in these eyes, where the iris can go and get stuck on the lens surface and a temporary discomfort could happen, wherein all you need to do is go in with the side port and with the spatula, just lift up the iris so that the pupillary block, reverse pupillary block is reverted. And then you need to use slow motion surgery, and you could do a hydrodelamination, which should separate the lens into multiple layers and make it a very easy surgery, and do a thorough cleanup, complete viscoelastic removal. Some of these very large eyes where a toric IOL is implanted, you might consider CTR as being an extremely cautious surgery. Of course, you would have to do a thorough retinal evaluation prior and in the follow-up visits. Sometimes your post-laser vision correction patients are those patients who are absolutely from the beginning log on, not wanting spectacles at all. They may be the subset of patients, but being a high myopes, I would not accept to do a clear lens exchange as a routine process. We need to be very, very clear. Those small presbyopes or those early hyperopes are the ideal cases to consider when you want to transgress into this very dangerous frontier. So what are the pearls to consider? We need to look at the ocular surface, the tear film. We need to examine the eye completely. We need to ensure that the capsular bag is intact. There's no zonular weakness. The retina is okay. The OCT is fine. In the ocular surface, if there is any meibomian gland suspicion of any issue, we need to do a meibography. We definitely need to do a tear film analysis. A tear breakup time is absolutely necessary. A Shermer's may be quite inadequate. A fluorescein staining is absolutely important. You need to explain the pathology to these patients. OCT macula would rule out all those n number of issues. And most importantly, we do have the access to optical biometers, but we need to very carefully look at the raw data, validate every measurement. Do not you have to be with your optometrist. Do not remove yourself from the whole process and treat the astigmatism. And you have the entire battery of lenses, and because it precludes my discussion of these lenses in this particular session on clear lens exchange, but you need to choose appropriately based on the patient requirement. In other words, it has to be very individualized selection. So the keys to success in a clear lens exchange is a very right kind of patient with realistic expectations and adequately motivated, the right choice of surgery. And on our behalf, it has to be an absolutely perfect surgery. And if all of it is there, then refractive lens exchange is one of the rare choices which you could offer to your patients who are seeking a refractive cataract surgery. Thank you.
Thank you, Chitra ma'am. It was such a nice, wonderful talk. It's always a dilemma to go in for it. A motivated patient and an inadequate cornea, you're not very comfortable doing that. You have made it, given a total overview of it when we could consider that. So anyone has any questions to ask Chitra ma'am? I think because we won't have her again for the last bit of the discussion. So we can ask her any questions if...
Hello, ma'am. This is Dr.
Hello.
Yes, doctor.
Dr. Chitra,
yes.
Coming because now you're getting very good implants and very good predictive accuracy of the formula. Are you have you begun, or are you sometimes pushed by the patients themselves as the person who has never worn glasses and he comes to presbyopia and he's a plano presbyope? Would you consider a clear lens with an advanced IOL?
See, our practice does have refractive surgical practice. So yes. We would never on any conversation set it off. Like if the patient has come to you, and you would not discuss about clear lens exchange at all to this patient, but these patients would have inquired about it, gone to the counselor and talked about it, come back to you. That's when that dysfunctional lens index is sort of some kind of an explanation when that point spread function is blurred and the dysfunctional lens index is less, and the patient is literally sitting on your head and wants a clear lens exchange, and I have a femto cataract platform. So in that particular case, after explaining to him, I would even tell him that he might really have a PCO if he's because of his age. With all of it, yes, I would do it. I would feel more confident doing a plano presbyope. Also will not ask. They are these hyperopes that +3 diopter or 3.5 and all, they're just not happy with those thick lenses. I would definitely look at doing it for them, but then I need to understand it's a small eye. I would definitely like to give oral glycerol pre-operatively to see that this is a soft eye when I'm doing the cataract surgery. There's no posterior vitreous pressure, which is taken, that is also addressed. So there are those small precautions I would take, and I would lot more confidence.
The femto platform a prerequisite? I think even
No, I showed you that flip procedure. No, it's not a prerequisite, but it definitely brings in, I'm able to do an astigmatic keratotomy even for a 0.5, 0.6 diopter of astigmatism. I wouldn't want to put a toric IOL for such low astigmatism. So there is greater perfection. We can't take away the fact that there is a perfection which is achieved there with great mental relief for the surgeon.
Yeah, definitely.
Yes, Sudhakar,
hello,
Dr. Kudu here. Sudhakar,
yes, sir. Yes.
Actually, in my case scenario, if the patient is plano presbyopic, if the DLI is normal, normally I love to do presbyon than the clear lens extraction and go ahead with the multifocal or EDOF lenses, because I've been doing this procedure for the last 13 years and my results are very good. So I adapt to presbyon, but you need to have that same platform with you.
Yeah, exactly. So very few people will have a presbyon, nor will they have such a long experience. So what they do generally is what most ophthalmologists do is obviously cataract surgery is their bread and butter. They're so comfortable. Now I'm saying just with the advanced lenses of getting 6x6, n/6 in a consistent manner with advanced formulae and advanced A-scan machines. So I'm saying for a general practitioner who does not have access to this, would you, or are they jumping in too early to advise or to treat low or early presbyopes?
No, we would not do it as a normal sequence of event. Let us not, because we should not be doing more harm to the patient. But there are very select subsets who you know will do well, and you know about your surgical prowess. Those patients who are insistent, it opens up one more possibility. That's all.
And since Rexis is the most critical step for,
Yes.
so I think if you have a femto platform, that will give you much more confidence to tell the patient, yes, things would go right, because otherwise it's a little unpredictable, I think.
Ma'am, this is Dr. Arif. Madam, in your second case, you showed that where there is a hyperope, where we did a clear lens extraction. You said there was a difference of +5 diopters in between the formulas in one eye and the +10 diopter. And which formula did you choose?
No, I chose the Barrett Universal, which I chose the Barrett. Actually, Barrett and Hill RBF, although they are some different technologies, one is artificial intelligence and one is a thick lens formula. But somehow you go for these very advanced formula, they have a lot of variables incorporated in their IOL power calculation, which brings in a lot of precision. Rather, it is said that only 20% of the eyes, the high with have large axial length or short axial length or post-refractive surgery eyes, these eyes definitely need these latest formulas. We have to keep that in mind.
Thank you.
Yes.
Can I ask one question? Yeah. Hi, Chitra. I mean, a lovely presentation. One query is, I think when we are discussing the option of trifocals in clear lens extraction in the presbyopic age group, but I think you would also be encountering, just like us who are refractive surgeons as well, there are a lot of patients who are probably coming in their mid-30s here. They are high myopes and would want a clear lens extraction here. And what's the option of opting to, trifocals in this high myopes, looking at that they might develop a myopic maculopathy or posterior segment problems in the days to come? So what is your take on that, and how do you react to such a situation?
No, high myopes in the age group of 30, I will not advise a refractive lens exchange at all. Although every single patient of ours who have done the clear lens exchange are good, we would not advise them at all. I would leave them with contact lenses and tell them to let's wait it out. Let's see that you have some early cataract.
I think this is something which is being increasingly discussed now, with the options which we are having now are much more than what we are having earlier. But of course, safety-wise,
myope should be an extremely last situation.
Absolutely.
The high myope, which I showed you, had a posterior vitreous detachment, which was a saving grace for him. Otherwise, I would not advise high myope, because the chance of retinal detachment is 8-fold more in these eyes.
Absolutely.
Vanati, just to answer your question, a very high myope, 30 years, if there is no cataract, my first option is going to be the implantable.
No. Implantable contact lenses, we are talking clear lens exchange with the AC.
Obviously, you do an ICL. When ICL is not an option for such patients, that's when I'm talking about.
Suppose if you are having already cataract, clear lens extraction 30 years, I would go ahead with a trifocal.
That's right. Yeah. That's what I said. When there's no lens changes at all, then you're looking at
trifocal. Again, it has diffractive rings. If he is going to do a lot of driving, I would tell him continuous range of vision. I would, because trifocals has a little bit of glare. So I would have explained that, and then I would select trifocal or a continuous range of vision in those patients.
Yeah. Thank you, all of you.
Thank you. Thank you. Thank you so much, Chitra ma'am.
Thanks a lot, Dr. Madhavi, and all of you on the State Ophthalmic Society for allowing me to break the queue and talk. Thank you so much, and thanks for the invite. Thank you.
Most welcome. It was a pleasure and honor for us to have you here. So we will move on with our next topic, the Holy Grail. All of us are looking for it as refractive surgeons, the presbyopia correction. For that, we have none other than Dr. Krishna Prasad Kudlu, who is the chairman of Prasad Netralaya in Udupi. He's a very dynamic and active person. He's also a member scientific committee, AIOS, and he's the president-elect for the KOS, Karnataka Ophthalmic Society. Indeed, happy to have you here, Dr. Krishna Prasad Kudlu. Over to you.
Thank you, Madhavi. Can you hear me?
Yes, we can.
In fact, I want to share Madhavi's younger brother and me are classmates. So it was, Madhavi is also originally from Mangalore only. Once again, I thank Dr. Gopal Raju sir, my dear friend Sudhakar, and the whole team of Andhra Pradesh Ophthalmic Society for this wonderful opportunity. Presbyopia, it is my keen interest. I've been doing presbyopic surgery in the last probably 13 to 14 years. So if you ask me, I think in the coming days, the presbyopia is going to be the real market for ophthalmologists. So I don't have, like for this particular presentation, I'm a consultant for Carl Zeiss India. This is my financial disclosure. So what exactly is a presbyopia, which is a physiological progressive loss of accommodation affecting individual in their middle age, regardless of underlying refractive error, causing difficulty in sharply focusing for near vision. So what we used to do before, we used to correct the dominant eye for distance and non-dominant eye for near. So there are always used to be a blur zone and patient used to come back with a lot of glare and halos. Nowadays, most of the machines were, what we do is we make the dominant eye emmetropic, make the non-dominant eye myopic, and along with we create a spherical aberration in both the corners that gets something called a blend zone, which makes the patient very, very happy. So why we adapted this micromonovision, as you've seen, even in the child with the amblyopia, brain tend to suppress certain blur from one eye to the other eye. It is very easy to adapt. So coming to the how presbyopic patient is affect my practice. See, I have got a lot of presbyopes. They come and ask me, especially emmetric presbyopes, sir, I don't want to wear the glasses. Even parents and relatives of LASIK patient been coming to me, they also want to get rid of their glasses. And even I have done some good number of patients, they're already undergone cataract surgery, pseudophakic patient, they also doesn't want to wear the glasses. So that's why, once again, I'm insisting here, presbyopia practice is like going to be the future in the coming days. So in coming to the preoperative evaluation, who are the patient can undergo this presbyon? Any person in presbyopic age, even last week I have done up to the myopia of 8 diopter depending upon the Pachy value. Hypermetropia I have done up to 5 diopters depending upon all their keratometry reading and Pachy value. I have done 200 plus patient with the emmetrope presbyopic, even with the astigmatism around 3 diopters. But make sure that patient don't have the cataract. Now coming to the technique, I think I'll come back to the refraction and the dominant eye testing, micromonovision. These are the very important steps. Then followed by routine LASIK evaluation, which the planning will be done by the CRS master software, which is given by the Zeiss, which can incorporate it into either of MEL-80 or MEL-90 examiner system. So coming to the history, I think it's very, very important. My chair time for the patient, those who are undergoing presbyopic laser refractive surgery or lens-based platform is 45 minutes. I spend time with the patient, ask their ocular history, ask their family history, whether they are on medication, whether they are having a dry eye symptom, whether they are having photophobia, all these complaints I myself ask and I counsel the patient for 45 minutes. Once again, I am insisting here, my chair time is 45 minutes. Once patient is convinced, then I go with the regular testing, start with the torchlight examination, look for the pupillary reaction, look for the whether patient, look for the squint, whether, and also I myself check for both monocular and binocular distant visual acuity without correction. And always if you're having a pupillometry, I always measure the pupil size also. If when I'm seeing the disc, if I'm having any doubt, I get their visual fields done. Then I go out with the other investigations. Then, so coming to the refraction, very important. Lot of optometrists, many optometrists working with me, but this particular test, I myself do it. And I take my time, make sure that I do a proper refraction. Once my proper refraction has been done, then make sure that it is duochrome balanced. Once it is duochrome balanced, then my next step to find out which is the patient's dominant eye. Make a small aperture in both the hand, make a small hole, tell him to read. I normally keep it around 624 distance, then tell him to see for distance, then tell him to get that hand near to his eye. Normally he get into his dominant eye, then try to close each eye and see. When he's seeing through the dominant eye, he could able to see. When he's not seeing through the non-dominant eye, normally he'll not see. Once you are okay, you know that which is the dominant eye. For example, this patient, right eye is the dominant eye. Left eye, I put a plus 1.5. This is called micromonovision testing. When I'm doing this, tell the patient to read for near vision. for N5. With the same correction on in his left eye, I tell him to read for distance. If the patient doesn't complain of any cross blur, these are the patients do extremely well after the treatment. There are 10 to 20% of the patient, they say that, doctor, I'm having glare in front of my eye. In such situation, I repeat for 2 times. Still patients say that I'm having glare and I'm having a double vision when the both eyes open when he's seeing for distance. I never consider him for this particular treatment. Then other dry eye workup is very, very important. They are 40 plus patient. Most of them sometimes might be having dry eye. You have to treat that dry eye, then go ahead with the treatment. And detailed fundus examination, a very important patient is having, if it is having lattice with holes, treat them, then call the patient after 3 weeks. These are the few very important, I think, pre-op investigation for any of the laser refractive surgery. Then about the refraction, I told. But all my patients, I do a cycloplegic refraction. Then these are the different, those who really want to check the dominant eye. Why I am once again showing the different methods of know the dominant eye, because I adopt the same technique when I nowadays offer for them lens platform. So normally when I'm going with the EDOF lenses, I put for dominant eye with the emmetropic correction, non-dominant eye, make myopic by 1 diopter. Similar concept will work even on the lens platform. That is why even in my cataract patient, I always look at their, which is their dominant eye. Once that is over, because most of the patient will have a clear preference. Normally dominant eye, we do it for distant, non-dominant eye, we treat it for near. Some patient might tolerate near in dominant eye, but in some patient, I have come, few of the patient, there is no clear dominance. Some patient will have an alternate dominance. What I do, once I check the dominant eye in one consultation room, then I send it to my colleague to recheck their dominant eye. If the both the places is fine, okay. Sometimes in one room, he'll have one eye and the other room I'll have a other eye dominant. That means this patient has got an alternate dominance. You have to be very careful, especially in such cases, really think about going ahead with the treatment. So documentation is also very, very important. So we treat dominant eye for distance and we treat non-dominant eye for the near vision. So then all other investigation, pentacam and epithelial pachymetry important. Then dilated vascular aberrometry also, sometimes I do it. Once everything over, now coming to the software, that is with the CRS master. So what we do normally, before the software, I just do this test, that is the eye trace. I don't have any financial interest in this particular topic, but why I do eye trace, especially what Chitra madam was talking about, the dysfunctional lens index. If DLI is very less, even patient accept micromonovision and every test is plus also. If DLI is very less, still I will rethink whether I will do this presbyopic laser refractive surgery. This is very, very important. So I do a good aberrometry, then I do the VASCA to know the ZX value. Once everything done, I think the whole nowadays even the software has been improved. You can even ability to include the functional age in this presbyon. Once this is about the software, normally we enter in a software like this. Normally standard setting, there is like we have to add only 1.5 in the non-dominant eye. But in patients with the 39, between 40 to 42, 43, I normally reduce to 1.25. Patient more than 50 years, I normally increase to 1.75. You cannot increase to 2 because the concept is very simple. 1.5 in the non-dominant eye plus some amount of spherical aberration, which gives an eye effect of almost a reading effect of 2.5 for near vision. That is more than sufficient for throughout there. Like this is the overall concept behind this treatment. Once this is over, then optic zone, normally we keep it for 6. Then all the data from the CRS master will be transferred into the excimer system. So once this is done, this is about the procedure. This is a case of a femtopresbyon. Normally, femto, I do it with the Visumax, fantastic machine. So take the this is a flap setting. Once the flap done, then the patient moved under the excimer table. The procedure is similar to the how you do the LASIK procedure. Lift the flap, keep the bed dry, then you can go with the treatment. Normally, treatment will be preset with the machine when you feed the patient's data into the machine. Once the treatment done, I think then once again flap will put back, then it has earned it properly. That's all. So coming to the recovery phase, it has got two phases. That is, one is the physical adaptation phase and the neural adaptation phase. This part I am not going to touch. Basically, what happens in this presbyon? This is called laser blended vision. Brain learns to see from near by combining the information from both the eye. So some patient adapt within 1 hour, but some patient even take up to 4 weeks. But my experience, short-sighted presbyopic or myopic presbyopic or hypermetropic presbyopic, they are the one quickly adapt to this treatment. Only in my case series, plano presbyopes take little bit longer time. Then this is what we said, I told, make the dominant eye immetropic, make the non-dominant eye myopic by 1.5 adapter with the inducing spherical aberration in both the cornea. Then the neural subraction happens. Always I tell the patient, never ever close each eye and see. Always binocular vision will be always sharper than the monocular vision. So basically it's a bilateral approach. So whether if the patient is also like immetropic presbyopic, we have to treat both the eyes. This is very, very important. After being doing like my strength of my practice is presbyopia, I give a different even options like lens-based option. Nowadays I do with the EDOF lenses without ring like Rayner EMV lenses. I do similar kind of concept like for dominant eye make it immetropic, non-dominant eye myopic by 0.75 or 1 diopter less, then still patient will have a similar kind of effect like this presbyon. But if you compare all other treatment available in the market in the age of 40, 42 or till 52 to 55, if the patient don't have cataract, presbyon probably the best and the safest presbyopic treatment available till date. Once again, I thank whole APOS Society for this opportunity. I've been supposed to come even to Vijayawada. Madhavika called. She said that after AOS, we'll call you. This is my small request. I have been with the society always. I'm standing for editor proceeding in the coming 2023 election in AOS. I need your blessings. Thank you, one and all, for the wonderful opportunity. Thank you.
Thank you so much, Dr. Krishna Prasad. As usual, you make presbyopia and its treatment very simple for us. Just hope that we also get the same machines so that we also can offer the same treatment to our patients.
Yeah, actually, I've been discussing with the different machine platform, like what Dr. Rohit used to do with the Swind. That is, the results are pretty okay. But I discussed even with Sri Ganesh. He had the Swind platform, but after 4 or 5 years, sometimes you may have to repeat the procedure. See, in my case, 1,000+ cases, only 2 to 3 patients actually had come, their hypermetropic come with the power, but most of them I never did a repeat treatment. Of course, there are some 3 patients developed cataract after 12 years, diabetic. So what I did for the dominant eye, I make immetropic, and non-dominant eye, I normally put a lens which is like make a 1.5 diopters for the near vision, that I increase the power. But I normally put a non-aspheric monofocal lens in both the eyes, because already we had created a spherical aberration in both the cornea. That will be still remaining. So what I put is non-aspherical monofocal lens. Dominant eye, same power. Non-dominant eye, myopic by 1.5 diopter. Still this presbyon works very well after even when you do the cataract surgery.
That was my next question. What would you do when the patient develops a cataract? So you've already illustrated that also. Yes, I think Dr. Vanati.
Yes, Dr. Kudlu, yes. I'm a surgeon who's still looking at and is very skeptical in starting presbyon in our age groups. What would you be your words of wisdom to convince me to go ahead bravely and do it?
See, basically, once again, I'm insisting that same dialogue in any laser refractive surgery for presbyopia, my chair time is 45 minutes. Normally, how once a patient comes to us, we spend around 7 to 8 minutes. I sit with the patient what exactly they want. All my pre-op investigation has to be dead on. Once that is done, then I don't think so any complication will happen, because machine treats perfectly well. Especially in my case series, initially, all myopes did superb results. They come like, still they are coming to me like last 10, 12 years, doctor, I'm so happy I'm not wearing the glass. So I think only thing is your pre-op investigation and workup and dominant eye testing, micromonovision testing done by the surgeon. I don't think that there will be any problem for the treatment.
Thank you, Kudlu.
Yeah, I think that's going to be our next topic. There's been a slight, because the next topic is going to be, thank you, Dr. Krishna Prasad, so much. We'll move on to our next topic. So we all know that it's a beautiful procedure, refractive surgery. But if you don't do a proper case selection, then the entire procedure goes into a disrepute for no fault of its. So proper preoperative investigation and workup is of utmost importance. We all know that. So to elucidate on this and give her valuable experience inputs, we have Professor Dr. Vanati from All India Institute of Medical Sciences. Welcome, madam. Over to you.
Yeah. Thank you, Dr. Madhavi. And thank you, Dr. Gopal Raju and team APOS for the opportunity to be in this fantastic meeting here. I have no financial interest in the mention of any of the products during the course of my talk. So I'm going to now, in the next 10 minutes, talk to you on the salient features one has to look at when you're screening your refractive surgery patients here. So I'm not going to make it very textbookish or very elaborate, but just hit dot on the points which you need to know. So point one, you need to know what are all the refractive lens procedures which can be offered to your patients. So some are cornea based, some are lens based, and some are, and then you probably have to adopt to a combination of bioptics in your patients here. When you look at the refractive corrections that is amenable or that can be done from medical legal point of view or the aspects, you will need to know what are the FDA approved medical legal limits for refractive correction. For surface ablations, -10 to +4, same for LASIK, for SMILE, and now the FDA has increased the amount of cylinder corrections in these patients for SMILE. For phakic IOLs, what are the options of what is the range available for hyperopic and myopic and refractive lens exchanges. So that's knowing about what's the quantum of refractive error, which is medical legally acceptable in the event you have any concerns later on. So that's important to know. Two is choosing the right option for your patient. So which is going to be correct for your patient here. And for this, you will need to look at the realistic expectations of the patients. That's when Kudlu mentioned you need to have a longer chair time. If you're looking at patients who are, type A personalities, particularly here, look at a very accurate manifest refraction in these patients, keratometry, corneal topography, pachymetry, anterior chamber depth, white to white. This in a nutshell is all which you probably will have to have on your first go to look at if your patient is going to be suitable for the refractive procedure you're offering him or her. In a step ladder wise approach here, first choosing the right patient, the refractive correction which is correct for that particular patient, scrutinize the topography thoroughly, then go on to your pre-surgical calculations of residual stromal bed thickness and the percentage tissue altered, the corneal biomechanics of the patient, and again, reevaluate if this is the best option you're giving to your patient here. Who's going to be an ideal candidate? Look at the age. So according to FDA approvals for LASIK, it needs about 18. SMILE, we still do about 18, but 21 is going to be your optimal age for SMILE. ICL is 21 to 45 and PRK, again, 18 years of age. Look at a stable refractive error. You would not want a change of more than 0.51 diopters in the last 1 year. 1 year is usually a little difficult, so we at least look at 2 consecutive refractions done 3 to 4 months apart, which needs to be stable, and a patient cannot wait when he's coming and wants an immediate surgery. I usually compare it with our current refraction, what we have and what the patient is wearing, and would not want a difference of more than 0.5 diopter sphere or cylinder. And then I would discuss it at length with the patient. Again, women who are not in the family way and are not breastfeeding, to avoid the hormonal influences on the wound healing. Those with autoimmune diseases, again, because these can have implications in the wound healing as well. Adequate counseling, realistic expectations, and be careful to rule out any other associated ocular comorbidities. So a thorough ocular examination is imperative in all these patients. Absolute contraindications, corneal for beginners, corneal ectatic disorders, because there's a lot of talk on adapting to refractive ablations, even in ectatic corneas now. So I'm applying this to more of the beginners or more of routine refractive surgeons, ectatic corneal disorders, unstable refractive errors, uncontrolled ocular surface allergies, meibomian gland dysfunctions, dry eye, blepharitis. Please optimize the surfaces before you would offer a refractive surgical correction for these patients here. Other ocular comorbidities like glaucoma, uveitis, cataract patients, uncontrolled autoimmune disorders are going to be a definite contraindication. There are various other relative contraindications which more advanced refractive surgeons would resort to, but again, a word of caution is required in all these eyes here. When you're looking at a corneal topographic map, what are all the indices which you need to pay particular attention to? So first look at the sagittal map here. So a K max of more than 48.2 is what I do keep. A difference in keratometry when it's more than 1, it rings a bell for me here. 1.5. So 2 is what the recommended. It's going to say it's going to be. You probably need to red flag and reevaluate your parameters here. When you look at the difference between the steepest K, that is the K2 and the K max in most normal eyes, is going to be less than 1 diopter. So that's going to be another very subtle index which you can pick up on patients which are on doubt. Skewing of the radial axis of more than 21 degrees and inferior superior asymmetry in keratometry of more than 1.4 diopters here. Again, there are several things on your elevation maps, anterior and posterior elevation maps. But do go back and check what is the best fit sphere you're looking at, because the amount of elevation is varies very subtly between the difference in the best fit spheres here. So common best fit sphere, which are kept around 8 millimeters, you would look at 12 on the anterior elevation and 17 on the posterior elevation, which are going to be your limits beyond which you're going to red flag the topography as well. Pachymetry here, for a normal topography, I look at a pachymetry of greater than 480 to be normal. For an abnormal pachymetry of topography, then I would want my pachymetry to be a minimal of 500 microns here. Again, look at the inferior superior difference in the thickness and look at the dislocation of your thinnest point from your apical cornea. So these are all subtle indices, and if you can look at these and scrutinize these on your topography map, you would probably be more confident when you're dealing with those borderline cases as well. Yeah. The two calculations which I do find very imperative in my practice is looking at the residual stromal bed thickness and the percentage tissue alter. So what's the residual bed thickness? How do you calculate it? You deduct the flap thickness and the ablation area from the central corneal thickness, and the percentage of tissue which you're altering by your maneuvers, that will include the flap thickness and the ablation depth divided by the central corneal thickness. And it's always safe when you would go less than 40%. If your PTA is exceeding 40%, then that cornea is not probably going to, or is going to be at a higher risk for development of post-LASIK or post-refractive surgery ectasias. Another particular parameter which I also place in mind is looking at what is going to be the keratometric alteration on the cornea after you do a refractive surgery here. So whether in myopic cases, how do you calculate it? Preoperative keratometry minus 80% of the refractive error correction you are planning. And hyperopic is preoperative keratometry with an addition of 100% of the refractive error correction contemplated here. So if your postoperative keratometry is going to be flatter than 34 or greater than 48, then those are going to be very unhappy patients, even if you give them a dot on 6.6 here. Again, the Randleman's ectasia risk exposed system is there widely out for all of you to go up and refer. And it's a nice one to have it on your desk when you're evaluating these patients and look at the risk categories depending on the points obtained based on the parameters of topography, RSBT, the age, the central corneal thickness, and the refractive error of the patient, which needs to be corrected here. A quick run through the maps here to look at what is going to be abnormal in what you need to particularly look at in these patients here. So of course, you're looking at the right map, the right eye, the age at which the imaging has been done here, and the first one, and the quality of capture. And when you look at the anterior cornea, looking at the K1, the K2 here, the Q value and the the quality strength of the particular patient here. This is your anterior, your axial or the sagittal curvature maps here, and you would look at the particular pattern of the topography which you can pick up in these patients here. So this I've already touched on, looking at what is going to be the change in your keratometric and the pachymetric, the keratometry, the RSBT of these patients here. I wouldn't delve into depth about the best fit sphere here because of lack of time. Looking at the anterior and posterior corneal elevations, again, we've deliberated on these is that you would look at the best fit sphere and look at the value which is recommended on your anterior and posterior corneal curvatures, which is going to be, if it's going to be beyond those of 12 and 17, then it's going to be a red flagged topography here. Again, look at the pattern or the islands which you have. You can commonly have central islands, or you can have displaced islands, you can have tongue-shaped patterns, and you can have increased anterior and posterior corneal elevations, which all will red flag your topography as well here. You're looking at pachymetry, look at the thinnest pachymetry, look at the dislocation of your thinnest pachymetry from the corneal apex here in your patients, and that's going to be a fantastic way of how you can scrutinize your topography maps here. There are more patterns on looking at your topography color indices, but I think we'll move on to a particular the bad display here. Before the bad, look at anterior chamber angle needs to be more than 30. Your AC depth needs to be 3 is comfortable with at least about 2.8 if you're planning phakic refractive procedures, and the pupillary diameter is a very, very important aspect which you will have to consider in your preoperative evaluations. In looking at your Bellin-Ambrosio, your bad maps, look at the dip which you're seeing in the central 2 to 6, 2 to 7. That's going to be quite important to pick up these subtle cases here. There are other indices, plenty of them, which are gaining research importance here. But what I would particularly look at is the Ambrosio relational thickness max, where we want it to be above around the higher, the better, the 390 or so. So when it's going to be lesser, then those are suspect cases, and definitely lower ones are clear-cut keratoconus, which you can obviously pick up on clinical examination in these patients here. Moving on from topography, what is more important when you're looking at phakic IOLs is the endo-ACT of greater than 2.8, a white to white of greater than 10.8 and lesser than 13. Remember to do specular counts for your patients, and most important is roll out lenticular opacities in these patients. Another important factor which I do emphasize to my residents and high myopes, please look for subtle changes of phacodonosis, iridodonosis, which means you're looking for zonulopathies, and these are patients which you probably are, or you would want to or not want, or would not want to do a phakic IOL for your patients. Again, I think you need to study your normograms and you need to look at your results here. And most of the time, the normograms work perfectly well when you're sizing your IOL. But in those small percentage of cases where unduly long eyes, where your sulcus diameter calibrations probably do not coincide. So those are ones which you need to pay particular attention to here. So PRK surface evaluations, flap procedures, non-flap procedures, there are a variety which you can offer. But if a patient is coming to you for professional needs, so you need to assess the professional needs, and you'll also need to go into depth of what is approved, what procedures particularly approved for the profession for which the patient is coming to you. So that's another important aspect here when you are offering refractive surgery correction, not for cosmetic purposes, but for professional purposes of these patients here. I'll just run you quickly through the next 2 minutes on a few case scenarios here. A 21-year-old female for cosmetic indication, a refractive correction of a -3.5 sphere and a -2.5 cylinder in the right, and a -3 and a -1.5 in the left here. Thinnest pachy was 508 and 520. The RSBT seems fabulous here. The residual keratometry is also safe. The PTA is also within the safe pattern in this particular patient here. So all looks well for this patient. And then here is when we look at the topography maps here, you find a Kmax of greater than 48 in this patient in the right eye. You're seeing a mild skewing here, inferior superior asymmetry in this particular patient. There is a displaced and a raised posterior corneal elevation in this particular patient here. Abnormal posterior elevation and enhanced elevation map in this patient. Your bad curves are all again bad here. So sometimes you might get such patients, especially because of contact lens warpage, or or some fallacies with your imaging, which is usually rare, or if it is a dry eye problem in these patients, I do particularly wait for these patients with with ocular surface optimization and then take them on after a 4 to 6 months evaluation. And if you're still skeptical, phakic IOLs are now a relatively safer option in these patients. Yeah, high myopes as -26, -25, go beyond the available values of your phakic IOL powers, depending on the different companies which you're choosing in, then you might probably want a bioptics in these patients here. When you're looking at patients who are in the presbyopic or beyond the presbyopic age group, we are high myopes, then I think we have had enough discussions on these. You would probably want to do a refractive lens exchange for these patients here. Those are there are those subtle patients which you are skeptical, which you are doubtful, where you want to rule out a subclinical keratoconus here. That's when your Corvus comes into play in looking at the corneal biomechanics, the CBI and the TBI values will red flag these patients. Again, a word of caution, most of these artificial intelligence offering data is based on Caucasian data. So when you're extrapolating them to Indian scenarios, please always look at an entire comprehensive picture, which I do rather than just looking at the TBI and CBI indices, and do discuss these options with the patients before I offer or choose not to offer refractive surgery for my patients here. I think I will stop here. Thank you all for your patient hearing. Thank you for the opportunity to be part of this wonderful webinar. And I hope I would seek your support and you would find me a suitable candidate for IGO editor. Thank you so much.
That is a very nice, comprehensive talk, Dr. Vanati.
Thank you, Dr. Thank you.
Yeah. I noticed that you did not touch upon aberrations at all, I know, as a form of kind of screening to, when would you offer a,
Yes. I think thank you for pointing out that lacune for me, because I was tailoring it to real basics. I think if you take it to advanced, it goes a full 10 minutes is something where even basics is not adequately covered.
Yeah.
So a simple word is for those who are doing and who want to look at, when you have a higher order aberrations higher than 0.4 here, I would normally want it to be in the routine range. But when you're having your higher order regions much higher in these patients here, so you can choose any form of an aberrometer which you want to look at, your wavefront analyzer, your eye trace, or whatever comes in your refractive suite here. But when you have a quantum of higher order aberrations, again, when you do pick up most of these cases with steep corneas, with thin corneas, you will definitely find that their higher order aberrations are on a suspicious platform for these patients here. So that's again is something which you would look at, and looking at your pupillary diameters here. So again, when you find your pupillary diameters are higher in your, so that's when you look at your scotopic, mesopic for these patients here. And these are again patients who are going to be unhappy patients in your postoperative period. So you need to counsel these options with them before you offer the surgery, and lay the choice on the table so that they are aware of what they are looking at. And specifically, if you're looking at type A personality patients, then that's when you would probably be a little more cautious.
Okay. Yeah. One more doubt. In the case scenario that you presented with a slight posterior float anomaly, but having good thickness and just about 48 and a low refractive error, would you consider doing something like a PRK extra or a LASIK extra for that?
Absolutely. I think looking at, as I rightly said, I do not go by all your topography, because there is a quantum of, the imaging anomalies here. A contact lens warpage and dry eye patients here. So rule that out here. Do a repeat imaging at a different sitting after a gap of, say, 6 to 8 weeks, depending on what the patient, but I would like to do it at least at 3 months on these patients. These are the patients in whom I would probably run a Corvus ST. I would look at the corneal biomechanics on these patients here. And over biomechanics, I think you can also look at their anterior segment epithelial ASOCT epithelial thickness mapping in these patients. So look at all these so that you yourself, I think the fact is convincing myself that it's particularly safe for my patient before I go on to convince to my patient that it's going to be safe for you, and then offer a surface ablation. So that's how I normally approach my patient.
Very nice one. Thank you.
Thank you. Thank you, sir.
Thank you so much, Dr. Vanti.
Thank you.
Yeah, it's an extensive topic. I know
Yeah.
we give you enough
Yes.
time for that, but you made it, you gave a total overview of it. Thank you so much.
Thank you.
So we move on to our next topic, dry eyes. Where are we? So this is a clinical entity which all of us see in our day-to-day practice, may it be refractive surgery or cataract or any other general ophthalmology. Dry eye is a very common complaint, and it has a particular bearing on our post-operative results, both in terms of patient comfort and the quality of vision. So to give this talk, we have Dr. Inder Rastogi from Haryana. He's the director of Triveni Hospitals Private Limited. Welcome, Dr. Inder. Over to you.
Thank you, ma'am. My screen is visible.
Yes, yes. Screen is visible, but not the topic as yet. Yes.
Is it visible now?
It's invisible. It's visible, but it's not on slideshow mode. Yeah. Now it's done. Yes, sir.
Yeah.
Yes, Dr. Inder, have you started speaking?
Yeah. Thank you, ma'am. So I hereby thank you, the Andhra Pradesh Society, Dr. C.V. Gopal Raju, Dr. Madhu, and all the members of the APOS Society. What is happening in dry eye is basically dry eye is a complex of dry eye disease, dry eye syndrome, and keratoconjunctivitis sicca. And according to the Tear Film Surface Society Dry Eye Workshop 2, DUCE, it is a multifactorial disease of the ocular surface, which is characterized by a loss of homeostasis of the tear film, and it is accompanied by the ocular symptom, in which basically there is a tear film instability and hyperosmolarity. There is an associated ocular surface inflammation, and there is a damage also. And that basically there comes a neurosensory abnormalities, and they cause this problem. There are two types of the thing, that is, one is aqueous deficient, one is evaporative. And in aqueous deficient, there is a Jogren syndrome dry eye, and Jogren syndrome primary, secondary, and non-Jogren syndrome is there is a basically lacrimal deficiency, lacrimal gland obstruction, reflex block syndrome. There is a problem, or there is a side effect of the systemic drug. On the other side, evaporative problem, there is an intrinsic problem and extrinsic causes. Intrinsic, there is a related to the eye, basically meibomian gland deficiency, oil deficiency, lid aperture deficiency problems, low blink rates, and drug action problems. In extrinsic problems, there is a vitamin A deficiency, topical drugs, preservatives, they can cause this problem, or in contact lens wearers, this can be the problem. Even ocular surface problems, allergies, they are all place this extrinsic causes. Effect of the environment, basically the low blink rate, wide aperture, gaze position, because of the age and because of the hormonal problems. These are the various drugs which can cause this, antihistamines, beta blockers. So these all multifactorial problems, they cause this problem. Aqueous tear deficient dry eye happens when the lacrimal gland produces tear component, and that is very too low. So the surface of the eye remains is not very much hydrated. While on the evaporated dry eye, it is usually happens when the basically it is a meibomian gland. It is there at the cause root, and it becomes inflamed. So the tear quality is deranged. Hallmark of the dry eye disease is the hyperosmolarity of the tear film, and it damages the ocular surface directly or indirectly, and that incites the inflammation. and hyperosmolarity of the tear film, it leads to the cascade of the signaling events that basically releases inflammatory mediators, that is tumor necrotic factors or interleukins 1 and 6, etc. And they lead to the damage of the ocular surface. So basic cause is hyperosmolarity, and that leads to this multi factors. And ultimately, there is a tear film instability, and which leads to the, again, vicious circle. So aqueous deficient or evaporative dry eyes, basically it is a cascade event, and these are problems. So in evaporative problems, there is basically hyperosmolarity, and ultimately it leads to the interleukins and these tumor necrotic factor release, and ultimately problem is there. So what we see is this basically elevated osmolarity and increased variability of the osmolarity of the tears. Basically, this leads to the dry eye disease. If we measure the osmolarity of the tear, 308 milliosmoles, that is a threshold of the mild or moderate disease, while more than 308 or 316 milliosmoles has been a cutoff for more severe disease. So basically, dry eyes is a complex of both the things, aqueous deficient or evaporative. It is a mixed bag for some patients. And ultimate goals to be achieved in the treatment is basically the relief of the symptoms of the patient. We have to prevent the corneal damage also. We have to provide the ocular comfort also. And ultimately, after the full treatment, the tear film has to return to normal state. Basically, the approach includes we have to educate about the condition to the patient. We have to modify the environment of the patient, especially this because of the computer problems, screen problems, and identification and elimination of offending topical and systemic agents, if there is any, topical ocular lubricants, and ultimately the lid hygiene or warm compresses. These are the basically advisory to the patient. Next step is basically we have to give the preservative-free ocular lubricants. We can do the punctal plugs occlusion, or at the night time we can give moisture goggles also. Device-assisted heating or expression of the mammalian gland secretions, that is by IPL, on topical inflammatory, anti-inflammatory medications under the corticosteroids or cyclosporins, or the liftigraft is not available, and or antibiotics that can be given to the patient. Further treatment option is basically we can give serum autologous drops, oral scleragogues, therapeutic contact lenses, AMG, or surgical punctal occlusion, or even tarsorrhea. The treatment basically that is in evaporative problem is supportive, that is by mask and heating pads, and active is basically IPL or LLT. IPL is basically intense pulse light therapy. We give 5 pulses of light separately to the both eyes, but it is usually not advisable for vaccine people. Low laser light treatment that is given by mask, and it is provided to the both eye at the same time of the treatment option is again in this problem, secretory problem is supportive is drops or anti-inflammatory drugs, or active is basically punctal block or surgical. We can give stem cell or mitomycin, this MMG grafting or salivary gland transplant. These are basically what the medications do to the patient. We give medicine to reduce eyelid inflammation, corneal inflammation, or we give inserts to give more artificial tear or tear stimulating medications that they have been given, but not very much in role. And autologous serum, yes, that plays a good role. So devices where they do stand these days they are yes, the devices play in the primary premium practice, but really they are expensive, and the multiple treatments can be required, repeat treatments can be required. and you can't do in the allergic patients where their skin is allergic. But ultimately, poor rate of interest if the patient load is not that much. So it is a white elephant for some people. And this is basically investigation with how the things have improved by the LLT or IPL treatment. How to decide that in such cases by mammography, breakup time has to be more than 7. And if meibomian gland is less than 50% is there, lipid layer is okay on interferometry. So if it is there, we can give this as a treatment, that is mask or hygiene or preservative treatment. And in IPLs, with the recent treatment, there is a ocular surface. They have improved, increased in tear breakup time. This blockage is decreased and improved quality of the secretions. So ultimately, that leads to the improvement in the lipid layer. So again, much more this recent investigation has come, that is tear biomarkers or inflammatory biomarkers. And Dr. Shetty's bioempath founders, that is ELISA-based treatment, they are doing it. And they diagnose this interleukins and all that, and inflammatory markers, and they treat according to that. So ultimately, still the question is answered that how much is the role of the inflammatory markers, and how much we can treat them. So yes, if it is a interleukin related problems or these inflammatory marker problems is there, and devices is with us, so it is more consumer friendly device, and it gives result instantaneously, and we can treat the patient depending upon their problems. So is it so simple? Yes, there are premium practice instruments available. Yes, there are so many things available, but ultimately in the common practice, these 3, 4, 5 things, they come into the play. That is, we can give arm compresses, we can provide artificial tear, we can ask the patient to wear glasses, reduce the screen time, and use a humidifier. And we have to ask the patient to stay hydrated. Thank you very much.
Thank you, Dr. Inder. It was very comprehensive.
Thank you, sir.
I
and
think
one more appeal. Yeah, just a small appeal that I am standing for member North Zone ARC. So please support me. Yeah, thank you.
Thank you, sir.
Thank you so much. The extensiveness of the topic is that mild, moderate, severe. That just shows that it can be very simple for a person with mild dry eye, but equally debilitating for a person with severe dry eye. So you have shown all the modalities of treatment. Thank you so much, Dr. Inder. So
thank you.
Any questions, or can we move on to the last topic of the session? We are slightly.
I think we are running out of time.
Yeah,
so.
exactly. So we'll come to the last topic of the session. That is, both doctors and patients are very much interested, and there are so much of query, and they have all the questions. Any procedure we suggest, but they say, how about smile? So this is a very interesting topic, and we are having Dr. Vardhaman Kankaria, the young dynamic ophthalmologist. He's the founder director of Asian Eye Hospital, Pune. He has a lot of international talks and publications to his credit, and done a lot of refractive surgeries, more than 25K in the last 10 years. Welcome, Dr. Vardhaman. Over to you, please.
I think we've reserved the best for the last.
Yeah, that's exactly.
Thank you, sir. Thank you so much, ma'am, for the kind comments. And thank you, first of all, to Dr. Gopal Raju, sir, and Dr. Madhu for the kind invite. I hope I hope I'm able to share my presentation. Can you see my presentation, please?
Yes, we can see.
Thank you so much. So friends, I think from the era of the posterior RK, which was done almost 100 years back, to the era of current generation, third generation refractive surgeries, including Contura, Smile, and the current generation of ICL procedures, we have truly come a long way. This journey has been full of amazing innovations and also some disappointments, but there are many procedures which have actually stood the test of time. The first such remarkable procedure was the LASIK, which was first performed on the human eye by my mentor, Professor Ioannis Palikaris. This is a historic video because this is the video of the first ever LASIK done in the world. So as you can see, of course, from those times, the microkeratome was completely built in-house in our own institute in the University of Crete with professors, physicists. You can see the flap looks very crude, very small, very big hinge. But I think from that era where we have come today is really a remarkable journey. But this was the first globally popular refractive procedure. It demonstrated a lot of advantages to its predecessor, which was the PRK. But of course, as LASIK became more and more popular, it got replaced with femtosecond LASIK. And even in the current era of femtosecond LASIK, we still have certain unanswered issues, which are basically flap-related intraoperative complications, which can happen with both microkeratome as well as with femtosecond lasers. You also have some examer-related, fluence-related issues, which can happen, especially related to the corneal hydration levels, humidity in your room, presence of organic vapors such as perfumes, and the post-operative corneal flap-related issues. So as Thomas Edison says, there is always better way to do it, and we have to find it. I think the emergence of the VisuMax femtosecond laser in the creation of SMILE and its predecessor, which was called as the RELEX, which is called as the refractive lenticular extraction technique, has been remarkable in this journey now. The VisuMax femtosecond laser works on the principle of photo disruption, like any femtosecond laser. And as you can see, there are ultra short infrared laser pulses, which are precisely focused in the corneal tissue. And at its focal point, the tissue is disrupted and a small bubble is created. When you place these pulses next to each other, you can create a cut of any shape and size in the cornea. And that is the beauty of using the femtosecond laser. So before the SMILE came into place, the first femtosecond enabled refractive procedure was called as FLEX. This is basically how the femtosecond laser is creating the first cut, which is actually the flap, and then it will be used to create a lenticule. So once the lenticule is created, in those times, the flap was lifted. And after lifting the flap, you had to peel off the lenticule and put the flap back in its place. So this had one advantage. Basically, you got away with the examer laser related issues, but of course you still had the flap, which still was having its own complications. So the RELEX SMILE was a natural progression of this advancement. And as you can see, SMILE is a technology which is currently known as the bladeless and a flapless procedure. In this case, again, we are using a femtosecond laser. This is the posterior cut which is being done. With the femtosecond laser, always the first cut is posterior. This is followed by the anterior cut, which is also known as the cap cut. And this is ultimately followed by what is called as the 3 mm side cut. You can also customize this cut to 2 to 4 mm if you would like. And then at the end, after you have dissected the lenticule, you can remove it in its piece. On the middle video, you can see there is a live surgery which is being done. And this is the posterior cut, which is over. Now this is being followed by the side cut of the lenticule and then ultimately followed by what is called as the anterior cut. Once the anterior cut is over, then you have a very small 2 mm refractive cut and 2 mm cut or 3 mm cut. And once that is over, you have to just go and dissect the lenticule as easily as you can. Now it depends on how well is your laser optimized. As you can see, this is called as a gas bubble escape sign, which has been already described. And this are the basically differentiation of the anterior as well as the posterior interfaces of this lenticule. Then with a spatulated instrument, basically this has to be dissected very gently. If your laser is very well optimized, it is a very seamless process and you hardly have to do any active dissection. Once this is done, then you have to go to the posterior side of this lenticule. And once this dissection is performed, you have to remove the lenticule and see for its integrity. In the initial times, Dan Reinstein had done a lot of work with SMILE. And even during those times, this was a paper he has published about 7 years ago. But what he could establish that time was that SMILE and LASIK were as predictable in the refractive error correction. The efficacy of achieving 20/20 vision was similar with the SMILE as well as the femtosecond laser procedures. And importantly, the safety of loss of best corrected visual acuity of Snellen's, which is more than 2, was also seen to be similar in SMILE and LASIK surgery when it came to the visual outcomes. Even the first day outcomes in his series, this is the old series, which is 7 years back, as you can see, the outcomes were actually similar. But over time, the SMILE has also become improved. The technology and the technique both have gotten better. And currently, it has certain advantages over the femtosecond LASIK. And the most basic advantage is actually that you have gotten away with the flap. So there is no flap to get displaced. There are no microstriae, and the possibility of epithelial ingrowth has reduced to absolutely negligible levels. We have published a case of epithelial ingrowth even after SMILE, but this is one of extremely rare scenarios that we had managed for one of our colleagues. But this is definitely seen to be significantly less amount of epithelial ingrowth with SMILE than with the LASIK procedure. It is also seen that the quality of vision with the SMILE is actually better because there is a better subjective centration of the treatment, which happens as you are actually asking the patient to look at the green focusing light on the visual axis, as against with LASIK, it is on the central pupil. So there have been studies which have been published. Yeah. So there have been studies which have been published, which have actually demonstrated that the topographic centration of SMILE was actually more to the visual axis as compared to the femtosecond laser enabled, examer laser enabled centration as well. Definitely, SMILE has also shown to have a better extent of treatment. That is, the optical effective zone that you achieve with the SMILE has been seen to be significantly better, more regular also in the periphery, as against in LASIK. As you can see, it can become amoeboid sometime in the periphery because of the loss of fluence. It is also seen and published now that SMILE is known to be, of course, aspheric, but it induces lesser amount of spherical aberrations than the LASIK procedures of even current generation. That's not only because the examer laser is going to lose its fluence in the far periphery of its ablation, but also because there is a bit of biomechanical change which happens in the anterior stromal lamellae, which are seen to be much more in LASIK as compared to the SMILE procedure. And this study, which is a very large-scale study by Lin et al. From China, has shown that the SMILE actually induced a statistically significantly less amount of spherical aberrations as compared to the femtosecond LASIK itself. But friends, I think one of the most important reasons to choose SMILE for me currently is definitely induction of less dryness. It was postulated theoretically that because when you are looking at the corneal neurological, let's say, innervations, there is a subepithelial nerve plexus. And when you are actually performing a LASIK, you are cutting a flap, which is actually getting rid of a lot of subepithelial nerves, and then you are ablating on the rest of them. As against in SMILE, actually, you are kind of trying to preserve the anterior subepithelial nerve plexus because your cap is intact. And this was further on proven by also confocal analysis. This is a study which is done in Japan by Kimiya Shimizu et al. And they have shown that compared to a normal eye, after you have undergone SMILE, even in the first 1 month, there is a corneal renervation as well as some remnant nerves which are still there. But at the end of 1 month, in LASIK, there was hardly any corneal nerves which were seen at that subepithelial nerve plexus layer. And also, as the, let's say, natural postulate of that is that if that is the case, if the corneal nerves are preserved better, the corneal sensations should also be preserved much better, which has been seen by this large-scale meta-analytical study by Dan Reinstein et al. And he has actually shown, compared to the 16 studies which are published in the literature against 9 studies of SMILE, it was shown that in LASIK, there is a sudden drop of corneal sensations which goes to less than 10%, and it improves very slowly. But as against that, in SMILE, it reduces to only 50%, and it comes very close to the preoperative state within 6 months. So definitely in my own experience of performing more than 8,000 SMILEs in last almost 10 years, I have seen that all my patients who undergo SMILE hardly complain of dry eye, and they're off their lubricants sooner than the LASIK patients. This has also been shown by both objective as well as the subjective studies published by both Young et al. As well as Danaher et al. From the Wilmera Institute, that subjective as well as the objective parameters in SMILE of dry eye were much significantly better than with LASIK surgery. So friends, this brings me to one of the controversial subjects, which is, does the SMILE actually retain biomechanical strength? So this has been postulated that the majority of the anterior, the biomechanical strength of the cornea is in the anterior 1/3, and that is what we are creating with a flap. We are probably reducing it, and then maybe with SMILE we can retain it. But if you ask me genuinely, I don't believe in this theory. I believe that in SMILE the chance of ectasia is as high as in LASIK surgery. So your selection criteria for LASIK and SMILE should be exactly similar. Do not dilute your selection criteria for SMILE, for thinner corneas, for asymmetric topographies, for borderline topographies. Whatever you would do and choose a patient for LASIK are the same patients you would actually go ahead and choose in SMILE procedure. So these are all theoretical or mathematical models which are postulating that, but in reality and biomechanical studies have not proven it fully. So of course, there are other benefits of SMILE. There is no stromal exposure. There is no need of interface irrigation. So lesser possibility of DLK and infections. It is a much faster single step and single laser procedure. Definitely these lenticules have been used as the tissue addition procedures, both for hyperopia as well as for keratoconus. We use it in our own setting over the cornea for cross-linking whenever we have very thin corneas which are not up to the mark for regular cross-linking procedures. The currently SMILE, of course, there were certain myths that SMILE cannot correct myopia as well as astigmatism. I think both of them can be corrected very well if you do certain modifications to your technique. SMILE is known to give rise to as good the first post-operative vision quality as compared to the LASIK as well. But of course, the current limitations do remain in the form of enhancement, because you can hardly do an enhancement with SMILE. With a SMILE, it is reported, but it is rare to do it. And of course, the hyperopia is still under trial. There is no success with the hyperopia treatment as such. But friends, definitely SMILE has merged the benefits of both PRK being without a flap and possibly with better stability, and LASIK of having completely fast recovery without pain and no haze, and to treat very high refractive errors. So we have come from the era of RK to the current generation era of SMILE, where we have actually jumped to a very gentle butterfly kind of procedure. So I would like to thank again the entire APOS team for giving me this kind invite and opportunity to present in front of all my friends from Andhra Pradesh. And if you feel that I deserve to be in the scientific committee of AIS, please do support me. Thank you so much. Thank you.
Thank you so much, Dr. Vardhaman.
Thank you, ma'am.
Such a beautiful talk on the latest procedure, so nicely told. Now the doctors who present in the panel and the viewers who are not having SMILE and who have to do the other refractive procedures will be feeling, are we doing the right procedure for our patients? You've put that doubt in us right now. Yeah. Any of the panelists, the expert panel, or Dr. Sudhakar, do you want to ask?
Is there any scenario where you would, I mean, I'm sure it's very rare, but would you prefer to do LASIK but not SMILE?
Yeah, no, there are scenarios actually. I think there is a place for every procedure actually.
Yes.
So although my SMILE is, I really love this technology, but I think the take-home message is not, SMILE is not for each and every person. I think we have to think about the benefit of the patient. Whatever suits the patient the best is what you should do for the patient. So for me, I would choose a topo-guided femtolasic for somebody who has hyperopia, who has high astigmatisms. Definitely, I will not choose SMILE for them. Although it is possible to do it, but in astigmatism, but the procedure of choice will remain as topo-guided femtolasic surgery. And of course, for patients who have slightly thinner corneas, my still go-to procedure will remain as surface ablations, definitely over SMILE procedure. But I think in my practice, 70% people do qualify for SMILE. The rest we still do with topo-guided femtolasic, surface ablations, as well as for ICL also. Yeah.
Yeah. One question to Vardhaman, can I?
Yeah, of course.
Quick question. Hi, Vardhaman. I think that was a fantastic elaboration. Now we do have a few contestants. I wouldn't say contestants to SMILE, but a few variants of SMILEs with the newer machines offering us probably a go-to or a easier way of dissecting the lenticules, especially for probably non-corneal surgeons. So, what are your thoughts on those, or what are your say on those?
I think, Dr. Vanati, you're right. And I think that is one of the benefits of the technology, that when technology gets established, there are other industry players who would also is in benefit of both patients as well as for ophthalmology as well. Definitely, there is technology from the Zemer now, which is clear. And the clear is supposedly slightly more friendly when it comes to the dissection, but slightly more cumbersome when it comes to the ablation of the laser. So I think both of them have their own places. But the thing about current generation, I mean, the SMILE with the Zeiss is that it is established over last 10 to 15 years. We have a lot of published data and we already know what we are getting into. I think about Clear as well as the one which is coming from Johnson & Johnson, we may have to wait for some time to look at both their safety, predictability, see all those factors. But definitely, I think we are in exciting times. Yeah.
Yes. Thank you, Varadhaman. Thank you.
Thank you. Thank you.
Yeah, thank you all speakers for the excellent talks given, and you have made it much more clear for us and widened our horizons. I think closing remarks, the chairman would like to say something.
Yes, it has been wonderful overall picture and suitable for everybody. I think we are running out of time, so we'll wind up quickly and hand over to Dr. Chandramohan, who is the chairman for the next session. And Madhvi, of course, has been a wonderful host.
Thank you, Dr. Madhvi and Sudhakar sir, for taking this session nicely. Vardhaman, excellent talk. Congratulations. Lalita ma'am and Arif, do you want to add any points before you close? You're on mute, ma'am.
Am I audible now?
Yes, yes.
It's for Dr. Vardhaman, sir. So
Yes.
in cases of low refractive errors, especially with mild dry eyes, so do you prefer SMILE or surface ablations, especially with borderline thickness corneas?
Yeah, I think borderline thickness means definitely surface ablation. I think, as I said in my talk, my selection for SMILE and LASIK are same actually. I choose SMILE only because of being a flapless procedure, so I don't have to worry about the flap issues, and the other advantages are there. But when it comes to thinner corneas, I do believe that surface is actually going to be a better procedure. There are a lot of publications, actually one of them from my mentor, Dr. Prema Padmanabhan ma'am from SN. When one eye LASIK was done and one eye surface ablation was done, 3 such patients, and the LASIK eye went on to develop ectasia, the surface ablation was rock solid. It says a lot actually. The biomechanically surface is going to score wherever you have a borderline profile. And of course, wherever it is questionable, ICL always scores over other procedures.
Surface cannot be compared with anything. It's superior to everything.
And Dr. Vardhaman will be the right person because he's totally into keratoconus also.
Yes, yes.
I think he will be.
So I think all procedures have their right places. I think.
Correct. Yeah. Arif, final comments?
Suppose
sir,
if the thickness is not borderline, sorry.
Yes, yes.
If the thickness is not borderline, if the thickness is adequate, and which procedure do you prefer? Like whether it's SMILE or surface ablation?
So I think anybody who has more than 2 diopters, I choose SMILE procedure. Anybody who has less than 2 diopters, although SMILE can be done, but I think surface will be my go-to procedure. Yeah.
Okay. Thank you, sir.
Sir, excellent talk, Dr. Vardhaman. And this is a question actually for both Dr. Vardhaman and Dr. Vanathy. Sir, like you people have talked about corneal biomechanics to be included in a routine practice. Then is it really very essential to go with corneal biomechanics, or pentacam alone should be sufficient for a beginner to start his refractive practice?
Yeah. Dr. Vanathy, you'd like
to?
Yes.
Yeah. I think the question here where you want to apply corneal biomechanics is when you're red flagging your topography. So when you're looking at those eyes with those borderline measurements here. So as I said, when you have a topography which is it's slightly suspicious and your corneal thickness is lesser. So I look at my corneal thickness on a normal topography, on an abnormal topography here. And then you have a red flag on those, then apply your Corvus to it and your ASOCT epithelial thickness mapping. And that is where what you want to identify is subclinical keratoconus, because these are the eyes which are at the highest risk for development of post-refractive surgery ectasias, whatever be the procedure. Today, I think the safety margins for surface ablations are probably a slightly better, but now I think the recent studies are questioning those as well. So these are the eyes where you probably have to subject them to corneal biomechanics. But as I rightly mentioned earlier as well, I do not use this artificial intelligence collated data to Indian eyes because they are Caucasian eyes, which is there. So do look at it comprehensively on fitting in your clinical characteristics, refractive characteristics, topographic characteristics, and then come to a diagnosis. If you're really scared, now I think the safety margins with your phakic IOLs is fantastically improved over what we had earlier. So there are a lot of people who are doing phakic IOLs even for low and moderate myopias here. So when your surface ablation is also in doubt, then I shift to a phakic. So to make it short, I think I use corneal biomechanics when any of my screening parameters, especially your topographic parameters, are being red flagged.
So Dr. Arif, very shortly, if I have to tell my view, I think for beginners, as you were saying, I don't think that it is a must right now because it is actually not well proven. It is not very reproducible as of current situation. So I think the biomechanics may not change your view, and I'm of the opinion it is better to reject more. So if I see somebody who has a borderline topography or a thickness and a good biomechanic on corvis, I will still not do the procedure. Because for me, even a single red flag is good enough not to do the corneal procedure for the patient. So for a beginner, definitely, I think biomechanics is not really required. But I think as Dr. Vaniti has correctly said, doing epithelial mapping will have more value because epithelial mapping will give you more suspicious cases in addition to your topography rather than biomechanics as of today.
Thank you. Thank you so much, all the panelists, Sudhakar sir and Madhvi ma'am. Now we'll go to the retina session. Chandramohan sir.
ICL would have completed the picture, the phakic implants, but unfortunately, I think there's a short of time in this refractive.
Yeah, that is included in the practitioner's perspective, I think, sir. It's
okay, fine, good.
Chandramohan sir and Lakshmaya sir.
Good afternoon, Madhu. Good afternoon, everyone.
Sir, good afternoon, sir.
Good
Sir,
afternoon, Madhu.
We have a buffer of half an hour that we have given for lunch so that you can utilize that time, and by 2 you can give it to session 4.
Definitely.
Over to you, sir. Lakshmaya sir and Chandramohan sir. Thank you all the panelists of session 2 once again. Thank you very much.
Thank you. Sir, good afternoon, Lakshmi sir.
Good afternoon, Chandramohan.
At the outset, I would like to thank APOS for this fine day-long CME and also the fine topics that they have put in the retina sessions. We have a wonderful array of speakers touching all important topics, both to the posterior segment as well as anterior segment surgeons. And we have a young, enthusiastic panelists with us. Without wasting much time, Sir Lakshmi sir, can we start the session?
Yes, Dr. Mohan. First of all, thank you, Dr. Mathur sir, Dr. Gopal sir, for giving me this opportunity. And we'll start this right. Already we are late, so we'll start this session. The first topic is on a case on anterior uveitis by Dr. Somashila Murthy garu.
Good afternoon, and thank you very much for inviting me to this session. And Can
Ma'am, audio is not very clear, ma'am. Hello?
I think there is some problem from the ma'am's side. She has her internet is.
Ma'am, your audio is not very clear, ma'am.
All right. Is my audio better now?
Yeah, it's better.
Yeah, fine.
It's better.
Because I do have a poor connection. So if at all I'm getting completely disconnected, please send me a message or give me a call. Otherwise, I won't know.
Yeah, you can proceed, ma'am. Now we can listen.
All right. Thank you very much. So mine is not just a single case presentation, but I'm going to take you through anterior uveitis via cases. And I'm Dr. Somashila Murthy. I'm currently a member of the scientific committee of AIOS. And just like I've been hearing since morning, I too am standing for it. For those of you who are wondering how many people are standing for this post, Dr. Gopal Pillai from Dr. Gopal from AP, and he too is standing for this. So there are 7 posts, and you're free to vote for as many as you like. Coming to the topic itself. So my plan is to present to you what are the commonest anterior uveitis entities, followed with what are some of the entities that we offer. Luckily for us, that in case of pediatric uveitis, it's always better to refer these patients. 1-year-old male, he had a history of sudden onset of symptoms for 3 weeks. He was already, by the time he came, showing us plus AC reaction, as well as a streak hypopyon, as that he has had such episodes in the past. So what this clinical photograph shows is that the posterior synechate, there's some kind of membrane on the pupil.
Your slides are not moving.
Hypopyon.
Slides are not moving and the voice is getting cut, ma'am, in between.
Okay. Is my next slide?
No, it is on the first slide only.
You are still in your title slide, ma'am, here.
Okay. Is it getting better?
No,
Yeah,
it is the first slide only.
Slides are not changing, ma'am.
I think instead of Wi-Fi, can you try using your hotspot, ma'am?
Hello, sir. Good afternoon, sir.
Yeah, I am on hotspot only. Unfortunately, that also seems to be very poor.
Oh, okay, okay, ma'am. Okay.
You unshare and then share again.
Okay. So you can see this slide, right?
Yeah.
All right.
Yeah, now we can see.
Has the next slide come up?
Yeah, it's changing, ma'am.
Okay. So this was about the patient I mentioned. Can you see the clinical image, the slit lamp?
Yeah,
showing the posterior synechate, the membrane, and the small layered hypopyon that the patient has. So because he came with history already with papers showing that he's HLA-B27. So the diagnosis
Hello? Hello?
So what we do for this patient is we start the patient on topical steroids every 1 hour, maybe at least atropine.
Hello, Chinlakshmi sir? Hello? Hello?
Hello.
Lakshmi.
Yeah. Can we shift to next topic in between? We can call her and make a video of people to talk to her.
Madhu?
Yeah, that would be better.
Yeah.
Sir,
next topic is an important topic, especially very frequently we find whether it is an endophthalmitis and TOS, very important topic. We invite Dr. Ajay Arora to talk on diagnosis and management of endophthalmitis and TOS.
Thank you,
sir, Dr. Ajay Arora.
Am I audible and visible?
Yes, sir.
Okay, thank you, sir. At the outset, must thank Dr. Gopal Raju, sir, Dr. Madhu, and the organizers of the VOC Conclave 2023 for giving this opportunity. And I'll just share my so my slides are visible.
Hello? Not yet, Ajay. Not yet, sir.
Hello?
Oh.
Yeah, the slides are not visible, sir.
Not yet, just share.
Yeah, now it's fine.
Is visible?
Yeah, now
yes, sir.
Okay. Okay. So thank you once again, and I'll be talking on diagnosis and management of endophthalmitis and TAS and intravitreal injections and beyond. So all of us, when we have a cataract surgery, we would like the results to be like this, where there is a perfect outcome and not a disaster like an endophthalmitis or an inflamed eye catarrh like this. Now, whenever we operate a patient, we can have 4 situations where the eye can be inflamed. Either it could be TAS, it could be an endophthalmitis, it could be an acute exacerbation or inflammation and a post-surgical trauma. Now, all of them have a common link, and that is they have an inflammatory pathology. But what is uncommon is that if you have an endophthalmitis, then there is an infection present, which is an underlying organismal cause, which is perpetuating, and therefore there is a little difference. Now, TAS was first described in 1992 by Monson. Now, it is an inflammatory response to a non-infectious substance, which is introduced into the eye during or immediately at the end of surgery. Now, what is the difference between TAS and endophthalmitis is that TAS is a one-time event and not an event in continuity, which means the TAS will present early, there is no replicating organism, and hence it is not self-perpetuating. All of us, even if we are doing excellent surgeries, we should always be cautious that whenever we do something different or we change our practices in some way, we can have TAS. So TAS is not a never event. It can happen with the best of people. Now, what normally causes TAS is a heat-stable bacterial endotoxin. And as we have seen in a recent episode of the All India Ophthalmic Society, where TAS occurred because of certain hydrophilic lenses, we were not, the All India Ophthalmic Society was not able to demonstrate an increase of endotoxins, but a lot of people reported TAS all over the country. TAS could also be because of reusable devices like phacotips and sleeves, ioprobes, Simcoe cannula, iris hooks or rings, viscoelastic residues, or contamination by various other materials that are used in cleaning of equipment, and abnormal ionic concentration of pH, preservatives that are used during the surgery or the post-op antibiotics. I hope I'm audible, no? I'm just checking.
Yeah.
Okay.
Yeah.
So, when we look at TAS, it usually occurs within 12 to 24 hours, while endophthalmitis, it can also present on day 1, like especially in cases of Pseudomonas, but usually present within the first 3 or 7 days. The other difference is that in TAS, there can be a limbus to limbus corneal edema, while in cases of endophthalmitis, it may be localized near the wound. Then you can have other features which are common to both TAS and endophthalmitis. But when you do a B scan, in TAS, it's generally likely to be anechoic, while in endophthalmitis, you can have vitreous opacities. Then, of course, culture will be negative in TAS, while in endophthalmitis, it will be positive. Let us see a few examples. Like this particular case, who was a patient with RK and phaco operated, we were sure that this is not a case of endophthalmitis, and patient was treated with intensive steroids, and over a period of 2 weeks, this unusual case of post-op reaction on limbus to limbus edema. There was inflammation in the beginning. Patient was treated with intensive steroids. Patient responded over a period of time, and patient's visual acuity improved. Now, whenever you have doubt, you must err on the side of infection. Like if you have a case of hypopion, it's obviously a case of infection, and you must treat it like one. In case, if it is very subtle, you must still treat it as a case of infective cause, and hence appropriate treatment has to be given. Now, most of the treatment for TAS, like TAS, you need to give steroids, you need to give cycloplegic mydriatic, lubricants, non-steroidal anti-inflammatory, and in endophthalmitis, all these things, plus you have to give topical antibiotics, intravitreal antibiotics, and systemic antibiotics, and in later stages, a vitrectomy may be required. Now, let us look at how to prevent TAS. You know, the task force for TAS proposed a few things, which is important for us to know. The ultrasound baths are one of the common sources of the heat-stable gram-negative endotoxin or the lipopolysaccharide, and hence you must make sure that the ultrasound baths in your clinic are periodically cleaned. The phacoprobes and ioprobes tips must be washed with 120 ml of sterile water after use. Do not touch ios with gloved finger. Do not reuse viscoelastic cannula because viscoelastic cannula cannot be actually cleaned completely. Some residue may be left behind after autoclaving, and they may be responsible for TAS. And it is preferable to use powderless gloves. Now, when I joined Shroff Charity Eye Hospital way back in 1997, we started following a particular procedure because those days powderless gloves were not available, that after having cleaned and gloved ourselves, we used to wash our gloves with sterile water and then only start our surgery. And that practice still holds true and it is very useful. Now, once you have done everything, then of course, ultrasound can be done and that will prove the diagnosis of TAS or endophthalmitis. Now, once you have reached a diagnosis of possible endophthalmitis, you must know how to collect the sample, how to transport it, and what all things you need to do. So the collection of sample can be done with a 26 gauge needle where you can carefully aspirate the vitreous, or it can be done with a butterfly, as was demonstrated by Dr. Das with Dr. Harry Flynn. We prefer to take a tap from the anterior chamber, which also works out pretty well in cases of endophthalmitis. And when you're operating, you can certainly connect your cutter with a syringe so that initially, before you actually connect it to the tubing of the cutter, you can aspirate a little material and send it for culture and sensitivity. So once we've taken the sample, we put it in an ETO pouch, we bend the 26 gauge needle from front and transport to the lab as soon as. And in case I'm operating a patient sometime in the evening and the lab is closed and you cannot send it immediately, then we keep it in the side wall of the fridge and send it the next morning. The other option which we follow in our center is to inoculate the culture plates directly and have a chocolate agar, blood agar, or severus dextrose agar so that they can be sent. And so these are the things which you need. You need 2 slides, you need 3 solid medias, 2 liquid medias, and these are required for diagnosis of endophthalmitis. Then, of course, we can do PCR, which is very useful in establishing a diagnosis of endophthalmitis, or the Bangalore lab of Exciton, which is very useful. Now, if in cases of cluster endophthalmitis, if in case you get a gram-negative bacillus, then you must suspect your supplies because it may be because of Pseudomonas. If you have a gram-positive coccus, then you must suspect Staphylococcus because then you should suspect your personnel. If it is a gram-positive rod like a bacillus, then you should suspect apparels. Now, there is a difference between the spectrum of organisms which was demonstrated by EVS and what has been demonstrated in the Indian studies. We have larger number of gram-negative bacillus present as compared to what was shown in the EVS. The EVS study showed about 4% gram-negative bacillus, but the various studies in our country have shown anything from 26 to 28% gram-negative bacillus. Another thing that has come up recently is that the antibiotics which were commonly used for the treatment of endophthalmitis was a combination of vancomycin and ceftazidime. Now, if we look at the resistance pattern of these antibiotics, the vancomycin resistance has increased in 2004 till today to about 6%, from 4 to 6%, while ceftazidime now has a resistance, as has been demonstrated by the LVP study, to almost 66%, which means giving vancomycin and ceftazidime may not be the best possible combination. So whenever we get a case of endophthalmitis, we have to use one antibiotic which is for gram-positive and one antibiotic which is for gram-negative, and commonly we use vancomycin and ceftazidime or alternatively vancomycin and amikacin. But now it's better to use vancomycin and imipenem. And whenever you're suspecting a bacterial endophthalmitis, dexamethasone can be given. I normally do not give dexamethasone if I'm suspecting fungal endophthalmitis, because then we have to give either amphotericin B or voriconazole. The preferred choice should be amphotericin B if possible. Now, this is an example of a patient where we gave, this was in the past, Vanco and Cefta, and the patient responded over a period of time. So this is just to show that every case does not require a vitrectomy. Intravitreal antibiotics are reasonably good enough in treating patients of endophthalmitis if you can make the correct diagnosis. So as I said earlier, you can combine it with Vanco or Tazobact or Vanco and Imipenem, and then we have other antibiotics, and these must be known and stuck to your operation theater wall so that you can choose the right antibiotic. Now, for any intravitreal injections, we follow a particular pattern of giving injections. You clean the surface. Now, all the injections in our center, obviously, a retina surgeon can give it anyway, but I have a device which is patented on my name. So this is a device which has got an undersurface, which has got a sawtooth pattern. It sits over the limbus. It has got a gauge which is at 3.75 millimeter from the limbus with a valvular entry. You can enter like this. This ensures that when you lift the device, there will not be any ooze. And we finally selected these two devices which we are using for intravitreal injections. So many anterior segmental intravitreal injections can use the device. That way, they don't have to fixate the globe, and they don't have to caliper to measure it, and it can be given. The procedure for giving intravitreal injection is standard, which I think should be followed for all intravitreal injections with the cleaning of the provident iodine. Use a 30 gauge needle, an oblique entry at about 3.5 to 4 millimeter, depending on whether it's a phakic status. And at the end, you can use topical antibiotic. So then some examples. So once you have given intravitreal antibiotics, you should also start patient on systemic antibiotics, because it's been shown that at least in the inflamed eye, the antibiotics do enter. So we normally use ciprofloxacin 750 milligram, and it works pretty well. I'll share a few cases and then I'll close. So this is shared by Dr. Ashish. This is a 45-year-old type 2 diabetic patient who underwent pars plana vitrectomy, intravitreal Vanco and Tazobact. The microbiology was negative. Patient had underwent a revit, and Vanco and amikacin was given. Patient's hypopyon came back. A second opinion was taken. A vitreous sample was sent for PCR. Patient grew Bacteroides fragilis, and we gave imipenem. So what I am trying to drive home is that organismal diagnosis is very important. Another patient who had Vanco and Tazobact given initially, after vitrectomy, the hypopyon actually increased. The sample was sent, which grew Pseudomonas aeruginosa. Patient received colistin and patient responded. Again, an organismal diagnosis is very important. This is a very interesting case, which I had operated way back in 2009. I had done a vitrectomy for a patient of endophthalmitis who had undergone phaco with the intraocular lens, where we gave vancomycin. There was no growth. Subsequently, we lost the patient to follow-up. Patient had received subsequently 14 injections of intraocular antibiotic, multiple injections of Avastin for DME, was culture negative, PCR negative, vitreous cytology negative, PET-CT negative, had also received methotrexate injection, and patient came back to me 6 years later with a recurrent vitritis. Now, this was a situation I was not sure what I was dealing with, but this old lady who still had an IOL in place, she said, I don't want to get my IOL removed. People have asked me earlier. So I said, okay, maybe it's a persistent recurrent endophthalmitis, and I need to get a sample to prove the diagnosis. So I thought that the only place where I can get the sample is from the zonular area. So I took a needle, which is 32 millimeter long, 26 gauge needle, made it into a cannula. It was a 23 gauge vitrectomy at that point of time in 2015. went into the area of the zonules with the cannula, aspirated as much as possible. And when I was aspirating, I could see something coming out in the anterior chamber as well. Went into the angle and aspirated this purulent material, which all of you must be able to see now. And this we sent for analysis. And we sent it to SN as well as Exciton. The SN lab grew P. acnes, the Exciton grew Fusarium species. So we treated both, and the patient responded to the treatment. And the patient, I followed her up till 2019, and patient is doing well. So the basic thing is that organismal diagnosis is important. If you have an intravitreal injection and following which you have an endophthalmitis, it is important to do an urgent vitrectomy. So the take-home message is, please take all steps to prevent endophthalmitis from occurring, differentiate TAS from endophthalmitis. When in doubt or on the side of infection, if suspecting bacterial, use steroids. Timely and judicious vitrectomy is very important. Organismal diagnosis is the most important factor in treating endophthalmitis, and you must document all your findings and must communicate with all your patients. Before I close, I must share a non-academic slide with your permission, sir, that me and Dr. Rajesh Sinha are standing for elections, Dr. Rajesh for secretary and me for treasurer. And I would certainly request for your support, and thank you for giving me this time. Thank you very much.
Thank you, Ajay sir. That's a wonderful talk. And a very important point you have stressed. First thing is to differentiate TAS from endophthalmitis. That is very important slide that you have shared. And one important golden point you have told, when in doubt, err on the endophthalmitis side. That is a very valid, important take-home message that everybody has to take. So don't keep thinking that it's an inflammatory.
I was audible during the presentation.
Yes, sir. Yes, sir. That's totally audible. Totally audible. So it's very important that you should think that it is an endophthalmitis rather than satisfying ourselves thinking that it's an inflammation. And sir has clearly enlightened how to give an intravitreal tap, take the samples, and then treat the case of endophthalmitis. So, any other questions anybody has got?
Sir, good afternoon, sir. This is Dr. Pawan.
Pawan, tell Pawan.
Sir, most of the time, sir told the cultures will be negative. Even gram stain, because I think so. This because our location or the labs, I just think most of the time the cultures will be negative. We won't get the sensitivity pattern. This thing. That time, even if you have a doubt that is an endophthalmitis, you better go with intravitreal injection first in the first shot within, and repeat it within 48 hours. If the patient is responding, you'll usually see the clinical signs. But once the case goes to vitrectomy, how many of surgeons go for PVD induction?
Yes, ma'am. I've seen the message. Yes, ma'am.
Pawan, two important things that you have told. First thing is culture. As you told, even our center, the culture positivity rate is only 30% for the vitreous tap and AC tap that we take. Even in the best of institutes, it's around probably 60 to 70% only. So many of the times you cannot get the organism that you are growing. But one key thing we can find out is whether it is a bacterial or whether it is fungal, these two things. Because if it is fungal, the line of management is different. So that you can get when you give the sample for KOH mount and gram positive. So for example, we should ask for a KOH mount and gram positive thing, which will come immediately. That gives an idea whether we are dealing with a fungal or a bacterial endophthalmitis. And as you told, once with the vitreous primary vitreous tap, it's not responding. Then it means that if it is a bacterial, we are not treating the right antibiotic. So in that case, when you are going for a core vitrectomy, I again recommend take another sample second time when you are taking a core vitrectomy, and then again send it for culture. That is the best thing. And sir, Ajay sir, are you doing A total vitrectomy and putting silicone oil, sir, for core vitrectomy?
No, I'm not. No, that is only in cases where we have a patient with a fungal endophthalmitis where we have to do, or especially in cases, certain specific cases, but otherwise, normally I do not like to go ahead and induce a PVD. I do as much vitrectomy as possible, maybe a little more than core. And as you said rightly, our positivity rate is about 40 to 60%, depending upon whether they take the sample from the anterior chamber or from the vitreous. And it is always important that you go to one particular lab where you are comfortable with. Because so we have been following with I have worked at Shroff Charity Hospital. We had established a very good lab there. I have a good working relation. So there I know that the reports which are going to come out are going to be good for me. So whenever we send a sample, they immediately within half an hour tell us what is the gram status and what is the KOH status. Once we know that status, we know whether we are dealing with the bacterial or the fungal. And once we have that clarity, then treatment is very effective, very easy.
Yes, sir. And one more point, you have already highlighted the ways to transport the sample. You're clearly told about how to store the sample and how to transport the sample. The best will be as you're doing to put the samples in the blood agar, culture media as early as.
Yeah.
Chandra Mohan, regarding the complete vitrectomy, can I add to it?
Yes, sir.
See, for us, PVD induction is as essential. Now, complete vitrectomy should be the goal. It is not about the base excision, but PVD induction should be attempted unless the retina is necrotic and fragile. Okay. So that will lead to complete, you hardly leave any core vitreous, which will act as a further culture media for the organisms to proliferate and be more synergistic with the growth. So for us, PVD induction is must unless retina is edematous and necrotic, where it will lead to tear.
Sir,
can I add one thing? So
yes,
what Prashant is saying is correct to an extent, but when a take-home message is Prashant is now we have an option of a shaving mode in a vitrectomy system. So we can go very close to the retinal surface and remove most of the vitreous. We should not go hunting for the PVD. Most of the patients we are able to induce a PVD, but if you are not able to induce a PVD, it does not matter. Put it in the shaving mode, remove as much vitreous as possible, so that the aim is to get as much vitreous out of the vitreous cavity as possible, so that the antibiotics, eventually fight is between the antibiotics and the organism. So if you are able to get your antibiotics into the eye and get most of the vitreous out, and the job is done.
Good afternoon, sir. I have a question regarding the TAS, sir.
Yes, sir.
In every infective component has inflammation in prior. So when we are seeing more of TAS, we are giving anti-inflammatories. So how frequently we should follow up so that even if infection gets in, so that we can give antibiotics?
No, so once you have to differentiate whether it is TAS or endophthalmitis. If you are not sure, I would treat them with intravitreal antibiotics. In case it is TAS, I would treat them with steroids, and if I think that the chances of it being TAS are much higher, then I'll treat them with non-steroidal anti-inflammatory and topical steroids and follow them on a daily basis. On the first day, I'll probably see them morning, evening. Next day, probably I'll see them on a regular basis. And once I'm sure that there is no infection, then you can follow them with less frequently. But if you're still not sure, then you should follow them as frequently as the case demands.
Okay. Yeah, the dictum should be, whenever in doubt and you're treating it as a sterile variant, see him on a slit lamp and an indirect ophthalmoscopy 6 hours after the primary examination.
Yes.
That should be the rule.
Yes, sir. That's a good discussion on the very important topic, sir. Now we'll move on to the next. Okay.
This is Dr. Neha, sir. Last question.
Yeah,
So I wanted to know which are the conditions where the IOL is explanted. When do you expect to explant IOL in case of endophthalmitis?
So one indication that is given was initially we used to do it, people used to say with P. acnes. I don't do it with P. acnes as frequently. So what do I do with P. acnes is I make an opening in the posterior capsule. I give a wash of the back, and so that whatever goes into the vitreous cavity, I remove it. So that one indication I've reduced. Other than cases of fungal endophthalmitis, we may want to remove the IOL. If it is a case of a recurrent endophthalmitis, I showed you the last case where after 6 years we did not remove the IOL because the patient was not wanting to get it removed. But in such a situation, I would remove an IOL.
For me, the
And this,
dictum is to preserve for me, the dictum is to preserve the IOL in a primary surgery. If it becomes recalcitrant and recurrent, that is the only time, be it a fungal, be it a P. acne, you should always try to preserve IOL.
Yeah.
Only recurrent, recalcitrant other cases.
You have to remove
the RT-PCR.
Sorry?
So the RT-PCR which you explained, so what is the RT-PCR you prefer to determine this bacteria, sir? What is the test you advise for?
No, when you send it for PCR, they have a spectrum of tests which is done. Like in SN, they test it for about 14 organisms. Exciton does it for the spectrum of organisms, and then they come out with the results, which we normally go back to. This was what was being done earlier. Now we have PCR testing available in every city. You don't have to send the sample to SN or to Exciton in Bangalore. So you go back to your lab and ask them how they are doing the PCR, and they'll tell you what organism it is.
Okay, sir. Thank you. Thank you very much for the healthy discussion. We will now move on.
We are already late. Now Dr. Somshila Murthy madam is there. Just we'll invite her to the next talk. Now we'll go on to the next talk, antiderivates, case of antiderivates by Dr. Somshila Murthy.
Morning again, and thank you very much. I hope I'm audible better now.
Yeah.
Yes, ma'am. Yes,
Okay.
ma'am.
Yeah, I'll just share my screen and try to make up for lost time by skipping a few of the cases. Is my screen visible?
Yes, ma'am.
Okay. So it looks like the session is more than retina uvea. It seems like a session for all who are contesting for AIOS, including myself. I was looking at the speaker list. And so I'm just going to quickly go through the first case which I had mentioned earlier, and I'm going to go through the first three situations. The commonest anterior entity, which is the first case, often missed or misdiagnosed, and the third scenario is underdiagnosed, but it may be commoner than we think. So the first case was this young man I was talking to you about earlier, and he came in with sudden onset symptoms. We know that he's HLA-B27 positive. So it's very easy for us to make the diagnosis of acute anterior uveitis. And here he has a report, so it's HLA-B27 type. And the treatment for him is topical corticosteroids along with atropine, which we give it in a high intense dose, and then taper gradually based on the improvement for the particular patient. Very often in most of the episodes, you'll have resolution of all this fibrin. The posterior synechia may not become permanent in this patient, luckily it didn't. So it's a common entity. Whenever you have the reverse, like you have a young male patient coming in, may or may not have history of any joint inflammation, the first investigation I always do for non-granulomatous disease is to ask them to get an HLA-B27 done. So even if it's positive, we know exactly what we're dealing with. But if it is negative, then okay, we still have to investigate, or maybe we just treat the patient and then think about investigating later. Remember that for HLA-B27, oral steroids are very rarely required, very few cases. So most of them, even though they may look very severe, improve very rapidly with frequent topical steroids. And some patients, of course, when they have systemic disease component, then they are already on immunomodulators. But for ocular disease alone, it's very rare that you need to use oral therapy. So if you have a patient with multiple episodes, like you give treatment, as soon as the medication is done, then the patient again has an episode. So these are the only few indications for oral immunomodulator therapy for ocular disease alone. So the clinical pulse from this case is that are that HLA-B27 is a common entity, perhaps in the case of non-granulomatous uveitis. In a young patient, maybe 50% of them could have HLA-B27 association. So try to rule it out. Even when the patient comes to us and they're quite elderly, they come to us more with the features of angstpon or ankylosing spondylitis. They still have recurrent anterior uveitis. This patient had, these two patients, this patient of mine and this one by Dr. JD's patient, had a cataract as well. So when they come to us in this age group, then surgically it can be quite a challenge because of the neck deformity. So they can't lie down on the operating table, and you have to resort to, the surgeon has to be sort of, a gymnastic kind of a person also, where you sometimes have to do standing surgery. So that was about the first case. Quickly taking you through the second case. Remember I said that it's often missed or it may be misdiagnosed. So this is another young male, 24-year-old, sudden vision loss and white reflex. There's no history of trauma and absolutely no history of red eye or recurrent episodes. When you see this patient, you see that there is the pupil dilates very well, so there are no synesthesia. There's an intumescent cataract, of course. And when you look carefully, you can see that there are multiple small to medium-sized whitish looking chaetic precipitates, and some of them are crossing the midline also. So when I set up the stage for you, it's very obvious that most of us would know that this kind of patient is nothing but Fuchs heterochromic cyclitis or Fuchs uveitis syndrome. But when the patients come to us in these various stages that I've shown here, just with the chaetic precipitates, sometimes with the the iris shows hypochromia, but very often it doesn't show, especially in Indian eyes. And sometimes they have a very florid looking chaetic precipitates, a lot of them, as well as AC reaction and vitreous opacities. So then these patients get labeled as intermediate uveitis. I've had in my experience patients who have received multiple therapies, including oral steroids, including Ozurdex injection, because it was thought to be, including tubercular therapy, because it was thought to be intermediate uveitis and not responding. So the clues here are, if you have a younger patient, and remember there'll be no red eye, and also there'll be no synesthesia, and there's low-grade inflammation. So this is classic for Fuchs heterochromic cyclitis or Fuchs uveitis syndrome. So in addition, the KPs can be stellate looking. You can get them if you have some way of looking at the specular or confocal. And rubella has been implicated as the etiology for this entity. Most of the time, the complications are very low, except that cataract is very high in these patients. Although glaucoma has been mentioned as a common complication, the incidence of it is very rare, luckily for us, but we must monitor these patients for glaucoma. So coming to the third scenario, the second was Fuchs uveitis, in which rubella virus was implicated. So the third scenario is something similar but different. So this is a 35-year-old lady, and she has a long history of recurrent episodes since 16 years. She has secondary glaucoma. She has a Forstner-Schwarzman type of syndrome, where the patient comes in suddenly with redness and symptoms of decreased vision. We measure the intraocular pressure, it's sometimes very high, maybe in the 30s or 40s. The patient has about 1 to 2 plus cells. And you have to start both anti-glaucoma medication as well as topical steroids to lower the pressure. This keeps on happening. So this is what this patient had. She also incidentally had LASIK surgery, with which she had good recovery. But when she presented to us, she had one eye was doing very well and the affected eye vision was very poor. And on the slit lamp examination, what you can see are those white centered or quite and medium to large size, very isolated chaetic precipitates. Some are here, some are here. So there's no pattern to this chaetic precipitates. She also had corneal edema because of the LASIK that she had undergone. So she had fluid in between the LASIK flap. But this is not important to this discussion today, but you can see those chaetic precipitates on the OCT images, which are literally very large and three-dimensional over there. So this particular patient has secondary glaucoma due to uveitis. So whenever you have a patient with recurrent anterior uveitis and raised pressure, so literally the diagnosis is staring at you, we call it as viral anterior uveitis. So there are 3 viruses that can cause this condition. How do we diagnose it? AC-TAP, of course, we were discussing just now, and it is available more and more, the testing, real-time PCR or qualitative PCR testing for these patients. But real-time PCR is better. So we can do an AC-TAP and send the specimen for the lab. And in this particular patient, we were very confident that this must be CMV uveitis. So we started treatment with Valgan cyclovir. Meanwhile, we got back the result, which showed that the patient had a very high copy number for CMV virus. and we continued the patient for almost 3 months of therapy. So the story for this patient is that she had resolution from her recurrent episodes. We do need to use low dose of topical steroids for a fairly long time because there is an immune component also to this disease. It's not purely infection. And she also had to undergo a trap because, as I told you, she had come with very high pressures and she had a 0.9 cup. So the classic features here are that she had these multiple sort of largish or point-shaped keratic precipitates, and she had mild AC reaction and very high intraocular pressure. So classically fitting into the CMV endothelitis, kind of an anterior uveitis or a viral anterior uveitis component. The two other viruses that are well implicated are HSV and varicella zoster virus. Acyclovir or varicyclovir work very well. Supposing you don't have access to AC tap and to getting the results, then one way is to look carefully at the clinical features. You can start the patient on a trial of acyclovir or valacyclovir, and if that doesn't work, then you might have to think of starting ganciclovir. The reason for not starting ganciclovir right away is because of its expense. It's very expensive for most of our patients. So to conclude, I took you through the commonest anti-uveitis entity, often missed that or even misdiagnosed fuchs. And the third entity was that we often underdiagnose it. So we keep on treating the glaucoma, we keep on treating the inflammation, but we often don't start the antiviral because the findings are so subtle. And the fourth and fifth scenario, I'll keep it for the next year's meeting. Thank you very much.
That was
Yeah. Chandramohan, you can continue.
Yeah, that was a nice presentation, madam. If time permits, we would have had even those two discussions also. But
sorry, it was my bad.
okay. So any of the panelists, any questions? Any 3 questions? Quick.
This is Neha, ma'am.
Yeah.
So I just wanted to know, are there any differential diagnoses for a case of anterior uveitis with glaucoma apart from viral uveitis and Posner's?
Yeah, so of course, do not rule out steroid response. Do not rule out all the other mechanisms of glaucoma. So chronic uveitis can also have secondary glaucoma due to angle closure. That's a very important entity. Some of the VKH patients can present like that. They can have bilateral, shallow angles. So that is one entity. You can have, in the chronic cases, you can have peripheral anterior synechia causing damage to the trabecular network. So that's a different entity altogether. So the chronic glaucomas due to uveitis over long time. The misleading diagnosis would be, apart from viral, as I mentioned to you, VKH, and another misleading diagnosis would be in the case of course, steroid responders, and very, very rare, that's why I'm leading to the last, is we have bilateral acute iris pigment dispersion syndrome. That's BARDI, that's a mnemonic for them. So that is very rare entity, that can be bilateral. So there's iris trans illumination defects or massive pigment dispersion occurring due to sort of an idiosyncratic response to either maybe a febrile illness or drugs such as ciprofloxacin. So that is about the differential diagnosis.
And
Good afternoon, ma'am. This
is a case of posterior panuveitis, I can say, like VKH or sympathetic ophthalmia, where we don't have any posterior signs, but we do see a lot of anterior uveitic reactions. So you think those cases are undertreated and you would advise to increase the immunosuppression, or do we treat it as just anterior uveitis?
No, all cases of both VKH and sympathetic ophthalmia, the putative target organ is the melanocyte. So it's just because that the melanocytes in the choroid have now got exhausted. Now the inflammation has moved anterior. So except for the mildest of cases, definitely all patients, you need to start them again on oral therapy. Topical alone is not adequate.
Thank you.
Good afternoon, ma'am. This is Dr. Pawan. In cases of anterior uveitis, patients who are not steroid responders, and how many patients would you consider a posterior subtenance injection?
Anterior
would you consider? Yeah.
Hardly ever. So I wouldn't say so, except for the anterior uveitis where there's chronic cystoid macular edema. So there's macular edema, then yes, then my indication goes. That's one of the classical indications for posterior subtenance. And otherwise, just anterior uveitis like HLA-D27 and so on, without any other complication due to chronic inflammation, I wouldn't give posterior supplement. They should respond to topical therapy.
Okay. Thank you.
One last question from me. Are you treating VKH and other conditions with intravitreal steroid implants, ma'am? Not giving systemic immunosuppressants?
That would be an exception, and we do it only for some reason, like say pregnancy intolerance or something like that. But conventionally, we go with the treatment that is sort of protocol based. So the guidelines for therapy are oral, because again, it's a systemically derived immune. So the antigen is now just not the eye. We also, if you remember, we have hearing changes, we have skin changes. So it's a systemic driven disease. So that is the reason why to give systemic therapy.
Okay. Thank you. Thank you very much, ma'am. Let's move on to the next topic by Dr. Gopal Pillai. Gopal?
I don't see him in the group.
Okay, sir. Gopal is not there.
I don't see him. Participants.
I'll call him. Before that, can you take your talk on Whitefield angiography and Whitefield imaging?
Okay, sure.
Okay, sir. You carry on. I'll confirm with Gopal. Sir.
Yeah.
Okay. Sir.
So good afternoon, friends, and thank you, Andhra Pradesh Ophthalmic Society, for this wonderful opportunity once more back amongst the most simple people of our country and a very loving people. Of course, I am also contesting for the post of chairman ARC. I'm going to be sweeter otherwise also. So back to my topic, I would be speaking on value of Whitefield imaging, call it a FFA, ICG, and OCT. Yeah. So these are the classical applications which we are all aware, where we use the imaging modalities to suspect, diagnose, investigate, confirm, treat. But more important is documentation for the reasons which I mentioned on the right side of the slide. These are the uses where we use. Well, so what is the difference between the Whitefield and standard is that you remember in a conventional photography, we view in a single view about 30 to 45 degrees. And by using a ETDRS 7-field chart, you can reach up to 75 degrees of the retina. But the thing is, we need to remember aura to aura ceratite is almost 220 degrees of retina. So that means practically we are not visualizing the 2/3 of the retina, and we are basing our diagnosis and thereby the management on 1/3 of the seen retina. And that's why the need to have look beyond the obvious. So these are the ways how we can have. So Whitefield is the place where you see up to 100 degrees, and ultra Whitefield is anything when you see more than 110 degrees. So this is what you see in a single frame on a conventional photograph. This is ETDRS 7-field. So hardly you can reach up to the equator. And this is Whitefield, and this is a ultra Whitefield where you can see aura to aura. These are the commercially available devices. I have no commercial interest in this, though I have with me Mirante by Nidec, which gives us in a single view almost 163 degree. And with the collage, we can see almost 200 to 210 degrees of retina. These are the plus and minus points, the advantages, what are the things. But you need to remember, if it is a SLO based, those are not true images. You have pseudo colors. That is the only limitation, where you cannot visualize the disc and comment on the disc in such SLO based imaging. Now, coming to Whitefield OCT, usually the standard frame width is about 9 to 12 millimeter length, I should say. In a Whitefield, you get up to 16 millimeter, and therefore you have a more panoramic view of a lesion. For example, in a peripheral CSR, you can see not only PED, but the total extent of the field you can see. These are some of the things. Choroidal melanoma, you can visualize at the same time, you can see the fluid. This is one of the cases which I would share with you to show the importance of a Whitefield OCT. She is a mother of a pathologist who presented to us with decreased vision, and you can see a ultra Whitefield photograph. Not only you see a peripheral lesion, that is a PCV, with a fluid percolating into the macular area. And look at the Whitefield OCT. So it is going through the peripheral region and also covering up to the disc, where you can even pick up the fluid. So you get in a single view the whole pathology of the disease. We did an ICG, we treated them with brolucizumab, and this is how we could follow it with a Whitefield OCT, where you can see on subsequent injection of a anti-VEGF, Yeah, we can see the actual document the reduction in the size of a peripheral region, which is not possible with a standard OCT. Now, the commonest indication of using FFA is diabetic retinopathy. Now, let us look at this example of patient who presented to us with a minimal bleed having undergone laser here. This is the older angiograms which the patient was carrying, where hardly you can see information. You see some NVD here, some capillary dropout just adjacent to the main vascular arcades. And here you look at the wide field photograph, you can see that the lasers are not extending up to the posterior vascular arcade. There is a big gap, more than 2 disc diameters. And if you do an ultra wide field angiography for this particular patient, you can see the total dropout. You can realize the dropout is quite extensive. This is the area which is totally devoid of any laser. The dropout is more extensive. And so not only you get an information about the NVD, same way in the left eye, you can see some leak in the periphery as well, which could never be picked up on a standard fundus photograph. So in this case, you need to do a laser not only into the posterior pole. The classic teaching of a post-graduation in our days was that you have to extend the laser marks 2 disc diameter away from the vascular arcade up to the ora serrata. But if you look at this particular photographs, you can see the ischemia extending quite ahead, anterior to the equator. And so it is challenging the whole concept of pathogenesis of diabetic retinopathies or venous occlusions. Now, this is a key, look at some advantages of retinal vein occlusion. Well, this is a standard photograph here. You see a sclerosed vessel and you see ischemia as localized as this. You do a wide field photograph as well as an angiogram where you can see the extent of the CNP areas, and you look at it much more bigger ultra wide field angiography where you can see the total extent. So had we based our treatment on standard photograph, we would have lasered this sector. But here I'm going to extend my lasers right up to this area where I'm marking it with my marker. So this is how a wide field angiography does add to your treatment. Well, this is a young patient who presented, was diagnosed as a case of a cystoid macular edema, was advised anti-VEGF elsewhere where they had done a standard OCT, the fold. We did a wide field OCT, and the moment we did a wide field OCT, we could see the sciatic cavities extending much more beyond. So it was no longer a case of macular edema, but it was a case of schisis as well, retinoschisis with a cystic edema in the center. And while the patient was complaining significant about the loss of vision, which was not explicable in a chronic degenerative diseases. He had recent onset of loss of vision. So we decided to do an angiogram for him. And this is what we saw on an ultra wide field angiography. So we could see telangiectatic vessels in the periphery as well as the leak in the periphery center, which could explain that there was the vascular component. That is what we call this vascular component was adding further to the leakage in this. So this was a vascular response in a case of a retinoschisis. So it did need an anti-VEGF, but with a better understanding that we also did a targeted laser this area that helped us in recovering and preventing further loss because of the superimposed macular vascular response, which was happening in a case of a retinoschisis. So how it changed my way of looking at changed my diagnosis, changed my management. Now, this is a case of, this patient presented to us as a partial RD, was advised retinal detachment surgery. Yes, fine, you see a detachment over here, but there was some fibrous tissue I thought I am seeing. When we did a photograph for the other eye, we also thought we are seeing some fibrous tissue here. We do an angiogram. So it's no longer just a detachment, but it is a case of a FEVR with retinal detachment in both the eyes. More importantly, because of this wide field angiogram, we treated the better eye first, which was innocuous, which was not having any symptomatology and could avert a imminent disaster in the form of a bleed or a detachment as it had happened in the left eye. Naturally, the left eye underwent a surgery with a vitrectomy after having dissected the tissue here and properly managed. Now, this is 52 years old female who had floaters in for 8 days and was advised a vitrectomy for epiretinal membrane based on this. But we thought there is a drag in the vascular arcade. This is what a panoramic total view of the fundus photograph. We could feel that the vessel, inferior vessel, is being straightened. And so exactly, again, our diagnosis changed and we did an FEVR with VMP. You can pick up sometimes a Ozurdex implant, which was put to tackle the macular edema associated here. Now, this is 48 years old male who presented with this. He was diagnosed as a Roth spot. Well, fine, we decided to do an angiogram. You can see wide field photograph. You can see multiple sclerosed vessels beyond the equator, total shutdown of the periphery. And this is in the both eyes. You can, and so the disease was bilateral. And when we investigated him systemically, he had a carotid disease bilaterally, which needed more definitive management beyond the treatment of eyes. Another case, this is a patient who was diagnosed to have lamellar macular hole. And we looked at it, we thought we are seeing a lot of sclerosed vessel. And this is what we see, a half zone disease. Half zone disease, we usually use the terminology in cases of ROP. Well, this is a shutdown leading to almost half zone disease in one of the eyes. Again, pointing towards some systemic disease. So this is how you can have a look at it. Now, this is a case of a choroiditis, heel choroiditis, complaining of progressive loss of vision with this photographs and the color photo and the angio, they said, which was not contributory to the reason for visual loss. We decided to do an angiogram and we thought we are seeing the in the anterior, we could see the peripheral dropout. We treated him with laser and the edema came down. Another case, 48 years male, systemically stable. He had a vitreous hemorrhage here, and we secondary to choroiditis, and look at the vascular response in a post-choroiditis case. You can see the shutdown in the extreme periphery. All the vascular abnormalities you are seeing is much anterior to the equator. So this is how wide field angiogram makes you think differently even in a routine cases. And we did a sectorial peripheral barrage, I should say peripheral laser in the peripheral region where there was a shutdown, and we could prevent the further bleeds. Now, this is 25 years female diagnosed elsewhere as Hill's disease with combined RD and was advised vitreous surgery. Well, this is the fundus as presentation. Well, it is a vascular retinopathy, we accept. But when we looked at the left eye fundus photograph, we thought we are seeing something abnormal. Well, this is the classic pruning of the blood vessels. We decided to do an angiogram, and you see this is a classic case of a Takayasu's disease with peripheral pruning. This was, in fact, a cover page of Ophthalmology journal last year. So this is our contribution. So this is how the peripheral and wide field angiography helps you. Another case, this patient, female, had a tricycle eye in the right eye following VR surgery. Father operated for glomus jugulare, grandfather operated for some brain tumor, details not available. So this is what we see. Well, almost to even to the best of the eyes, VR surgeons, we thought we are seeing better. But this history, the three things made me something, I thought I should investigate this girl. We did a wide field angiogram, and a wide field angiogram, we could pick up small vascular tumors in extreme periphery, which we cannot again pick up on a standard angiogram because those areas are unseen in a standard fundus photograph. Well, we treated her with LIO, triple freestyle, and this is the post-treatment. Father, we invited him. We thought we are seeing something bad. We did an angiogram for him. Again, he had a angiomas. Her brother was also asked to see us, and he also had multiple angiomas. We treated him. And after treatment, again, a year later, we did an angiogram for the guy. He had a recurrences and some new lesions, which needed further treatment. We did, of course, the genetic study, and we could establish it. But what we learned from these three cases, one family, is that wide field FFA helped us in picking up the disease in all the three asymptomatic family members. And importantly, wide field FFA should be repeated in such cases at a yearly interval to pick up the new lesions and treat them adequately. Well, this is another case of a VKH where you can see multiple lesion blisters in a single go, and a standard OCT, wide field OCTs where you can see an angiogram where you can pick up the lesions. I will just run through this presentation for want of time. Another case of blisters, which came as a cover page. And well, this is a patient who complained of night blindness with sudden loss of vision, diagnosed elsewhere as a CRAO, case of CRAO. Yes, of course, it was a CRAO, but on wide field angiogram completed the diagnosis. He, of course, had retinitis pigmentosa in both the eyes. This 1-month-old baby diagnosed as ROP. We could do a photograph for him. In a single go, you can see not only the lesions, but seedlings in the vitreous cavity, the case of retinoblastoma. Another triad of leukemia where you rarely see a combination of metastasis, infiltration, growth spot. was a cover page of Eye Journal last year, our contribution. So this is how, this is our, yes, there are certain patients who are reluctant. This patient, young guy, had a blunt trauma from a ball, and he was diagnosed as Berlin's edema. We did an angio color photo, and we could see an horseshoe tear. Of course, we had picked him on an indirect ophthalmoscopy, but he was not accepting that he had a horseshoe tear. The moment we showed him a wide field photograph and we could show him the horseshoe tear, he was ready to get treated properly. Another case of a detachment, which again you will see, you can pick up the lattice with a horseshoe tear at one of its edges, multiple other lattices. This is how it helps you in convincing the patient. Again, the same case story here. It's a massive bullous detachment with a lattice degenerations. Even other are having multiple lattice degenerations, which you could show the patient and treat him prophylactically the best eye. Now, this is another case of a decompression retinopathy. Yes, fine. These are all SLO-based images, not true color. But with this particular system, because of the 4 lasers, they are almost near to a true normal. And conversion from 3D surface to is still a challenge in retinal imaging. But be it, it's one of the ways to look at the retina, because if you see full of the retina, your diagnosis, your way of looking at the disease as well as treatment is going to change. And these are some of the contributions from our group from this wide field angiograms in last 1.5 years. Thank you, everyone.
That's a wonderful series of cases, sir. Like textbook, typical textbook pictures would be published in any textbook. Sir,
now, they are all cover pages. They are all cover pages already published.
You use, sir, that system? Which wide field imaging system?
That is a Mirante by, it's a SLO-based multimodal imaging by Nidec.
Okay, Nidec.
Even Ajay now has it.
Yeah, we have it for last almost 6-7 months.
Okay.
We are looking forward to following the footsteps of Bhavan Kule and getting some cover pages.
Yeah, rest of the cover pages by your images. That was wonderful, wonderful depiction of cases, sir. Peripheral diseases, especially the angiomas, especially. We will miss even in clinical examination. Also, we might miss those angiomas.
Very true. Very true.
Any question from panelists? Any opinion? Rajesh, Lohit, Neha.
Sir, after seeing the wide field imaging, I think we can use it as a screening tool for diagnosing who is having a family history or previous history diagnosed with paraneoplastic syndromes.
Yeah.
It will be a screening tool.
Not only screening tool, it changes the way you look at it. As I said, the conventional teaching in a diabetic retinopathy is to extend your pan-retinal photocoagulation up to the equator. Now we are seeing in all vascular retinopathies, the ischemia is not restricted by the equator. It extends quite anteriorly. And so is the need to treat even beyond the equator. So in previous things, when we studied, the only way was to treat up to equator. If there is a further recurrent bleeds, then we would extend the beyond anterior to the equator up to the ora serrata. So, but this now establishes why we used to treat the anterior to equator, because this is not a posterior pole disease necessarily. It is extending up to the equator. So
no, I'll just make a point if I'm audible.
Yeah.
Yes.
Yeah. So what we have found out is that whenever we operate a lot of these diabetics and other patients, many times you have recurrent bleeds. So if you go, so we started doing a wide field angiography in all these patients. And whenever we do that, we find that despite having done a lot of lasers, still we have not covered the entire area. And we may find a neovascularization in the periphery, which we would have otherwise missed. So once we have started covering them, the incidence of recurrent bleeds have reduced.
That's correct, sir. Even while doing PRP, it will be a good guide to direct our laser marks to the non-perfusion areas.
Correct.
If any non-perfusion areas, get good coverage.
Large areas of CNP, and if you direct it to those areas, so then it becomes very specific and useful.
Yeah, sir. That's a nice talk, sir.
Thank you.
Move on to the next talk by Dr. Piyush Bansal.
Yeah, every anterior segment surgeon will have some complications. So we need a backup. So here we have a VR surgeon who will give us a guidance how we should go about when we have complications. Welcome you, sir, Dr. Piyush Bansal.
We'll just take a leave because I'm in a meeting at NN. I'm sorry. Thank you once more. Chandramohan, thank you.
Yes, sir. Have a nice time.
Thank you.
Very good afternoon, sir. Am I audible?
Yeah, yes, sir.
Yes.
First of all, I would like to express my thanks to Dr. Gopal Raju Garu and Dr. Madhu Garu and to the esteemed members of Andhra Pradesh Ophthalmic Society. It's especially nice to be here because Andhra is where I learned the most, if not all, of my vitreoretinal training as well as my ophthalmology. So having worked in Hyderabad, in Vizag, in Nellore, Kandakur district. So Andhra holds a very close place in my heart. What I'll be speaking about is just some case scenarios where we, as retinal surgeons, can come to the rescue of our anterior segment colleagues when they are having a difficulty in the OR and they have inadvertent falls. So, is my screen visible?
Yeah, yes, sir.
So thank you. The first case is of a nucleus drop, as you can see over here. So after there's a lot of corneal edema. So after making a scleral tunnel and then clearing off the edematous cornea, the epithelium, the next step would be to go in and make entries with the trocar cannulas, 23 gauge, as you can see over here. Now you can see the fallen nucleus pieces over here. So what is important for the newer people would be to first clear off all the vitreous around the nucleus before even inducing a PVD, and perhaps not to chase the nuclear pieces and then gradually start removing them with the cutter itself. As you can see over here, it was possible to remove them with the cutter. After the entire nucleus is removed, depending on the kind of capsular support that you have, you can decide on the IOL. Like in this particular case, you saw that since the capsular support was there, a 3-piece IOL was implanted. The second case would be of a nucleus as well as an IOL drop, a complete nightmare for the surgeon. And obviously, it's very important that the surgeon does not keep chasing behind the pieces and makes a referral in time. So again, it's important that, if you're using a cutter, as you can see over here, to remove the nucleus piece, you can obviously clear off all the vitreous around the nuclear piece. However, if it's a harder nucleus and one wants to remove it with the phacophragnetome, then in that situation, it's important to first clear off the vitreous and only then taking the fragmentome. Otherwise, one is going to cause inadvertent traction. Following this, the IOL is also lifted up using a forceps. One can use different methods of bringing the IOL up. As you can see over here, once the forceps has a good grip over the optic, it's important to hold the optic as much as possible and then bring it into the anterior chamber, following which it can be removed depending on the size of the incision. If the incision size is bigger, you can just pull it out or you can cut the IOL as well. Now, again, a different way of rehabilitating this patient as compared to the previous one. Since there's no capsular support, decide to put in a scleral fixated intraocular lens. As you can see that this particular lens has eyelets. So you after making scleral flaps and using the railroad technique of taking taking the Foley suture out through the scleral flap, under the scleral flap, and then going through the eyelets of the lens, and then tightening the lens and rehabilitating the patient. A slightly different technique of removing the IOL over here. You can use suction from the vitreous cutter itself, and then using that bring the IOL up. If you have difficulty, you can obviously use BFCL also, and then hold the haptic or the optic with the other instrument, the forceps in this case, and then gradually bring it up into the anterior chamber. Then move on to another instrument so that you can grasp the lens firmly. It's important to grasp the lens firmly so that you don't drop the lens again into the vitreous cavity. Slightly different one over, you can see that the capsular bag is also, the IOL has fallen along with the capsular bag. So it might be a tad difficult over here. So again, one can also use another source of illumination, a chandelier illumination over here, so that one can use a bimanual technique to bring the IOL up with more ease, and then you can gently pull the IOL out. Now, this particular case, I just wanted to show because it's a slightly different one. So in cases where you have, say, for example, you want to salvage conjunctiva in cases of glaucoma or any such cases, and you don't want to make too many ports or too many entries into the sclera or damage the conjunctiva, then in such situations, you can do this simple modification. So what you see over here is an entry being made into the infusion line. Now this would be a 25 gauge entry, and then using the chandelier, you can push the chandelier through the 23 gauge port, infusion cannula. It quite easily goes into it, and this will give you a kind of a double illumination as well as infusion from the same port. So both the actions are happening to the same port, and then you can go ahead and do your vitrectomy, clear off all the vitreous around the lens, make sure that the lens is the IOL is free, and then instead of making a separate Parspena vitrectomy port, you can go in through the underneath the scleral flap. As you can see, the haptic was broken away, and we pulled it out, and then going through the other side, just hold on to the lens without making an extra port. And once you have the IOL in the anterior vitreous, now similar to cutting the lens in the anterior chamber, what is being done over here is using a retinal scissor. You're cutting the IOL in the anterior vitreous cavity. This can be a little tricky because again the plane is slightly different. It does not have that support from behind, and you see that it's a slightly slower process, because obviously the scissor is a micro scissor, so it is taking more time to cut the lens. But we want to try it out and see if we can cut it in the anterior vitreous cavity itself, so that we can remove it through a small, same 2.8 mm clear corneal incision. And then you can see that it's being pulled out from the same incision that was revised, so that we didn't have to make a separate enlarge the incision or make a conjunctival opening. And after this is done, it's obviously important to check the periphery in all of these cases. Complete vitrectomy base shaving is an option that there is a lot of difference of opinion over there. Now, what is being done over here is since there's no capsular support, decide to do a glued IOL. So slight modification also over here as well. So obviously hold in the haptic of the 3-piece, bring it out, exteriorize it from one end, and then exteriorize it from the other end, make a scleral groove. And after making the scleral groove, the haptic of the IOL is then gently tucked. Now, some surgeons also like to cut some part of the IOL. There are different modifications, even modifications to Yamane's technique. And after that, put in some glue and stick the scleral flap. Obviously, you can also cauterize it, but then there are cases of exposure that are also reported with such situation. Now, another video I did want to add into this was the case that I did yesterday, when after the IOL was removed, I implanted an iris claw, but unfortunately I couldn't add the video in time. So thank you very much for your kind attention. And if deemed worthy, I would request all of you fine surgeons to please consider me for a member scientific committee if deserved. Thank you.
Yeah, thank you, sir. It was a nice talk. I think Dr. Gopal is back.
Yes, sir.
Yeah, Gopal, yeah.
Yes, sir. Yes, sir.
Any doubts regarding this last topic? Anyone, any panelist want to comment? Or...
Hi, sir. This is Rajesh. Sir, excellent presentation. Sir, just one question. If the iris is good, and what would be your to-go lens you want? You will prefer an iris claw or a scleral fixated IOL?
So, that's an excellent question, Rajesh sir. So these days I hardly use scleral fixated lenses, especially the ones with the sutures. I would, if the iris is good, I would definitely consider the iris claw lens. They're quite robust in their fixation. It's in fact very difficult to remove. I had to struggle when I wanted to remove an iris claw in one particular endophthalmitis case. So again, iris claws are very good option. That is the reason that I wanted to show that video, but unfortunately I couldn't manage to add it in time. There's another implant that I'm quite eager to use, the CT Flex by one of our colleagues, Dr. Nivian in Tamil Nadu. So I believe those lenses are also quite robust and comparatively easier to use. So I'm quite looking forward to use those as well.
Yeah, thank you. Any more doubts?
Yeah, we can move on to the next talk, Chinlakshmi sir.
Yeah.
Gopal.
Diabetic retinopathy is one of the leading cause of blindness right now, which is preventable, and a lot of changes have been happening. Let us hear from Dr. Gopal Pillai. What is the new and regarding diabetic retinopathy? Yes, over to you, Dr. Gopal.
Thank you very much, sir. Can you see my screen?
Yeah.
Okay. Thank you very much, sir. And I deeply thank the Lakshmaya sir, Gopal Raju sir, and all of you to have given me this opportunity. So basically, there are a lot of things which are happening in diabetic retinopathy. And we know that our population of 1.4 billion has about 150 million people who are diabetics. And each year, the number of people who are actually getting diabetic retinopathy is increasing. Currently, the age of the diabetic population in India is also on the rise. And very soon we will reach a stage where, currently about 1/3 people with diabetes have diabetic retinopathy. We will reach a stage where half of the people, or maybe 2/3 of the people with diabetes have diabetic retinopathy, because the average age of a diabetic and the average diabetic age are keeping on increasing. So for our country, this is a major challenge that we are going to face in the next maybe 10 to 15 years. And so I will basically show in this particular presentation what we have tried to do, our bit in trying to improvise, trying to bring in technology or science from the bench to the bedside as to what is possible in diabetic retinopathy. So currently we know that good tight metabolic control, laser, anti-VEGF and steroids, and vitreous surgery are the three major things that we can do in the management of diabetic retinopathy. And these are some of those things. And our Chancellor, Mata Amritananda Mai, what she says is, if you build large hospitals, you can touch about 10,000 lives or 15,000 lives or 20,000 lives. But if you make cutting edge research, you can touch, millions or more lives. So basically we need to all audit our results so that we know how we are, and we should know how big is the community problem, and research to make things cheaper yet with good quality, and how to increase predictability regarding results or predictability regarding prognosis. And in India, generally, we have not been doing a lot of etiopathogenetic study because it is very expensive. And can we do some things to prevent the disease, and counseling tools? These are some of the needs of the hour. And so, clinical and surgical audits are definitely all of us are doing, because we are all surgeons and physicians. Epidemiological research, basic biological research, drug development, drug delivery research, equipments and machines, and artificial intelligence. These are the things that we require in diabetic retinopathy. So let us just go into some of my studies, whatever we have done in this particular regard. So here is a proteomics and molecular study in proliferative diabetic retinopathy and in diabetic macular edema. Here we took aqueous samples when we injected, and we stored in -70. And this was like what is happening to the patients whom we are injecting for diabetic macular edema. How many people are responders? How many people are non-responders? Can we pick up the non-responders early? Currently, after 3 or 4 or 5 injections, we would say that if the edema is not reducing, we will label them as non-responders. Can we pick them up in the first injection itself? That was the question that I asked. So is it that the VEGF is not reducing? Is that the reason why they are non-responders? And so how should we do? So what I did was I took in about 40 patients of diabetic macular edema and gave intravitreal ranibizumab injections. 1, 2, 3, and 6th injection were mandatory. The 4th and the 5th injections were, PRN. Like if there was macular edema, I would give. If there is no macular edema, I would not give. This was all the 40 patients. And VEGF levels were measured using ELISA, and OCT and vision was taken each month, and statistical analysis was done. The study was funded by the global Novartis. It was a competitive grant which I had won. And then we looked at ELISA through VEGF through ELISA test. All right. And all the, patients with baseline VEGF was looked at, and we categorized them into 3 groups. one group had a baseline VEGF of 150 to 600, 600 to 1750, and above 1750. Can you see the difference? Lower VEGF levels, less than 1000, behaved almost similar. But the very high VEGF levels behaved completely differently. The moment I stopped injection, you can see that it increased significantly like that. And even the best corrector, this is a logmark visual acuity. So it is showing improvement, but much different from the other two areas of VEGF. So there is a group of patients with very high VEGF levels, which behave differently from the other. Now I try to differentiate between responders and non-responders. Responders are defined as people who have normal macular thickness in 6 months, or reduce more than 40% after the first 3 injections, which are mandatory, or only 4 injections were required in 6 months. If all the 3 criteria were met, then I call them good responder. If all the 3 criteria were not met, then I said it is poor responder. And then what we did was we looked at VEGF in the good responder and the non-responder. I'll just go into it. The red is a non-responder. You can see the change in the visual acuity here over 6 months. And you can see here that at the 6th month, the responder patient, the green is the responder patient, the VEGF levels was high. Why was the VEGF levels high? Because the responder did not get the 4th and the 5th month injection. So the VEGF actually increased. And what about the non-responder? The non-responder's VEGF level was much lower as compared to the baseline because they got the 4th and the 5th injection. So we understand from this simple thing that, non-responders become non-responders, not because VEGF is not reducing, but because of some other players. So now we should find out what are the other players. So for that, we did 2-dimensional gel electrophoresis and found out the difference in proteomics between responders on the one hand and non-responders on the other hand. So these 5 proteins which are there, if you find them out in the aqueous on the first visit, you can actually pick up a non-responder. So that's a very good idea. Like you don't have to wait for 3 or 4 or 5 months to pick up a non-responder. Immediately on the first go, you can just get a drop of aqueous and put a point of care test, just like a urine pregnancy test, and get your non-responder ready. Then we looked at other proteomic factors, so that we did cytokine bead analysis, and we found out that these were the interleukins and the cytokines which are significantly problematic in the non-responders. You can see that the orange here is a non-responder. IL-6 in non-responders are much higher as compared to the responders. IL-8 in non-responders are much higher. Just like that, MCP1, the monocyte chemotactic protein 1, that's also much higher in the aqueous in the non-responder as compared to the responder. So this is again another biomarker which we can use, day 1 of injection to pick up a non-responder. All right. So these articles are published, and then I also looked at OCT biomarkers and its correlation with the aqueous cytokine biomarkers that we looked at. These were the characteristics that we looked. Now look at IL-6 levels. Cystoid versus spongy. In spongy, the IL-6 levels are 3 times. ISOS junction, if it is disrupted, it's about twice. And if there is a drill, it's about 8 or 9 times higher, the IL-6 as compared to when drill is absent. Similarly, IL-8 level in spongy, it is about double. If it is disrupted, it is lower. And if number of high reflective spots are more than 10, it is half. And hard exudates, if they are present, it is half. So IL-8 is a protective type of a cytokine. So, and this is dexamethasone study in which we looked at it. And then we looked into mass spectrometer, mass spectroscopy to pick up proteins. I found out that there were about 50 proteins in which in vitreous hemorrhage, they are in 1,000 times higher concentration than pure traction retinal detachment. And there are about 50 proteins which are about 1,000 times in higher concentration in TRD than vitreous hemorrhage. Now, how will this be used? In a patient with proliferative diabetic retinopathy, we do not know whether this patient is going to take the route of a vitreous hemorrhage or a traction retinal detachment. If I can use this biomarker, I can predict which PDR patient will move to traction retinal detachment, which PDR patient will move to vitreous hemorrhage. That would be very nice. So these are the use of biomarkers. Now let us move forward from this and look at another thing. This is about developing a new molecular target. It's a glial cell study where what we did was we had Muller cell culture and astrocyte culture, and we overlaid proliferative diabetic retinopathy vitreous on top of it. and we incubated for 4 days and looked at which are the new proteins which are formed because of interaction between these Muller cells and astrocytes, along with the proliferative diabetic retinopathy. Why did we take Muller cells and astrocytes? There are only 3 cell lines in retina: Muller cell line, astrocyte cell line, and glial cell line. So we took 2 of those, and we found out that one protein called GMF-beta is significantly expressing higher whenever these cultures were challenged with proliferative diabetic retinopathy. Now we have a new molecular target, just like VEGF, which can be targeted. So in which now we have found out an inhibitor to that, and that is what we are going to try now in animal experiments. Now in animal, the rat retina is almost 97% homologous to the human retina. And so we did all those studies. And this is again another thing. Now there is a recent study which is published in the Eye, which told us that if you used dexamethasone implant with ranibizumab, there was a 20-letter improvement in those patients. And as compared to probably 10-letter improvement, which is maximum, 10 or 12-letter improvement, which you get with monotherapy of ranibizumab or aflibercept. So this one, what we did was, we have a nano cover, and we combined the dexamethasone and anti-VEGF into a nano cover. The thickness of the nano cover determines when it will be released into the vitreous. So we have a combination nano drug delivery, which is subconjunctival, which can be sequentially delivered into the eye without an intravitreal injection. And the next stage to this would be a gel formulation. So here is a case in which the thickness of the nano cover will determine at what time that you want to have the drug delivery. So if you want to have, in the first month anti-VEGF, you can put small nano cover to it. And if you want to have the second month dexamethasone to be delivered, you can put a thicker nano cover, which will disrupt after 1 month. So that is how this particular thing goes. And this is proof of concept to say that, transclerally in goat size, you can have transcleral passage of these nanoparticles. And this is fluorescent study, which shows that proof of concept that it goes inside. And then the next idea is, not with an injection, just with an OCU-CERT. So here is a candidate drug that I used, which is called sirolimus, a tyrosine kinase inhibitor, otherwise called rapamycin. And what I showed is that, we made a nanomicellar formulation. And this nanomicellar formulation, I studied the physicochemical properties of that. This is the scanning electron microscopic images, etc. And then moved into, making it into an, micellus, and then added an OCU-CERT platform to it. And we looked at the delivery of the drug inside the eye and all the chemical properties of the OCU-CERT. And now this OCU-CERT, this is like a very, very tiny thing. These are microscopic images, the transmission electron microscopy. And we found out that it would, one particular group, 03, would be there for 80 hours. So which means that once in 3 days, you need to replace that OCU-CERT in our fornix. Now, further studies, actually, I'm not going into the details of it, but it showed that it is significantly effective. And the side effect profile was also noted in chorioallantoic membrane, etc. So this is a complete ex vivo study, which is going into an animal study now. Then coming on to diabetic retinopathy. Now, the next thing is about screening, universal screening methodology. So can a non-mydriatic camera, if you are using door to door, can it pick up diabetic retinopathy, at least vision-threatening diabetic retinopathy? We found out that after all this data, we found out that about vision-threatening diabetic retinopathy, if you dilate and examine versus if you take a non-mydriatic fundus photography, almost there is no statistical difference between them. But mild and moderate and all, you may miss with non-mydriatic fundus photography. But vision-threatening diabetic retinopathy, you are not going to miss. Then comes artificial intelligence. How can we apply this non-mydriatic photography into an artificial intelligence? So this particular study was about using 2-dimensional images to develop a 3-dimensional image and finding out the F-score in that particular. Then our F-score was much higher than a lot of other studies. And this is about automated detection of microaneurysms, hard exudates, characterization of hard exudates, and how we can score based on that. All the microaneurysms need not be lasered. Only the leaking microaneurysms need to be lasered. And currently, we are not scoring the hard exudates. We are only looking at macular thickness. And if the macular thickness is high, we will inject. If the hard exudate score is also an important treatment paradigm. And so we looked at how to measure that area of exudates, number of regions, the thickness of the exudates, the count of exudates, the area, the distance from the center, all that was calculated. Now, this is a small AI tool which we made to actually look at, this is no diabetic retinopathy. To the 100th image would be the maximum diabetic retinopathy. Now we added to it all the systemic parameters like hemoglobin A1C, serum cholesterol, we can add all them. Renal involvement, smoking years, diabetic duration, what is a stroke or heart attack was there, good follow-up he will do or not, and then look at what is a present image versus 10 years later image, current and future retinal image. This is a good counseling tool for prediction for that particular patient. Now, if he knows that if he can control his hemoglobin A1C and stop smoking, and if the second image is better, that's a great counseling tool. So, my dear friends, these are some of the new thought processes that is there, that is in store in diabetic retinopathy. But these are things that will come in the future, and this will be converting whatever epidemiological problem that we have into something that we can try to solve. Thank you very much, sir. Thank you very much. I would also like to thank Lakshmaya sir and Gopal Raju sir and all of you who have heard my presentation. Thank you very much.
Gopal, that was wonderful. That's another avatar of you I have seen for the first time. Research so much. Huh? Wonderful research points that you have took. The first thing is that non-responder thing, which can be found out even before starting anti-VEGF, or where we have to give a combination of drug, VEGF and steroid. These two are two wonderful things. If it is applied, hope it will come into use soon by the research that you're doing, and we will all be very benefit from that. And also to say the patient that 10 years down the stream your eye is going to look like this is a wonderful thing of counseling. So he will understand, and he will try to reduce his risk factors also. 1, 2, 3 risk factors he will reduce. And this wonderful research that is being carried out. I congratulate you, Gopal. So any of the panel,
may I also take this small opportunity to request everybody that I am also standing for member scientific committee. Sorry for doing that, and welcome each and every one of you to AIOC Kochi.
Yes.
Directly contact me if there are any problems, please.
Yes.
Gopal,
good afternoon.
Yes, sir.
Gopal, one query. Actually, you had showed one 10 years after with all the inputs. Can you show with the same thing? Suppose he has some smoking, alcohol, obesity. Yeah. With all these features, you have this adjusted picture. Yeah. Okay, second picture, if you control all this, how it would like to?
It's like an LIC premium calculator, sir. So you reduce your hemoglobin A1C from 12 to 6, and your cholesterol level you bring down. Your renal parameters, you say that you will get under control. Cannot, but then you will stop smoking. You will show ophthalmologist regularly. That second image will keep on getting better and better and better. And now the next part of this particular AI predictive model is to incorporate what the patient sees, because a retinal image patient cannot understand much. We can understand better. But how are you going to see? That from 0 to 100, if I am basically plotting, that's the next stage that we are going to do. Sir.
Okay. Is it available? Is it you are getting that AI model?
Yeah, I'm getting it onto the the Play Store, sir. In about 3 months, it will be ready to go into the Play Store.
Wonderful. That's great.
So can I add 1 or 2 points which Gopal, we've been working with Gopal with part of AIOS. Hi, Gopal. This is Dr. Ajay.
Hi, sir.
Hi, how are you?
Yeah,
so we have also been looking at, finding out of the entire population of India who will have vision-threatening diabetic retinopathy, because to screen all of them is almost impossible. So if we can have criteria for setting up vision-threatening diabetic retinopathy, then we can direct our resources to the patients who are likely to develop vision-threatening diabetic retinopathy, and then we can, treat them. Another point I wanted to bring out was that if you look at what was predicted for diabetic retinopathy after 20 years of diabetic retinopathy, 60% will have some changes. But in India, a lot of people do yoga, do a lot of, various things they do. Even 30, 35 years old diabetic do not have changes of diabetic retinopathy as predicted by the Western literature. So there's something different happening which we don't understand. I think that is where Gopal's work is going to help us a lot.
Yes.
Yeah, I think excellent talk, sir. You really took us into the future. And thank you, sir. Thank you, Gopal, sir.
Past 2 now, I think we'll wrap up this session.
Yeah. And
Sir, one last doubt, sir.
The practitioner's perspective to Sujata madam and GR Reddy sir to take it forward from here. I thank all the speakers and panelists of the retina sessions to take time on their Sunday. Thank you so much once again for your contributions. Sir.
Thanks a lot. Thank you very much.
Yeah.
Lovely.
Thank you very much.
Yeah. Sujata madam and GR Reddy sir.
Good afternoon, everybody.
Okay, Madhu. How are you, Sujata?
Thank you, sir.
Okay.
Welcome to this Ophthalmology Conclave 2023. Wonderfully organized by our young scientific committee chairman, Dr. Madhu, along with our president, Dr. G.R. Reddy Garu, and our secretary, Dr. Gopal Raju, and our treasurer, Dr. Vishnuvardhan Garu. And very nice one. It's going on. And now we are going to start our session, practitioner's perspective. We'll invite our first speaker, my friend, Dr. Santosh Honavar. I think he's ready with his talk.
Yes, I'm ready, sir.
So he's going to tell about the common oculoplastic surgeries and with video assisted skill transfer technique. So Dr. Santosh, we all know him. So he's going to be our incoming person, and let us hear from him, from his vast experience. Thank you, Dr. Santosh.
Thank you, Sujata. I thank APOS and especially Madhu and Gopal and Dr. Reddy sir for taking initiative to organize this. Am I audible? Is my voice?
Yes.
All right. So I'm going to share my screen. I have a little patchy internet, so I don't know how it will pan out, but let's just try this. Okay, so I was asked to speak on common oculoplasty surgeries which are of use to a general ophthalmologist. I'm going to show you some surgeries. I'm obviously not possible to show all of this, but I'll concentrate on lacrimal surgery, lower lid entropion, and a little bit on congenital ptosis. Now, when you talk about DCR, it is a skill that is actually being, it's going away from the realm of ophthalmologists and getting into the field of ENT surgery because most of the ophthalmologists have stopped doing DCR and are referring it to their ENT colleagues for endonasal surgery. I think that is a trend that has to stop because lacrimal surgery, well performed, has about 95 to 98% success. DCR is extremely successful. It is right next to cataract surgery in terms of its success. So whenever we talk about DCR surgery, generally patients are discouraged because of scar that they anticipate from external DCR. But if you make your incision right along the anterior lacrimal crest, under the level of the medial canthal tendon, about 10 millimeter, 9 millimeter incision, that is hardly ever seen. If you still worry about the scar, then you can make it at the lower eyelid crease right here and make a cutaneous flap and reach the anterior lacrimal crest. Now, the second people worry about is the bleeding. If you look at this picture from Dutton, you'll realize that if you make your incision here, the red line is the anterior lacrimal crest, and this is the medial canthal tendon. You don't have any known blood vessels in that area. This angular vein will come in the cat's paw retractor that you're going to use. Inferior palpebral vein is much higher than the level of the medial canthus. So you are not going to encounter any major known blood vessel if your incision is at the anterior lacrimal crest. Of course, you may have a tributary of a minor blood vessel, a vein or a small artery, or an anomalous course of a known blood vessel, but those are very rare situations. Even if you look at the arterial tree, that in this area, in the anterior lacrimal crest area, there's hardly any blood vessel, and the angular artery is much medial to it. So you're not going to encounter much of bleeding. The second thing people worry about is whether they would cut the medial canthal tendon or not. Well, of course, they are not supposed to cut the medial canthal tendon normally, but if there is a situation where if the nasal bridge is flat, if the patient has had trauma, or if it's a child, or if it's an overhanging anterior lacrimal crest, then visualization may be poor. So in that situation, they can cut the medial canthal tendon partly so right on top of the bone. If they try to cut it on the soft tissue, then you can see that the common canalicus is right under the medial canthal tendon, and that is likely to get injured. Going on to the video itself. My incision is marked by palpating the anterior lacrimal crest. So I'm palpating it using a lens spatula, which is a nice curvilinear instrument. And you can mark your incision with the tip of the spatula itself. You don't have to use an ink to mark if you really don't need it. Then the next step is to make an incision, which is using a Bart Parker knife. This is skin and superficial orbicularis deep. Then orbicularis is split using tenotomy scissors. It's never cut to minimize bleeding. Then the cat's paw retractor gets in, and that actually takes care of the angular vessel. Then orbicularis is further split to approach the periosteum. So once you reflect see the periosteal reflex, you can scrape off whatever residual orbicularis is there with the suction tip itself. You don't have to use any sharp instrument. Then you march towards the anterior lacrimal crest. Once you reach the anterior lacrimal crest, your plane of dissection should be between the periosteum and the bone. Never get between the periosteum and the lacrimal sac, because there is something called perisac plexus of veins, which will irritatingly ooze. You have to continue to dissect this until you reach the junction of the lamina papyrus of ethmoid and the lacrimal bone. When you reach that junction, you'll see a pencil thin line, which you're supposed to fracture using the blunt tip of the periosteal elevator. And from there on, use a lacrimal punch to reach about 10 to 12 millimeter, or at least 8 to 10 millimeter higher than the anterior lacrimal crest. So posterior edge of the ostium is always at the junction of lamina papyrus of ethmoid and the lacrimal bone. Anteriorly, you go higher than the anterior lacrimal crest as much as possible till the approximation of the mucosa to the bone is so tough that you cannot insert the punch. Inferiorly, you have to expose the sac-tuck junction to prevent a complication called Sum syndrome. Superiorly, you have to go 2 millimeter higher than the common internal puncture. Once you're done that, you insert a probe through either upper or lower canalicus. This is for a beginner surgeon. As you get more and more experience, you don't have to do this step. This probe has to be directed to come out at the junction of the medial wall of the sac and the floor of the sac, because you want a large anterior sac flap. So once the probe comes out, probe is coming out now, you can actually visualize the probe. You make a vertical incision starting from the sac duct junction to the fundus of the sac. Mucopurulent material within the sac comes out. Then you make 2 horizontal incisions to open the sac like a book. Basically, you have a large anterior sac flap and a small posterior sac flap. Now, the posterior sac flap, either you suture it or remove it. I tend to remove it because I don't find that it is beneficial. If you suture it, there is hardly any change in the success. So that's the posterior sac flap that I am removing. The next step is to make 2 mucosal cuts. Mucosal cut is made at the inferior edge of the ostium first, and then the superior edge of the ostium. Both these are joined together at about 2/3 depth of the ostium. You don't go deeper than that because the inferior middle turbinate will be right there. The next step is to remove the posterior mucosal flap, and then finally you suture it. When you suture it, I tend to suture it with surface to surface anastomosis. This will give you a lot of leeway, because even if the mucosal flap is thin and flimsy, or the nasal or the lacrimal sac flap is scarred, thin and flimsy, you can still have a very good anastomosis. If you use edge-to-edge anastomosis, there is a chance that the suture may cut through or your flap may break down. So surface-to-surface anastomosis also gives you the advantage that you can tighten it to the extent that the flaps are taut. Otherwise, you may have an overhanging flap, and which means you need to further hitch it to the periosteum. Then, since it's a uniplanar incision, the wound presents itself. There is no need to excessively suture it. 3 or 4 sutures through the orbicularis and 4 to 5 or 6 sutures through the skin, depending on the size of the incision that you have made. Syringing is always done on the table to check for the patency and also reassure the patient that everything is fine. And that is the end of surgery. So next surgery I'm going to show you is involutional entropion. Involutional entropion is a very common problem seen in elderly individuals. As the name indicates, it is age related. Here the problem is with the lower eyelid retractor. Either it is dehiscensed or detached. The second problem is with overriding of the preseptal orbicularis over pretarsal orbicularis. Third is the horizontal laxity of the eyelid. Now, Jones procedure is used in involutional entropion because it corrects two of the three mechanisms. It reattaches or plicates the lower lid retractor. It also creates a plane of scarring in the orbicularis, preventing overriding of the preseptal orbicularis over pretarsal orbicularis. It does not address horizontal laxity. So if a patient has horizontal laxity, Jones procedure can fail. And that is the reason why you should combine it with lateral tarsal strip if there is horizontal laxity. That's the skin orbicular incision that I'm making. The next step is to make a suborbicularis dissection to expose the orbital septum. You only expose the orbital septum and you don't open it. And what you see is the white band, that is the lower lid retractor. This lower lid retractor is exposed and it is held up, and the patient is asked to look up and down. You will feel a tug, confirming that it is indeed the capsulopalpebral head of the inferior rectus muscle. Once you feel the tug, you are ready to suture it. You have to reattach it to the lower edge of the tarsus. You can take two sets of sutures, internal with vicryl, external with skin or silk, or you can take one set of suture to include all the tissues. Here I am doing the one suture technique where I am taking skin orbicularis, detached lower lid retractor, inferior edge of the tarsus, and orbicularis and skin again. So with one suture, you're able to reattach everything back. That is the lateral suture that is being taken. And similarly, we take a medial suture as well. But with the medial suture, you have to be very careful not to overcorrect the medial part of the entropion. If you do that, then the patient will still have epiphora because of eversion of the puncta or medial entropion. That should be avoided at all costs because patients will not then be happy because symptoms continue. Each of these suture is tied with enough tightness to get the correction of your choice. Basically, you should not overcorrect lower lid entropion. It should just be corrected. It has a tendency to overcorrect if you tie your sutures too tight. And that's a problem because patients will have epiphora thereafter. That's the end of entropion surgery. It's a very gratifying surgery because it addresses two of the three mechanisms of involutional entropion. This is preoperative and that's the postoperative appearance. This is one more patient, preoperative and postoperative. You can see correction that is going to remain stable and there's hardly any need for resurgery in Jones procedure. Next, let's go into congenital ptosis. In congenital ptosis, depending on the amount of ptosis and amount of levator action, you decide which surgery to perform. Like a patient who has this mild ptosis of about 2 millimeter and levator action of 8 to 10 millimeter, the first test that you perform would be phenylephrine test. If phenylephrine test is positive, that means after instilling 2.5% phenylephrine in the superior fornix, and after 2 minutes to 5 minutes, if the lid lifts to normal position, at least by 2 millimeter, then the patient qualifies for mullerectomy. It is performed using the mullerectomy clamp, which is described by Putterman. Suppose a patient is phenylephrine test negative. Most of the patients are negative for phenylephrine, especially in congenital ptosis. Then you perform what is called Fastenal-Servet procedure, which is nothing but tarsoconjunctiva mullerectomy. It's performed typically in patients who have 2 millimeter ptosis and about 10 millimeter levator action. The surgery is shown in this video. That's the preoperative appearance of the patient. Surgery is performed under frontal block, which is a sensory block. You invert the lid and mark exactly at the pupillary axis on the edge of the tarsus. Then you pass 3 sutures, one through the middle of the tarsus and one on medial as well as the lateral side through the folded edge of the tarsus. This is to stabilize the tarsus. Next set of sutures come through the superior fornix and exit just short of the eyelid margin. The purpose of these sutures is to secure the conjunctiva, posterior edge of the conjunctiva, so that you can easily suture it. Otherwise, it will retract into the fornix, and for each bite, you have to dig into the fornix, which causes bleeding. Lateral sutures should avoid taking through the palpebral lobe of the lacrimal gland. Otherwise, they may be bleeding during this passage of this suture. Once you pass this sutures, the next step is to measure the amount of resection. As I said, for every millimeter of ptosis, 2 millimeter is the resection. This patient has 2 millimeter ptosis, so we are measuring 4 millimeter and marking it exactly in the pupillary axis. Then you do what is called anemization. You have to do a very light RF cautery in the area of your incision so that there is minimal bleeding. And as you see here, it is tapering towards the medial side and the lateral side, and it is remaining absolutely parallel to the lid margin. This will maintain the normal contour of the eyelid margin. Otherwise, you'll have a distorted contour. Once you make this mark, the next step is to make a thin conjunctival and tarsal groove. This is a very superficial groove that you make in the tarsus. Everything under visualization. Surgery is carried out under operating microscope. So you're very precise during this surgery. Then you deepen the groove to get a gape like that. The gape indicates that we have gone full thickness through the tarsus. Then we lift the lid and excise tarsus and the folded palpebral conjunctiva. So here we are excising 4 millimeter of the tarsus, and on the back is 4 millimeter of palpebral conjunctiva. So it's 4 millimeter of tarsus and 8 millimeter of conjunctiva that we excise in this procedure, Fastenal Savard procedure. Once you excise it, the next step is to suture the edge of the conjunctiva to the edge of the tarsus. For this purpose, we make 2-point marks at the either edge of the lid crease and use a 6-0 plain catgut suture on one end. This knot is buried outside so that it does not irritate the cornea and the conjunctiva. Then the suture is taken in full thickness and it is run in a continuous manner, completely buried. No part of the suture should get exposed, otherwise it will rub on the cornea. If you fear that you're not completely buried, then you should always use a banded contact lens for a week following surgery so that there is no corneal epithelial issue. This is to secure the posterior edge of the wound so that there is no granulation formation. And at the end of the incision, you come back to the anterior surface and complete the suture. This procedure works very well, and most of these patients attain good correction because it is a mathematical procedure. It's highly predictable, and this patient, you can see that the lid crease position also has normalized. This is one more patient with the right eye ptosis. You can see following Fastenal Savard procedure, her lid crease has become normalized. So you really don't have to work on symmetrizing the lid crease. It automatically gets symmetrized with Fastenal Savard procedure. If a patient has much severe ptosis and poorer levator action, then you do levator resection. There are many nomograms for levator resection. This is the Beard's rule, which we hardly ever use because there are too many variables. What we use is the Berkey's rule, which is a very simple rule, which states that for a patient who has 6 to 7 millimeter levator action, you have to correct the ptosis exactly where you want it to be postoperatively. If the levator action is worse, you overcorrect on the table. If the levator action is better, you slightly undercorrect on the table. This is the last surgery I'm going to show. This video shows the procedure of the surgery. We have marked the lid crease already symmetrical with a contralateral eyelid. Then we make a skin orbicularis incision using a monopolar RF electrode, minimizes bleeding, suborbicularis dissection to expose the orbital septum. Change in color from pink to yellow indicates that we are on top of the orbital septum. Then we make suborbicularis dissection to expose the anterior surface of the tarsal plate. That is the process. About 4 millimeter of the anterior surface of the tarsal plate is also exposed because that's exactly where you're going to pass your suture. Once you've done this, you invert the lid on a Demers eyelid retractor and inject subconjunctival xylocaine. That's the Demers coming in. Then we inject subconjunctival xylocaine to create a plane of cleavage between conjunctiva molars and the levator aponeurosis. So once you've done this, levator gets separated from the conjunctiva molars muscle. Then you pass sutures through the levator aponeurosis to have total control over the levator aponeurosis and also vertically tent it up. 3 sutures are passed, which are 4-0 silk sutures through the levator aponeurosis. This is going to help a beginner surgeon, but as you get more and more experience, you can avoid this step. Now we are disinserting the levator. That slope has to become a perfect triangle that completes your disinsertion. You can see that the now slope is getting obliterated and it is assuming the configuration of a triangle, which means that we have gone full thickness through the levator aponeurosis. Once you're sure that you've gone full thickness, you simply peel the levator of conjunctiva using a dry Johnson bud. That is the end of the posterior dissection. When we come back to the anterior surface, open the orbital septum, and what comes out is the pad of fat. This pad of fat has to be retracted using a Demers slit retractor so that you see the anterior surface of the levator. Now that is the Whitnell's ligament that you see there. White band is the Whitnell's ligament. Sutures in this Beard's nomogram, Burki's nomogram are always passed right under the Whitnell's ligament. Horns are very gently cut not to damage the Whitnell's ligament. That's the cutting of the horns. Then we are ready to pass the sutures. We use 6-0 Prolene suture. First suture is passed in the pupillary axis right in the middle of the tarsus, 4 mm from the upper edge of the tarsus generally, and make sure that it is not full thickness. Then it is taken out through the levator aponeurosis right under the Whitnell's ligament. It's a double arm suture. One arm of the suture can be on a free needle. Similarly, medial and lateral sutures are also passed, and each of these sutures is tied with enough tightness to get the correction of your choice. Then the stump of the levator is excised, and we pass what is called a lid crease formation suture, which is nothing but re-establishing the lid fold by suturing orbicularis to the edge of the levator aponeurosis. Skin is not taken in this suture because we don't want a permanent lid crease. This lid crease has to be dynamic. It has to disappear when the patient looks down like a normal lid crease and should start appearing and become more prominent as the patient starts looking up. Final step is to close the skin using 6-0 Prolene suture. This is a running suture that we use so that the scar is minimal. At the end of the surgery, of course, we use a frost suture so that the cornea remains protected. This is a patient who has undergone right eye levator resection. This is again a patient who has undergone right eye levator resection. And that's a patient who has undergone Whitnell's sling. Whitnell's sling is a procedure where we do an internal sling, sling the tarsus to the Whitnell's without cutting the horns of the levator. This works well in primary position, but this will have tremendous lower down gaze lid lag and lag of thalamus. So I think my time is up. Thank you so much. Sujata, if you have any comments or questions, I'll be happy to.
Thank you, Dr. Santosh. One of the best talks recently I heard, and very nicely demonstrated surgically. Even the beginners and non-oculoplasty surgeons also can learn the techniques, and they can easily do such a way you demonstrated. Very nice. And I'm very proud of you. You proved yourself as one of the best teachers of ophthalmic oculoplasty. Thank you very much. My comments are actually in the skin approach. I do almost same procedure. Only thing is the stump of the levator aponeurosis, I don't cut, I leave it like that for natural resolution. Suppose if I require to redo the thing immediate post-op, we can do it because the entire stump is available. That's the only difference I do. The entire technique is almost same I do.
Yeah, same thing taught both of us anyway. So.
Yes, that is something like tucking procedure I do.
Right.
Thank you very much.
Thank you.
Sir, Dr. Reddy, sir.
Dr. Santosh,
yes,
excellent
sir.
talk.
Thank you, sir.
All the residents will be and the practitioners will be benefited from your talk.
Thank you, sir.
Thank you.
Thanks. My next, our next speaker, Dr. Madhu, two of the speakers are not available, you said. So we can proceed with Dr. Manoj or...
Yes, sir. Manoj Mathur, sir, is there.
Dr. Manoj or Dr. Amit Porwal, whosoever is ready, we can...
Manoj, sir, is there, ma'am. He can go ahead.
Yeah. Dr. Manoj?
Yeah. Good afternoon, Sujata.
Thank you very much. Dr. Manoj, also another very good friend of mine. And we worked together at Sadhuram Eye Hospital long back, way back in 1992. And very nice to invite you for this session. Please go ahead, Dr. Manoj.
Thank you, Sujata. Thank you, Gopal. Thank you, Madhu. And thank you, G.R. Reddy, sir, for the invitation. It's my pleasure to be amongst you here today. And I shall be sharing my screen now. So I shall be talking today about treatment philosophy in medical management of glaucoma. Are you able to see my screen?
Yes, sir. Go ahead.
Yeah. So is it a full screen, Madhu?
No, it's not full screen.
Yeah, it's not full screen yet, sir.
Yeah. So good afternoon, everybody. Hope I am visible and hope my presentation is seen full screen now. So I shall be talking to you about the treatment philosophy in medical management of glaucoma. So glaucoma is the second leading cause of irreversible blindness globally. About 12 million people are affected, and 10% of those people blind from the disease. The problem with this disease is 90% of the cases remain undiagnosed. That is the reason why we need to observe the World Glaucoma Week every year and create awareness among the public. And on the other end of the spectrum, there is a problem of overdiagnosis. That is, about 50% of the cases are overdiagnosed. That means how not to miss glaucoma in your clinic. At the same time, how not to overtreat glaucoma is also to be emphasized by way of CMEs like this we are holding today. So let us start from the scratch. The definition of glaucoma. What is it? It is a family of ocular diseases characterized by progressive optic neuropathy and visual field loss. What happens is there is a progressive retinal ganglion cell loss that results in gradual optic disc cupping. And this structural defect is when it is associated with the visual field deficits, and then irrelevated intraocular pressure is no longer included in the definition. So what happens is when there is a structural and functional correlation with the structural defect in the optic disc that leads to suspicion of glaucoma, that has to be correlated clinically, functionally with visual fields, and then a proper diagnosis of glaucoma can be made, and those patients need to be started on treatment. What are the basic medical management in glaucoma? You need to treat differently angle closure glaucoma, which is acute and chronic, and primary open angle glaucoma. Acute angle closure glaucoma has a different paradigm of management where you need to have an osmotic reduction of aqueous, then you have to reduce the formation of aqueous and try to open up the closed angle and then give a supportive therapy. Whereas in chronic angle closure, we can attempt by trying to open up the angle by way of a YAG-PI, especially in appositional closure cases. But the primary medical management of glaucoma revolves around management of POAG. What is the aim of the glaucoma management? It is basically, number one, to prevent the nerve fiber loss. Number two, to prevent any further visual field definition. This is what we have discussed in the definition of glaucoma. And most important, to retain the quality of life for the patient, this is to be given adequate stress. Now, if you see this graph here, there is, as the age advances, there is a normal physiological loss. So if you detect the disease at this point, if you don't treat the disease, it goes down like this into the realm of blindness. The aim of treatment is to skew this curve so as to run parallel to the normal physiological loss. You cannot try to regain the lost vision, and neither can you make the loss of RGC static. The loss is always there, but the aim should be that this loss should run parallel to the normal physiological loss. Then the visual field deterioration, whatever defect has already taken place, the aim should be to let that visual field deficit remain stable and not to increase overtly as much as possible. The quality of life, it is very hard to quantify, but for the patient, it is the most important. The very diagnosis generates anxiety. Don't tell the patient, I think I am suspecting glaucoma in you. Mind you, the patient will never sleep for the rest of his life peacefully. The functional loss due to the disease, they will be embroiled, they'll be Google searching this about the disease, and it will lead to the inconvenience of treatment. For us, it is very simple to say, use 3 drops to 6 drops per day for the rest of your life. How inconvenient it is. The side effect of the treatment, the exposure to the preservatives, and last but not the least, the cost of the treatment. All these things need to be taken into account whenever we are managing a case of glaucoma. And what we can do, we can only, as of now, modify and control IOP. Can we give some sort of a vasoprotection or a neuroprotection? The research is still on. Promising results are being shown, but yet to be conclusively proved. As of now, we can only modify and control the intraocular pressure. So how much target pressure or how much target range we need to decide depends on the amount of glaucoma damage that is detected, the life expectancy of the patient. The baseline intraocular pressure is also important, how much you need to step down the intraocular pressure. Then there are any additional risk factors that need to be taken into account, like family history, diabetes, hypertension, thyroid disorders, long-term use of steroids, frequent change of glasses, and last but not the least, any additional risk factors, the amount of intraocular pressure, that is the primary risk factor, needs to be taken into account, as I have shown here. And over a period of time, the rate of progression can be decided and a target range can be decided. And it is a dynamic range. From periodically time to time, we need to take a call as to what is the best suitable target pressure or a target range for your patient. So can we afford some sort of a neuroprotection and vessel protection? I have said earlier, possible, yes, yet to be conclusively proved. So the ultimate goal, what we have discussed till now, boils down to preservation of visual function adequate to the individual needs with minimal or no side effects for the expected lifetime of the patient. That is, the patient should not go blind without any disruption of his or her normal activities. The patient should be able to carry on with his daily routine at a sustainable cost which the patient can afford. So all these parameters we have discussed about treatment philosophy boils down to this one particular statement issued by the Glaucoma Society guidelines. So how does the anti-glaucoma medication act? Basically, they are inflow reductors or outflow facilitators. Outflow facility can be through the UV scleral outflow as well as the trabecular outflow. The outflow facilitators are prostamides, alpha-2 agonists, cholinergics, prostaglandins, and ROCK inhibitors, whereas inflow reductors are alpha-2 agonists, beta blockers, and carbonic anhydrase inhibitors. What is the aim? So whenever you're assessing an anti-glaucoma medication, it has to be assessed on 3 parameters. Number 1, the efficacy, the ability to modify the intraocular pressure. That is number 2, and the safety profile of that particular anti-glaucoma medication, both ocular as well as systemic, and any additional bonus that particular anti-glaucoma medication is able to afford by way of neuroprotection or vasoperfusion. So the treatment challenges in glaucoma, notwithstanding the anti-glaucoma medication, the patient problems or non-adherence may contribute to suboptimal IOP control, and unfixed combinations of topical therapies increase the schedule complexity and may affect adherence. So the medication washout is also a problem with multiple eye drops. So FDC, that is fixed glaucoma medication combination, can be tried. Like, they afford more convenience, they give improved compliance, they give diminished risk of washout from the second drug administered soon after the first, and that limits the patient's lifetime exposure to BAK. And various studies have shown that FDCs perform better than single bottles, multiple drops over a long period of time for all patients. So if you assess the amount of all the FDCs that were available till recently, all were combined with timolol, pilocarpine, dorzolamide, brimonidine, latanoprost, or any PG analog with timolol. And a few years back, the introduction of brinzolamide and brimonidine opened up the armamentarium for anti-glaucoma medication. And now with the introduction of ripasudil plus timolol combination, again has given us various possibilities to use with patients which do respond to these molecules, so much so that the brinzolamide and brimonidine combination, if you're using, you can use just 4 molecules of anti-glaucoma medication in just 3 drops in only 2 bottles. And the introduction of ROCK inhibitors, you can aim to use 5 molecules in 4 to 5 drops a day in 3 bottles. Various permutations, combinations. These are not mathematical models, but each patient responds differently, diversely to all or any or multiple anti-glaucoma medication. And we need to assess every case independently and choose the right drop of medication for a better compliance and better adhesions of anti-glaucoma medication. And now to conclude the final slide, the clinical guidelines in medication, whenever you are trying to treat the patient with anti-glaucoma medication, use 1 drop, a first choice monotherapy. If it's effective on verify the tolerability, if the patient is able to tolerate effectively and your target range or target pressure is reached, you can continue. And periodically, we need to verify the endpoints, that is the quality of life of the patient, the visual field, whether the fields are remaining stable, the optic disc structurally by optic disc clinical evaluation, or fundus photography, or OCT if you have an access to, and the IOP too. If the target pressure is not reached, but the medication is effective, we can add a second drug so that to potentiate the action of anti-glaucoma medication or a fixed combination, and then try to attain the target range, and the same the thing follows. If the first choice monotherapy is not effective, if you are not got the desired reduction of intraocular pressure, then in that case, you need to switch to a different form of monotherapy, and subsequently the same things follow. So thank you very much for your patient hearing. I think I have finished in time. Thank you, Sujata. Thank you, GR, for this opportunity.
Thank you, Dr. Manoj. Very nice talk, especially the last one. The flow chart is very nice, and it is giving us a very good idea about how to go about treating the glaucoma patient. Dr. Reddy sir, please, your comment.
Manoj,
yeah,
you did excellent job, and you are known for it.
Thanks, GR.
Amit Porwal, sir, if he is there, we'll start with his.
We can start with Dr. Amit Porwal. Welcome, sir.
Thanks once again, Manoj.
Thank you, sir.
Amit Porwal. Okay, in that case, Srini sir, are you ready, sir?
I'm ready.
Okay, then we'll go ahead with your presentation, sir.
Dr. Srini, how are you? So welcome.
Good, ma'am. Good, ma'am. Very good.
Welcoming you.
We had a nice time in Warangal.
Warangal and that.
See, there is an issue with the audio of my laptop. So I'll be presenting from my laptop, and the audio will come from my phone. I told Lakshmi, I said this is okay. You can hear me, right?
Yes.
Yes, Srini, talk to the video technology also. They are fine.
Yeah.
It is fine.
Okay. Yeah, and your the presentation is full screen, right?
Yes.
Okay. Thank you, Sujata ma'am, Reddy sir, Madhu, Gopal sir, and all APA for giving this wonderful opportunity. Madhu, a wonderful program, excellent. Like the whole program is really good. Congratulations, and thank you for inviting me for this talk. This is basically, I mean, as you know, I'm basically a phaco surgeon. Does some glaucoma surgeries only. I'm not basically known as a glaucoma surgeon, but as a cataract surgeon, I'm making this presentation. What goes through my mind, and what practically I do when I take up a patient for cataract surgery in these situations. These are the scenarios that I feel should be discussed. One is lens-induced glaucoma. The other one is postoperative glaucoma. The other one is ocular hypertensives and pseudoexfoliatives not on any medication. Glaucoma patient is well under control with topical anti-glaucoma medications. There are a few situations which are not actually having glaucoma, but in those situations, we actually use glaucoma medications perioperatively. One is a crowded anterior chamber, short axial length, hard cataract, those with poor endothelial status and all. So lens-induced glaucoma, we all know, and probably this is what Dr. Amit is going to speak on. So we have to, the definitive treatment is basically cataract surgery, nothing else. But it takes some time before you take up the patient for cataract surgery. In the meanwhile, you have to control the inflammation and bring down the intraocular pressure to the maximum possible. So you go for the maximum medical therapy. Here, we might avoid the prostaglandin analogs because it takes a longer time to act. So it's not going to be effective then and there itself, and it is known to induce inflammation also. The same thing with postoperative glaucoma also. Here again, we might tend to avoid prostaglandin analogs there. So this study by Ken Hayashi et al. Has shown that postoperative, if you're doing cataract surgery in patients with pseudoexfoliation, there is a postoperative intraocular pressure spike. So if you give oral acetazolamide 1 hour before the surgery and 3 hours postoperatively, this helps to blunt this postoperative intraocular pressure spike. So if you're taking of a patient with pseudoexfoliation for cataract surgery, might be a good idea to give oral acetozolamide preoperatively and postoperatively to prevent this from happening. So why should I actually discuss carbonic anhydrase inhibitors in a talk like this? Because it's an isoenzyme that is present in the corneal endothelium, and in the study by Thomas Malkowski et al., they've shown that carbonic anhydrase. See, if there is carbonic anhydrase on the corneal endothelium and going to inhibit that, so theoretically it can cause corneal edema, right? But this study has shown that the carbonic anhydrase facilitates ion transport, impacting corneal endothelial function in bovine, but doesn't do that in human corneal endothelium, despite its presence there. Saying that they concluded that different mechanisms might be acting in different species, and so none of the studies have shown that carbonic anhydrase adversely affects the corneal endothelial function, and we can safely use carbonic anhydrase inhibitors perioperatively in cataract surgery. Now coming to ROCK inhibitor. See, ROCK inhibitor here, see, we would be, this study, like Fujimoto et al., we're going to use it not as an agent which is going to reduce the intraocular pressure. It's we're going to use it in cataract surgery for its endothelial protective effect, because this study by Fujimoto et al. Has shown that ROCK inhibitor ripasidil has an endothelial protective effect. So this was the study. See, they had two groups, 13 patients with 13 eyes, in which ripasidil was used, and 13 without any ripasidil use postoperatively. And it was seen that in the group in which ripasidil was not used, the corneal thickness was much higher postoperatively. That means that in the group in which ripasidil was used, there was a protective effect, and the corneal thickness increase was much slower. So this result suggests that ripasidil may help maintain the corneal endothelial function and reduce cell loss after cataract surgery with low endothelial function, suggesting that it may be broadly used in those with poor corneal endothelium, like endothelial dystrophy, and in hard cataracts, Brock cataracts, when you use more energy, there will be a lot of this pieces flying around, chattering, causing endothelial loss. So in those cases, it might be a good idea to use ROCK inhibitors perioperatively in these cases. One problem with ROCK inhibitor is that it has been shown to cause corneal honeycomb. So this is the corneal honeycombing. But see, the good thing about corneal honeycombing is that it doesn't seem to affect the vision, and it disappears after you stop the ROCK inhibitor. So probably in these cases, I've been using it. I'm not sure if it is. I mean, theoretically, it is okay. The redness used ROCK inhibitors for the corneal endothelial protection. How much it is protecting, I'm not very sure. Maybe my surgery or whatever, I get good results with that. So this is another situation. The patient doesn't have glaucoma, but has got a crowded anterior chamber. It's been shown that we use mannitol half an hour to 1 hour prior to cataract surgery, 100 ml. You can use 200 ml, but it's just the same. Effect is the same. It acts a bit faster only. So 100 ml is good enough. 100 ml given half an hour to 60 minutes prior to cataract surgery effectively lowers intraocular pressure and increases the anterior chamber depth in this case. So this helps in cataract surgery. So this is another use of anti-glaucoma medications in difficult cataract surgery situations. Now, what is the effect of cataract surgery on eyes with glaucoma? Okay, so it can have two effects: effect on the cystoid macular edema and the effect on intraocular pressure. Let's first take the effect on cystoid macular edema first. So this study by Lee et al. Has shown that the cystoid macular edema occurs in a significantly higher number of patients with primary open-angle glaucoma undergoing uncomplicated cataracts. It's an uncomplicated cataract surgery, and the risk is much higher in patients who are on prostaglandin analogs. So this is a study on which my discussion is going to continue. How does a prostaglandin analogs? You all know how they induce cystoid macular edema. The trauma during cataract surgery induces the release of inflammatory mediators. They leak through the vitreous and reaches the blood retinal barrier or blood aqueous barrier, whatever we call it, and cause leak fluid and causes retinal edema or cystoid macular edema. So that is what happens. But see, it is very unlikely that the prostaglandin analogs that you give per se, they go leak into the vitreous and cause the breakage in the blood retinal barrier. What should be happening is that whatever inflammatory mediators are released, these prostaglandin analogs prolong the production of them and prolong the action of those endogenous inflammatory mediators. So it is not the direct effect of prostaglandin analogs, it's an indirect effect of prostaglandin analogs that is there. All the studies have shown here have shown that prostaglandin analogs can play a role in development of pseudophakic cystoid macular edema. Okay. But so based on this, should we actually stop prostaglandin analogs for cataract surgery? See, I mean, I'm sure the surgical skill of everyone who is doing cataract surgery has improved so much that I mean, in anybody's hand, except in very early, those who are in the early stages of their career, who are not actually going to take up these cases anyway. In almost everyone's hands, the release of prostaglandin during cataract surgery is very minimum. So there is not enough prostaglandin in the eye for these prostaglandin analogs to act and cause cystoid macular edema. So you have to consider that. And also another thing that you have to consider when you're thinking of stopping prostaglandin analogs is that, see, the untreated intraocular pressure per se is an increased risk of pseudophakic cystoid macular edema. So this also has to be kept in mind when you're considering stopping prostaglandin analogs. But when you balance the studies, a lot of studies actually say prostaglandin analogs can cause cystoid macular edema. Let's consider we are going to stop prostaglandin analogs preoperatively. If you're going to stop prostaglandin analogs preoperatively, when are you going to stop it? And with what medication are you going to stop it? See, pilocarpine, because once the prostaglandin analog is stopped and you take up the patient for cataract surgery, the IOP should be under control, right? Otherwise, that again is a higher risk for cystoid macular edema. So when this prostaglandin analog has to be taken over by another anti-glaucoma medication, which is equally effective, and it has to start acting by that time. So pilocarpine is the one which acts very fast. It acts within 4 days, but obviously we don't use pilocarpine in cataract surgery cases. Topical carbonic anhydride is another one which acts very fast. Acts within a week, but it's too weak to actually replace prostaglandin analog. So all others are quite effective, but they take about 4 weeks to act. So the switch, if at all it is made, it should be made 1 month before cataract surgery. Another thing to be considered is with cataract surgery is a probably cosmetic procedure these days. And you want a real quiet eye post-operatively. Brimonidine can cause allergy. You start it before surgery. You don't know if it is going to go red after the use of brimonidine. And when you use timolol, you have to consider systemic complications also along with it. Another factor to be considered. See, you stop prostaglandin analog, how long it is going to stay back? See, if it stays back for long, it still has that cystoid macular edema inducing property, right? So this study has shown that it takes about 4 weeks for the washout effect of prostaglandin analog. So the prostaglandin analogs to be washed out. The effect of prostaglandin analog to be washed out from the eye. But see, based on that, okay, again, 1 month before cataract surgery, it has to be stopped. Right, but you have to consider this. This washout effect is for the IOP lowering effect only. It is not that because of the remodeling that takes place in the ciliary muscles. It's not that prostaglandin analogs per se stay there and reduce the intraocular pressure. So the cystoid macular edema inducing property has to happen, then prostaglandin analogs have to be there, present there. It is not there. It's an action on the ciliary muscle that is staying longer and giving the effect. But anyway, it might be wise. Like let's play it safe. It might be wise to wait for 1 month for prostaglandin analogs to be washed out completely. And this is another study. There are a lot of studies saying it is safe, saying that it is not safe. This is one study which showed that there is no statistically significant increase in the risk of clinically significant cystoid macular edema with the use of prostaglandin analogs. But this survey of the important survey of ophthalmology, which considered a lot of studies together, concluded that the eyes on prostaglandin analogs may be at an increased risk of cystoid macular edema, and it suggested that non-prostaglandin analog IOP lowering topical medications should be used at physician's discretion following a risk-benefit assessment. So this is the final conclusion. I mean, you have to decide whether to stop it or not based on the condition of the eye. So this is it. So should we stop prostaglandin analogs? Yes, if you're sure that you can control the intraocular pressure with an alternative anti-glaucoma medication. Yes, if you can wait 1 month for cataract surgery. Yes, if the patient is at a higher risk of cystoid macular edema, including those with post-uveitic cataract, cystoid macular edema in the other eye, retinal vascular diseases, higher risk of PCR, those with posterior polar cataract, definitely higher risk of PCR is there. Stop prostaglandin analogs postoperatively in complicated cataract surgery. Avoid prostaglandin analogs for postoperative intraocular pressure high. So now let's consider the other effect of cataract surgery, effect on intraocular pressure. So this study has shown that following cataract surgery, intraocular pressure dropped by about 4 millimeter, and this effect lasted for months together. Okay, and the strongest predictor for the significant intraocular pressure drop after cataract surgery was a higher starting intraocular pressure. So it drops after. Sorry, like I'll just continue. Like so, it drops after cataract surgery, and so the question here is whether we should or we can stop anti-glaucoma medications following cataract surgery. So everything depends on the level of intraocular pressure and so how much drop it has the cataract surgery has achieved, how much it has dropped down. And see, many studies have actually shown that we can stop one medication or two medications following cataract surgery. So if the patient is on two medications, we can bring it down to the one medication. If it is on 3 medications, the question is why do you just do a cataract surgery? Well, say you should go for a combined surgery. But so theoretically, if it is there is a chance for you to drop one of the medications following cataract surgery. So this is basically the whole presentation as such. The major thing is whether you should stop prostaglandin analogs following cataract surgery. See, when we discuss with the pure glaucoma practitioners, many say that they do not stop prostaglandin analogs preoperatively, but they do stop prostaglandin analogs postoperatively. See, I personally don't stop them preoperatively or postoperatively. See, if you are stopping it preoperatively, then stop it. I mean, anyway, it is not going to continue. So if you're not stopping it preoperatively, why are you not stopping it preoperatively? Because you believe that it is not going to cause cystoid macular edema. And I believe in my surgery. I know that I'm not inducing a lot of prostaglandin analog release. So I don't actually stop it postoperatively. But if there is any complication, yes, definitely I stop it. Oral acetylcholamide, I do use it in pseudoexfoliation cases. In crowded anterior chamber cases, definitely I use mannitol for cataract surgery. Dorzolamide, if the patient is on dorzolamide, I ask them to continue oral dorzolamide. This is from the viewpoint of a phaco surgeon on the anti-glaucoma medications perioperatively in cataract surgery, and I take this opportunity to welcome you all to AOC 2023. I know that all of you are going to come. We from the LOC side, we are putting in our maximum efforts to make it a huge success. We off late we are having some problem with the accommodation part of it, because when Cochin is not a big city like Mumbai or Delhi, because of that the inventory for rooms are not high. But so bear with us. We are going to do a maximum to make your stay comfortable in Cochin. Thanks a lot once again, Sudha ma'am, Reddy sir, Madhu, Gopal Raj sir, everyone. It is a wonderful opportunity for me. Thank you.
Thank you, Dr. Srini. One of the best talks about pre-operative glaucoma medications for a cataract surgeon. A lot of discussion you did about the prostaglandins and whether when to stop them, when to start them, and when to do. I think it is definitely beneficial for the audience who are having so much of doubt about all these things. Thank you very nice. And we'll see you at Cochin again. I'm coming to Cochin. Okay.
Thank you, Dr. Pradeep Reddy sir, would you like to add to the discussion?
Actually, there can be a lot of discussions here.
Yeah. We have 2-3 retina consultants, sir. Sorry,
am I audible now?
Amit is supposed to be here. I saw Amit in this.
Yeah, he was there and he's coming back. Meanwhile, we can have the panel discussion with Dr. Pradeep sir. Yeah,
of late I have seen with the prostaglandin analogs is that we have severe AC reaction in some of the patients post cataract surgery, especially with bimatoprost. So what we used to recommend at is that we usually stop the prostaglandin analog one week before the cataract surgery, which should be fine, and substitute it with Diamox, and post surgery after seeing the IOP, depending on that, we'll substitute the prostaglandin analog with either beta blockers or alpha 2 agonists or any other drug which is suitable for the patient. That's how we used to do.
Yeah.
So have you seen any such kind of thing in your practice, sir?
No, not at all. Not at all. I'm not, initially, before I started doing all those studies, going through all those studies, I was actually stopping prostaglandin analogs. After going through all these studies and discussing with all those in GSI and all, they are absolutely categorical that it need not be stopped before cataract surgery. Then I thought, okay, like they know better than me, the studies know better than me. Then I ended up not stopping prostaglandin. I do about 700-800 phacos in a month, and there are a lot of patients who are on anti-glaucoma medication. So the patients who are on anti-glaucoma medication undergoing cataract surgery in my hand are quite high. But touch wood, I'm not faced any problem like this. Yes, I'm going to really look for anything like that, like even 1+2+ cells in these patients. Definitely, it's a good feedback, and I'll definitely follow up. Thank you.
Regarding one thing, Pradeep, the most important thing is the cystoid macular edema. Because of the prostaglandin analog. Even only 1 week back, I got the known patient of glaucoma. Even after 1 month, I put him on again prostaglandin analog, which is using before surgery. And now 1 month started again, he's developed cystoid macular. Any patient coming with increasing vision after cataract surgery, known patient is on prostaglandin analog, you always look for macular. It is not uncommon. It is not uncommon.
Yeah. KVV sir, please go ahead. KVV sir, unmute yourself, sir.
Unmute.
Amit sir, you're ready, sir, to go next?
Yeah, regarding all the anti-glaucoma medications,
in the surgical interventions, better to stop all the topical medications. We have excellent anti-histozolamide and intravenous mannitol. We can take care of with the help of this alternative anti-topical medications in the shortcoming of this glaucoma surgeries. Because if more or less every topical anti-glaucoma medication will have some part of inflammation, which you have to take care of post-operative.
Yes, Amit sir, go ahead.
Yeah, Madhu, can I start screen sharing?
Yeah, please.
Sorry,
we'll have panel discussion after Amit sir again.
Yeah, actually, my internet is not stable. Just shifted to my new house.
No problem.
Lot of issues are occurring.
No problem. No.
Just let me know if my voice or my slides don't they disappear.
Yes, yes. Your voice
Both
is
are
there.
visible. Please go ahead, sir.
Welcoming Dr. Amit Parwa. Please.
Yeah, thank you, Dr. Sujata ma'am. Just starting my slide share.
Yeah. They're visible.
Yeah.
But slideshow.
Yeah, I'm just on. That's what there's some problem. I don't know today.
Internet is on and off for sir.
Yeah.
Yeah.
Again, it is hang. You can go ahead with the discussion, Madhu.
Yeah.
Once the thing comes, I'll just lift my
Amit,
finger.
Amit, we can have the discussions on your opinion on stopping prostaglandin analogs for cataract surgery.
So basically, what I do is, Shrini, I don't stop any anti-glaucoma medication except for pilocarpine before the cataract surgery. They continue with all the medications till the day of surgery, except for pilocarpine, which is stopped 1 week. And prostaglandin analogs, after the surgery, I stop it for 4 months.
See, this is where like if you don't stop it preoperatively, the reason why we stop prostaglandin analogs, I mean, theoretically, preoperatively or even postoperatively, is it's basically it's cystoid macula inducing effect. So with the it's an indirect effect on the prostaglandins that are released during the cataract surgery. With our surgical techniques, the amount of prostaglandins that are released are minuscule, and so is there any point in stopping it post-operatively? And also, like though it is theoretically the effect of prostaglandin analog is going to stay for a month, it is not going to be there per se. It is a action on the ciliary muscles that is causing the persistence of IOP offering effect. That is right. But if you're not stopping it preoperatively, why are you stopping it postoperatively? Because I mean your surgery is so good that the amount of prostaglandin release is not. See, why are you stopping it postoperatively? That is my question.
Srini, I'll get back to that before I again stop my my screen gets
Okay.
I think now it's there full screen. So I'm just sorry. I'll go ahead with my talk, Madhu.
Please.
Yes, please go ahead.
So I'm going to talk on managing combined disease, that is glaucoma and cataract. So we all know that cataract and glaucoma is the most common ocular condition associated with the aging process, and there's an increased risk of nuclear sclerotic cataract with elevated IOP and also with the use of anti-glaucoma medications. So the modern cataract surgery, as Srini was telling, has become very popular and more successful rehabilitative microsurgical procedures. But the success with the management of glaucoma, either medically or surgery, has not yet achieved the similar success as what we achieved with the cataract surgery. So the patient expectation for functional result is similar to that achieved by the modern cataract surgery. So we have to do preoperative counseling when we deal with both these diseases. So the perplexing question is how to manage this coexisting disease to promote the best possible outcomes. So surgical correction of visually disabling cataract will not rehabilitate the glaucomatous loss of visual field and the visual acuity. And the initial decision making is crucially determining the type of intervention in coexisting glaucoma and cataract. So basically, we have these three basic surgical approaches in managing this combined disease. That is the cataract extraction alone with the IOL implantation, or you can go ahead with the sequential surgery. That is trab is done first, followed by cataract surgery, the two-stage procedure. Or you can do a combined cataract and glaucoma surgery, which is the most common surgery performed in handling these two diseases nowadays. So what are the indications for cataract extraction alone? When you have a visually disabling cataract with IOP under good control, you have mild glaucomatous damage, you have minimum visual field loss, patient is on 1 or 2 well-tolerated topical anti-glaucoma medication and also is compliant with anti-glaucoma medications. So what are the advantages of this cataract extraction? We have a long-term IOP reduction of up to 5 years. There's less need of post-operative medications and there's a small reduction in mean IOP of 1 to 3 millimeter after the cataract surgery. Disadvantages being there's early post-operative IOP rise in most of our patients in pre-existing glaucoma, especially within 24 hours and maximum within 2 hours of post-operative. There's a close monitoring and prophylactic medical treatment needed when you have this raised IOP spikes. Coming to sequential surgery, that is a two-stage procedure wherein TRAB is done first, followed by the cataract surgery. The indications are here the glaucoma dominates the clinical picture. There's a significant optic nerve damage. There's an advanced visual field loss. There's uncontrolled glaucoma despite maximum target therapy and laserablasting. So the advantages of sequential surgery is it eliminates the need of anti-glaucoma medications, improves the quality of life and vision enough to delay the cataract surgery. In some cases, cataract surgery can be done 4 to 6 months later once the filtering lab is well established, and this is the two-stage procedure. The only disadvantage being there is no need of 2 separate surgical procedures. Filtering surgery might hasten the cataract development, and cataract surgery might have an adverse effect on the filtering lab. Coming to the triple surgery, that is a combined cataract plus glaucoma surgery. This is the most common surgery performed nowadays because of the added advantage. We'll come to that later on. The indications being visually significant cataract with glaucoma under borderline control despite maximum tolerant medical therapy. There's an adequate IOP control but significant drug-induced side effects. There's a glaucoma with a history of non-compliance with medications. There's an adequate IOP control and well-tolerated medical therapy, but there's advanced glaucoma optic atrophy. Also uncontrolled glaucoma for an urgent need to restore vision when 2 operations are not feasible. So the advantage is it eliminates the need for 2 separate operations. The early post-operative IOP rise is significantly less. The significant improvement in visual acuity at the same time the IOP is being addressed. And this decreases the need of glaucoma medications. So coming to sequential versus combined surgery, sequential surgery performed better than combined surgery or vice versa. There is no significant evidence to support this concept. Decision as to which option is adopted should be based on the specific clinical scenario and to the comfort level of the treating surgeon after discussion of the various options with the patients. Coming to the sequential surgery, that is a cataract extraction after filtering surgery, cataract extraction should be positioned to maximize the bleb survival. Cataract incisions site depends on the location of the filtering bleb. The most preferred location is a temporal location. Phaco with foldable to clear corneal incision with or without suture is a surgery of choice. And synechiasis, most of these patients do have synechias, and synechiasis should be done to if it is present due to the previous glaucoma surgery. Intraoperative complications, especially vitreous loss, have been associated with the bleb failure, which has to be noted and taken care of. So coming to the techniques of combined cataract and glaucoma, you have a single site surgery and a combined twin site surgery. Single site, you can do an SICS of phaco plus trab, and twin site is always phaco and trab because the amount of dissection which is there with SICS trab in twin site is too high, so we don't advocate that. Coming to a short video of both these procedures, I'm showing simultaneously single site as well as the twin site surgery. So always you make the superior rectus bridle suture or a corneal stay suture so that it gives adequate exposure of the bleb area. Then you mark your conjunctival flap. If it is an SICS trap, I mark basically 6.5 millimeter, and if it is a phaco trap, I mark 3.5 to 4 millimeter. In one go, make sure that you cut at the limbus. So basically, you have to make sure that in one way you cut at the limbus, identify the bleeders and cauterize only the bleeders. You never over cauterize it because if you over cauterize it, when you make the scleral flap, there will be shrinkage of the scleral flap. After the cauterization is over, you can, if you are going to use mitomycin, you make sure you use a wax sponge and count the number of sponge which you are going to insert into the subconjunctival area, so that you count the same number of sponge when you are taking out. Nowadays, I don't use subconjunctival sponge. What I use is the mitomycin injection subconjunctival as much posteriorly as possible away from the bleb. After a holding period of the desired, according to the case scenario, I have a holding period and then I start my scleral flap. So scleral flap, again, you mark it out. As I told you, for SICS, it is 6.5 millimeter by 3.5 millimeter or 3 millimeter. Whereas if it is a phaco trap, it is always 3.5 by 3 millimeter. I always prefer a triangular flap because I've been trained with that. The trick to make the flap is always lift up the apex and lift the apex and push it in the air as much as possible. And with the help of a cutting edge of a 15 blade, just touch at the junction so that you get a uniform flap. Once this flap is created, Then you can shift temporarily for the phaco trap, that is a twin surgery, and with this SICS trap, you continue with your SICS lateral horns or the side pockets which you make is in a routine SICS surgery and finish the surgery. So the most important part with what is necessary in creating this combined, treating this combined surgery is the creation of the single flap and handling the conjunctiva. So this is very, very important. Now the cataract surgery is proceeded. So in this phaco trap, this was a case of small pupil after synecholysis, malignant ring is used to dilate the pupil so that I get enough exposure. And I always prefer a slow motion phacoemulsification when I'm doing this combined surgery because I don't want much of pigment release. And when you come with the SICS trap, it's the same normal technique. I'm just skipping forward these videos because let us come to the straight trap part which is needed. So in this case, I'm in the SICS trap. You can make this clear internal ostium with the help of 11 number blade or with the help of a Kelly sponge. 2 by 1 millimeter you can aim it, or you can use a 1 millimeter Kelly sponge and make the internal ostium. A broad-based spherical arectomy is what is needed, and then you can put a single intermittent apical suture and two releasable suture or a single releasable suture depending on your skills. So whatever is comfortable in your hand, you should go ahead with that. So these are my initial videos where I used to put a apical intermittent suture and two releasable suture. Nowadays, I just put one single releasable suture and I got enough control. Technique of releasable suture is very, very important. One must know how to put the releasable suture because it has its own advantages. You can titrate the amount of filtration you want. If a bleb is becoming flat, you can release the releasable suture, start the bleb massage, and you can revive the bleb. So the technique of releasable suture is very, very important, which is being shown in this video, and you should be able to put the releasable suture properly. After the releasable suture, what is more important is the conjunctival closure. Conjunctival closure is very important, and you should make sure that you take an anchoring suture at the limbus when you close the conjunctiva with the help of 80 vicryl. Now, why this anchoring suture is needed? Because if you don't take this episcleral or the limbal pipe and you just suture the conjunctiva, then because of the upper eyelid movement, there will be a conjunctival flap retraction behind and the blood will get retracted behind. So this anchoring suture is very, very important. Now, conjunctival closure is done with the 80 vicryl and intermittent locking suture, interlocking sutures are used, and that's the way conjunctival flap is closed. So this is the way basically you are going to do the combined surgery. And this is what I wanted to talk about this combined disease. Thank you. And just a small appeal from my side that I've been in this post of AIS as an ARC member and a member scientific committee since last 6 years. I've given my best and I've committed for this work which I've taken. Again, I seek your blessings for the same post I'm contesting again, that is member scientific committee. I hope I have justified this tenure of mine previously also. So just a small request that please vote and elect me as a member scientific committee. Thanks a lot.
Thank you, Dr. Amit Porwal. Very nice talk and so many doubts clarified regarding the combined surgery. Now, Dr. Reddy sir, please your comments, expert comments.
Yes, I think Dr. Ravindra and Malleshwari also can join the panel discussion under the leadership of Reddy sir. Yeah.
Good afternoon, everyone. I'm Dr. Malleshwari. So my take on stopping preoperative anti-glaucoma medication. I don't stop any anti-glaucoma medications preoperatively, but postoperatively, I do stop prostaglandins and carbonic anhydrase, topical carbonic anhydrase inhibitors. Because if any corneal damage is there or corneal endothelial compromise is there, that can be worsened by the use of carbonic anhydrase inhibitors. So I used to stop topical carbonic anhydrase inhibitors as well as prostaglandins and ripacetyl rokinase inhibitor. So if any endothelial problems or any corneal problems are there, we are not prescribing rokinase inhibitors because it is having so much of it is creating so much of problems on the cornea like SPKs or corneal melting also we saw in one case. So we are not advising ripacetyl in the post-operative patients. And the other things like prostaglandins, definitely we used to stop for 1 week. Meanwhile, we are using oral carbonic anhydrase inhibitors like Dimox. So this is my take on the anti-glaucoma medication. And Manoj Madhur sir and Amit sir and as well as Srini sir explained very well. Nice talks, and thank you all.
Dr. Malleshwari, just sorry to interrupt this. Ravindra also is here. Ravindra, can you give your inputs regarding what Madam told about carbonic anhydrase inhibitor topical drops to be stopped post-operatively?
This actually is a new concept, but I think we are stopping PG analogs, but carbonic anhydrase inhibitors need not be, means it is still a gray area. Maybe with next developments in the literature, we will be having a more clear idea.
Yeah, so basically prostaglandin analogs post-operatively are stopped because they cause anti-segment inflammation also. And we don't want any inflammation. So after the surgery, even though they have 6 weeks of wash-off period, but until the day of surgery, prostaglandin analogs are continued. And after the surgery, we stop it because we don't want any extra anti-segment inflammation, even though we are treating with the steroids. So the chances of CME also is there, but everybody gives prophylactic and SID, Nepafenac or Propinac also. But prostaglandin is notorious that with congestion and anti-segment inflammation and chances of CME is more. Studies have shown that, and that's the reason we stop after the surgery. And some more, if the emergency arises, we can start after 6 weeks of the surgery. So if there is no PC break, but if there is a PC break, we have to avoid at least for 4 months the prostaglandin analogue. Coming to the Repasodil and ACE inhibitors, what we are talking about, madam. Repasodil is having lot of advantages. The only disadvantage is the side effect. Corneal melting might be a single case which was reported. Corneal conflict with the corneal verticillata is reported with this ROCK inhibitors. But again, if you stop it, it is reversible phenomenon. But if you're doing a combined surgery, carbonic anhydrase inhibitors and the ROCK inhibitors, they have the antifibrotic activity also, and they increase the chance of bleb survival. So my take would be I wouldn't stop. In fact, if I feel that the bleb is failing, other than the bleb filling manuals which we do, I always start with either a ROCK inhibitor or a ACE inhibitor because of its wound modulating effect. And this is already published in the literature.
Sir,
Difference of opinion will be there, but I'm just sharing my opinion.
Sir, if there is any corneal edema or if there is any damage to the endothelium because of if it is a rock hard cataract or black cataract, then also you used to continue the topical carbonic anhydrase inhibitors.
Yeah. Because the wound bond, it is always better if the corneal edema is due to endothelial damage. That means it is not due to raised IOP. So that time anti-glaucoma doesn't have a role. It is basically the steroids will have a role in that.
Yes.
If the corneal edema is due to raised IOP, then only this anti-glaucoma medication have a role.
No, sir. Like that time the endothelial pump mechanism is little compromised because of our surgery or because of the hard cataract and all. So that 1 week I used to stop topical ones and oral ones I used to continue. But the topical ones, because again it inhibits the carbonic anhydrase enzyme and again it increases the corneal edema. That's why I used to stop for 1 week, and at the end of 1 week again I will see the patient, and if everything is fine, then we used to start again carbonic anhydrase, even topical also.
Okay.
So otherwise normal patients where cornea is crystal clear and those patients we used to continue. Those patients who had some corneal problem after surgery, then I used to stop for at least 1 week.
Thank you. Thank you so much, ma'am. GR Reddy, sir.
No, actually, only the carbonic anhydrase inhibitor, I don't stop it. And I didn't. Only thing is when they because theoretically the carbonic and this carbonic anhydrase inhibitor, that sodium pump, sodium potassium pump mechanism is there. Theoretically, we think that the carbonic anhydrase inhibitors enhances the corneal edema, but when the endothelium is excellent, this problem we don't see. If it is a compromised cornea, endothelial loss is there, and better to avoid. Otherwise, there is no absolute indication to stop carbonic anhydrase. The only indication to stop is prostaglandin analogs. That is a must.
So one more thing which I didn't cover in my talk was I just mentioned about the combined surgery was only cataract and trap, but now with the evolving era of mix, I didn't have time to speak on that. We also do the combined cataract with MIGS procedure also nowadays, especially in India because it's a developing country and economics play a very vital role. So we do bang and GAT procedure now, and that is also one of the ways to treat this combined disease, that you can use MIGS procedure for mild to moderate glaucoma also. So the combined disease indications have basically broadened now after the introduction of mixed procedures.
after doing bang, how much of pressure reduction you observed in a cataract case? Cataract plus bang.
So basically about 5 to 10 millimeter is a broad range what we see a reduction. So the indication for MIGS surgery is always mild to moderate glaucoma. But now our horizon is widened. Even in advanced glaucoma or a failed TRAB also, we do this bang procedure because the patient won't be totally free from glaucoma medication, but at least if he is taking, suppose 4 medications for advanced glaucoma, he will come down to at least 2 medications. So it is always a safe procedure and the number of medications will be reduced. And for mild to moderate glaucoma, you can always be off medications. And it is always better to give a trial when your TRAB is failed instead of going ahead with a more invasive procedure, because this is less invasive and more safer.
Actually, we got another advantage is there, another facility for going for this thing. Better always, if you can have, you should always acquire the skill to do that. And the advantages and disadvantages, it all depends upon how much skill you develop. Because it is always better to develop the skill.
Which one do you prefer, Amit sir?
I personally feel, let me, so I am also in my evolving stage. I am acquiring these skills. So what I spoke to my friends and mentors in Arvind, and what they guided was, first, I think we should learn how to do a direct gonioscopy. So at least every routine cataract, whenever you do, first practice your direct gonioscopy. Once you're comfortable, start with the bang procedure. Because bang is more forgiving, you know which plane you are into it. Once you are comfortable with bang, suppose you have performed at least 50 bang procedures, then you can go ahead with the GAT, because now you already know which plane you are in. Because in GAT, you have to cut the TM and insert the proline suture. So if you are in the wrong plane, you will cause more trauma. So first, the stepwise, like how we do teach FICO. The first do divide and conquer, then do stop and chop, then do a direct chop. So stepwise transition, how we teach in FICO or what we have been taught. So in MIGS, I would prefer this. But industry is always there. They will tell straight away put eye stent, it is very easy. No, I always feel that go stepwise. Don't come to straight away. Don't run to ride a Mercedes first. Ride a Maruti first. Go stepwise. So I would go with the bank first, and then with the GAT, and then with any implants. Because injecting an implant is very, very easy, but it is not that you first you should know what you are handling with, which plane you are going into.
I agree, Amit, I do that. I agree with you, Amit, but the example what you gave, no, it is easy to drive
a Mercedes than a Maruti
instead of Maruti.
That's true, sir. But I always feel a stepwise transition which is needed, because unless and until you are, see, we all know our gonioscopy which you do on a straight line indirect gonioscopy, but performing a direct gonioscopy is a skill which we need to acquire, which we need to practice in routinely. Because mind you, this glaucoma MIGS surgery is not going to be only in the glaucoma domain. Even every cataract surgeon will practice this, and he should practice it, and at least for mild to moderate glaucoma, once he's well versed, he should do it. Because it's a skill. We can't say only glaucoma practitioners should have this or only cataract surgeons should have this. Everybody should be able to practice whatever skill comes. And this is not so difficult. This procedure is very easy, and one should learn this.
Yeah, I think very valid points are there. And sir, any experience like what Dr. Srini sir was telling, are we using these ROCK inhibitors for any of these corneal indications, prophylactically or therapeutically? Do you have any experience in the panel, anybody?
But I used it, Madhu, but I didn't find any advantage.
Yeah.
So my cornea specialist in our department here used for corneal non-resolving corneal edema.
Okay.
And a few cases, the corneal edema resolution was there.
Okay.
So I have been talking about these ROCK inhibitors quite a few times, and I've done a lot of literature search. What I feel is ROCK inhibitors are basically like a Ramban, you know, the Ayurvedic or the other alternative modality people have their Ramban. For any disease, you use this powder or you use this tablet and it will work. So ROCK inhibitors have a varied mechanism of action from anterior segment to the posterior segment. So it has a role in glaucoma, it has a role in cataract, it has a role in cornea, it has a role in retina. So we don't know where it is acting. So my main search, I was trying to do literature search was, it has a favorable role in corneal edema and on the corneal endothelial cells. Then why corneal verticillata occurs with this drug? So this has always runs in my mind because it has a corneal, it is treated, it is used in corneal disease, but then why one of the side effects is corneal complication.
Corneal complication.
And it is corneal verticillata is seen quite often. It is not that it is not seen.
Yeah.
So ROCK
Luckily, it
inhibitors
is
will
reversible.
yeah, it is reversible. So ROCK inhibitors, what I feel is industry driven, lot of marketing, but as a glaucoma specialist, that is the last drug which is reserved to buy some time before we perform glaucoma surgery on that patient. At my center, we have a huge backlog. We have a lot of waiting time for the combined procedure or the glaucoma procedure. A patient is on maximum medical therapy. There's no other alternative. So just to buy some time before my date is available to him, I start using a ROCK inhibitor.
Yeah, actually, even the molecule itself, what we have seen in literatures like what Kinoshita has used, is different from the commercially available thing that we are using.
So Netasudil, all the different percentages were tried in the studies.
Yeah.
But the only thing is what is, I think 0.01 is available in the market, and that is the one which has the good effects.
Yes,
the
sir.
higher concentration did not have any much effect. Similar, it was similar to the concentration which is there now, and the lower the concentration also was tried, but that also was not working. But only thing is what is reported in the literature, patients do complain there is increase in redness. And what patients say, I've never heard this complication, you know, that after we instill the drop, I have pain in the eyes. No eye drops cause any pain on installation except for ROCK inhibitors.
Yeah.
So this is the only molecule which has taught us that even if you put an eye drop, it causes pain. So dilating drop, when you put, there was burning sensation.
Stinging,
there was never pain. But this drop causes pain to some people. So this is something which we all have to take into consideration. That the patients are not malingering. Okay, we have pain. It is real pain what the patient experiences once you put a ROCK inhibitor.
Srini sir, final comments.
Basically, what I've presented is the relative literature, and in the literature there is no evidence that the topical carbonic anhydrase inhibitors adversely affect the corneal endothelium. So probably, when you think about it, yeah, it is a carbonic anhydrase inhibitor. If it acts on the endothelium, it can cause corneal edema, but literature shows no evidence of that. So, but if you feel that there is a corneal edema, stop it. There is an alternative anti-glaucoma medication for it, which is actually stronger than that. Let's go ahead with it. But literature has no evidence on that. And ROCK inhibitors, basically one of the pain factor. I'm not actually faced that, but that's something that I should look out for. The most common reason why the patients do come back is that with the redness, but when I use it post-operatively, probably because they are already on anti-glaucoma steroids. I've not seen anyone come back with complaining of redness. So that is regarding that. And prostaglandin analogs, definitely initially before I did this review of literature, I was actually stopping it because theoretically, yes, it should be causing cystoid macular edema. But after the review of literature and talking to the big glaucoma people like Dr. Amit and others, they don't stop it preoperatively, but they do stop it postoperatively. I do continue it postoperatively. I've not really seen any anti-segment inflammation with that, but if people have actually, I'm not seen any published literature which says that postoperative anti-glaucoma prostaglandin analogs causes severe anti-segment inflammation. But if there is anything, and I'll have to search for it. If I can find that evidence in the literature, I'll stop it postoperatively, like what GSI advises, not really GSI, and big guns and GSI advices. So this is my take on this. I've learned a lot. Basically, as I said, I mean, you might consider me as a high volume cataract surgeon, because when I'm really bothered about the results and the good feedback from my patients, and this is what I'm following. And as of now, I should not say like it works in my hand. I'm not telling that. So I'm basically going exactly what is by what is available in the literature, and that has worked well in my hands. And regarding IV mannitol and oral acetazolamide, see, I've seen one patient with severe systemic problems with oral acetazolamide when I was in APOS center. So I'm a bit scared of using oral acetazolamide. I do use it when and where it is required. So always ask for self-allergy and use it. Mannitol, yes, for those with crowded anterior chamber, definitely I do use it. But still, there are a lot of situations where with cardiac issues and all, uncontrolled systemic hypertension and all, where you can't actually use it. So I still continue the topic perioperatively.
Yeah.
Madhu, only one thing which I would like to add.
Yes, sir. Yes.
Shini speaking, sir?
No, I think he got frozen. He's traveling.
Yeah. So, Madhu, only we have been talking about what has to be stopped before the surgery. But one thing I would like to add is we need to add something before the surgery for the success of the surgery, especially on people who are anti-glaucoma medications, especially person who is on prostaglandin analog. We should start a smart steroid at least 5 to 7 days before the surgery to increase the rate of left survival and to decrease the ocular surface inflammation. So this will give us better result. So we always talk about stopping, but we never talk about starting a smart steroid. So always a person who is on chronic anti-glaucoma medication, I mean chronic, what I mean is a long time, if he is on an anti-glaucoma medication of any sort for a long duration, we should start topical steroids, smart steroid, and rhodoprenol 5 to 7 days before the surgery, at least 4 times a day. And if he is not on a topical anti-glaucoma for a long duration, if he started on a prostaglandin analog, even for a short while, then also I would advocate this steroid, because all these molecules, they cause ocular surface inflammation. Earlier it was more because of the preservative. Now we have preservative free, but still in spite of using the preservative free molecule, the anti-glaucoma molecule inherit themselves has some role in the ocular surface. So this is very, very important.
Yeah, it's a very practical point, sir. Thank you so much. I think the only place where we want to stop carbonic anhydrase inhibitors would be in a post-transplant case. Probably post-PK or post-endothelial keratoplasty, where the endothelium is already compromised. It is there in literature that we should not use any topical carbonic anhydrase inhibitors. Other than that, I don't think we routinely stop it. So I think great discussion, great inputs from all the speakers and panelists. Thank you so much for taking your time out on a Sunday and being here. Thank you, Amit sir, and all the speakers once again. And I thank Sujata ma'am and Reddy sir for doing an excellent session that is useful to all the practitioners. Thank you very much.
It was nice to see Reddy sir and Sujata ma'am after a long, long time.
Thank you. Thank you, everybody. Very nice session. Thank you. Thank you, Madhu. Thank you, sir.
Yes, sir. I think our next session will start at 4. So I think we can all break for a bio break and have our coffee, teas and come back.
Yes. Bio break is a much good word.
Yeah.
New terminology.
Zoom break.
Okay,
Zoom
bye.
break.
See you all, everybody.
Bye, sir. Bye. See you in Kochi. Yeah.
Yeah.
Okay. We will.
Good everything went well.
Okay. Sir. Okay, sir.
Okay,
sir, thank you.
Thank you, Jia Redgar.
సార్ మార్నింగ్ నుంచి ఆన్లైన్ లోనే ఉండిపోయారు సార్, భోజనం కూడా చేసినట్లేరు.
మధు ఇదిగో తెచ్చుకున్న భోజనం కలకండి. ఓకే మధు.
Thank you very much. Yeah. వివిఎల్ఎన్ సార్
ఏం మధు చెప్తున్నారు
సార్? 350కి మళ్ళీ కన్వీన్ అవుదాం సార్.
అలాగే
ఇందులో ఎవరైనా మిస్ అయినా నెక్స్ట్ సెషన్ ఎలాగో తర్వాత ఇంకేం లేదు కాబట్టి అందులో అకామిడేట్ చేద్దాం సార్.
సత్యనారాయణ గారు ఏంటి డబుల్ యాక్షన్ చేస్తున్నారు? సత్యనారాయణ గారు డబుల్ యాక్షన్ 2 స్క్రీన్లు పెట్టి పెడుతున్నారు.
మై టెక్నికల్ ప్రాబ్లమ్స్ సార్, మీలాగా సోఫిస్టికేటెడ్ గా
మాది సోఫిస్టికేటెడ్ బ్యాక్గ్రౌండ్ పెడితే నా మొహం కనపడట్లేదు, అందుకు తీసాను.
Good, బాగుందండి మధు, కంగ్రాచులేషన్స్.
సార్ కంగ్రాచులేషన్ టు ఆల్ ఆఫ్ us. మీరు అందరూ వెనకాలండి.
కానీ చాలా భారీ పని బాబు, ఇది రిహార్సల్ లాగా ఉంది మన మిడ్ టర్మ్ కి.
అదే సార్.
ఓకే, అయితే ఇంకా పోకుండా
అంతే సార్. 3:45 విల్ బి బ్యాక్. అండ్
అలా
సార్ ముందు సెషన్స్ లో మిస్ అయిన వాళ్ళని కూడా ఇక్కడ అకామిడేట్ చేసేద్దాం సార్. నెక్స్ట్ ఎలాగో సెషన్ ఏం లేదు కాబట్టి.
ఓకే
సార్.
రైట్.
సార్ ఈలన్ సార్.
హలో,
ఈలన్ గారు వచ్చి సార్ నెక్స్ట్ సెషన్ ది. ఆయన 3:45 3:50 జాయిన్ అవ్వమని చెప్తాను.
Hello, good evening, sir, everyone. Good evening, Dr. Madhu.
Good evening, sir. We are just in middle of a bio break.
Oh,
so
sorry.
Back by 3:50.
Okay, because you said my name, that's why I started talking.
No, I just wanted to tell you that time is there, so don't worry. 3:45 3:50 will be online back, sir, again.
Sure.
Your talk is the first, sir, as per schedule. You can be there.
Sure. Thanks a lot again. Okay.
Thank you, sir.
Thank you. Bye.
ఉంటానైతే. Sir, welcome, Subudhi sir. You're on mute, sir. Sir.
Thank you so much.
Yeah, we'll take you in this session, sir. Yeah. We'll just start by 4 o'clock, sir.
Okay, acha.
We are taking a bio break.
Okay, then no problem. Yeah. Hey, Savisachi is also there with me.
Yes, sir. Yes, sir is also there. Elam sir has also come, and yeah, I think.
Audible clearly?
Hello, sir. Good afternoon, sir.
Yeah, audible, very audible.
Nice program, Dr. Madhu. You have taken a lot of pain and care in arranging this program.
No. Pleasure, sir. Pleasure to have you with us.
Hi, Alan.
Hello, sir. Good afternoon, both to you and Subudhi, sir.
Good afternoon.
Dr. Madhu, I am not able to use that background. It is actually creating a lot of white spaces. Is it okay?
No problem at all, sir. You can, okay. You're fine like this.
I think because I'm wearing a blue shirt, it's causing a lot of.
No problem. No problem.
Thank you. Thank you.
Yeah.
Namaste.
Namaste, sir. How are you?
Yes. Fine, sir. Fine. It's really nice to see you.
Yes, sir. This session may start in another 5 minutes.
Yeah. I think. Let me finish at the first.
Okay. So we are moving all over the India, all states, I think, now.
Almost all the states are involved. Yes.
Sir, with half of that effort, Subudhi sir will become directly Rajya Sabha MP or Lok Sabha MP.
I'm sitting in the airport.
Yeah.
Mr. Sir, namaste.
Namaste, sir.
Bavanara. I am there at the airport, Ahmedabad airport.
We'll take you first, sir. No problem.
Sir.
Elan sir, that is okay, sir. We'll take Subudhi sir first.
Perfectly okay, sir. No problem.
Yeah.
No problem.
Thank you.
Good evening.
Sir, good afternoon, Dr. Nadella, sir. Thanks a lot.
Sir, you are on mute. Vishnu sir. Unmute yourself.
Best wish, Sandeep. Try your best, sir. We'll do our best.
Thank you, sir.
Yeah. I'm actually KMC Manipal student and Mangalore student.
Sorry, sir. Sorry, not able to hear, sir.
Student of KMC Mangalore.
Oh, you're okay. You're from KFC Mangalore. Okay, sir. Great.
Yeah, I think you may be knowing this Gurudat Kamath or other.
Yes, sir. Dr. Gurudat Kamath, sir. I know him very well. Yes, sir.
Yeah, the type. Yes.
Yes, sir.
All the faculty are now my classmates there.
Oh, great. Yes, sir.
Elan sir, were you in Davangere also?
No, last week I had been to Davangere, Dr. Madhu.
Oh, okay.
No, I was never in Davangere. Last week I was there.
Okay. Chaitra ma'am has also joined.
Yeah, she has just joined.
Hi, everybody. Good
They're
evening.
having a very big program in Narayan Netralaya Angiogenesis Club. Still, ma'am was able to take out time from that busy schedule and join us. Thank you so much, ma'am.
Thank you, Madhu, for the opportunity. Sorry, I was a little late.
No
Because the
problem.
meeting was still going on.
Yeah. We'll start at 4 o'clock, ma'am.
Sure.
Ramya?
Sir?
Hi, Ramya. Good evening.
Good evening, sir.
I think Ramesh Babli sir is also traveling, so he may not be able to moderate.
Okay.
You can take that role and assist VVLN sir in moderation.
Okay, sir.
The program will go as per schedule only, but we have Dr. Subudhi sir, who could not do his presentation in the morning as he was traveling. So
Okay,
we'll
sir.
have his presentation first,
Yeah.
followed by Elan sirs, and then Chitra ma'am.
Okay, sir.
Chaitra ma'am also couldn't join in the morning. So first we'll
Okay.
start off with Subudhi sir, then Elan sir, and then Chaitra ma'am. After that, it's as per schedule.
Okay, sir.
Okay. We'll start sharp at 4. VVLN, sir.
Ready.
Madhu.
Sir. 4 more minutes, sir.
Okay.
Ramya will be there to help you with the moderation.
Sure.
Ramesh Bubli sir is traveling. Whenever he'll join us, sir.
Okay.
From the expert panel also, Swaruparani ma'am has already joined with Chalpat Reddy, sir.
Okay.
And speakers are also, we have already 4 speakers that are ready, sir.
Yes. Other speakers also will join before this?
Yes, sir. You have 2 speakers from the previous sessions.
Yeah.
So one is Subudhi sir and Chaitra ma'am. Those will complete one before and one after Elan sir. Then we'll follow that order, sir.
Okay. Right.
Yes, sir. I think in 1 more minute, we'll start the session. Subudhi sir, you are ready now?
I'm ready.
Yes, sir. Just one more minute. We'll take you in. Yeah, a very good evening to all of you. I welcome you all back to the virtual ophthalmology conclave by APOS. This is the last session of this online program, and it would cover cataract in form of premium IOLs and difficult scenarios. And now I hand over this session to Dr. VVLN sir and Ramya Setam Raju to take it forward. VVLN sir, over to you.
Yeah. Welcome to the session, cataract, premium IOLs and difficult scenarios. And before we start the session, I welcome all the guest speakers and I thank you for your participation in spite of your busy schedule. So before the routine schedule, I request Dr. Subudhi sir to start his topic.
Shall I start?
Clinical approach to CSR. Yes, sir.
Okay. Let me share my screen. Am I audible?
Yes,
Yes,
sir.
sir.
You're audible. Your screen is visible, sir. Go ahead.
My presentation visible?
Yes, sir. Yes.
Okay. Thank you. So first of all, I must thank Andhra Pradesh Ophthalmology Society giving me this opportunity to participate in this virtual webinar. I thank my friend Gopal Raju and Dr. Madhu giving this opportunity. My topic as it's a very common topic, central serous retinopathy. There are so many synonyms for this disease. It is CSCR, CSC, there are a lot of diseases, but very commonly we put this term as a central serous retinopathy. It is an idiopathic disorder characterized by a localized serous detachment of the sensor retina at the macula, usually the macula, secondary to a leakage from the choriocapillaries through one or more defective RPE sites or outer blood retinal barrier. The main state of management are observation, photodynamic therapy, and laser procedures. So how to approach a patient of this CSR? Because it's very commonly we come across every OPD 2 to 3 patients we get this. So first of all, we must evaluate clinically, then investigate the patient and then treat the patient. So most of times we find these patients are usually young males and suffering with a type A personality and lot of steroid intakes for any region and lot of they are under stress because most of the times they are commonly seen between 20 to 35 years of age group. So proper history taking is very important in all these cases. Symptoms usually unilateral blurred vision with a relative scrotum and the central visual field, unilateral metamorphopsia, micropsia, and mild dyschromatopsia are very commonly complained by the patients. And usually visual acuity is down by 2 to 3 lines in the visual acuity chart. And examination, you will see the relative hyperopia. These patients, they improve with +1 diopter, but some, 1 or 2 lines are improved. And there is always a positive photostress test. In the fundoscopy, you will see very typical, a circular rig reflex in the macular area. It's a round oval sensory detachment at the macula, demarcated by the line. And at the center, we get a small PED within this detachment area. And foveal reflex, usually because the retina is elevated here, the foveal reflex is absent. And sometimes you get subretinal deposits, which may be seen on the particular in the area, central area. And sometimes you get also multifocal pigment changes suggesting chronicity of the disease. This is a typical picture you can see of the central serous retinopathy. There are 2 types. You can say the acute classic CSR. It's very commonly we come across this disease. There's a spontaneous resolution within 3 to 6 months, within fully normal recovery. But sometimes it recurs very often, and recurrence CSR is sometimes termed as a chronic CSR. And there are a lot of diffuse retinal pigment epitheliopathy, and chronic course usually lasts 4 to 6 months, and more than 50 years age group it affects, may have permanent visual disability even after recovery. Normal 6/6 vision does not achieve after the recovery of this disease. And rarely we get a bullous type of a presentation where the retina is elevated very high, characterized with large and more numerous areas of serous retinal and RP detachments, mostly seen following the systemic steroid therapy. For any region that the patient takes steroids, you get a large CSR. You have to differentiate this disease from the optic disc pits, PCB, macular hole with serous detachment, coronal tumors. But the CSR is such a typical picture. I don't think there will be any confusion in getting the diagnosis of the disease of CSR clinically. However, If you are in doubt, we can go for some of the investigations. Amyloid gives the distorted macular vision, giving us metamorphosia, and of course OCT. OCT typical in the case of CSR, there's elevated neuroepithelium, neurosensory retina with a lot of fluid collection under it, and we can get some of the precipitates on the posterior surface of the detached retina. And again, fundus fluorescent angiography, if you are still in doubt, you can go for the fundus fluorescent angiography. It gives a typical picture of ink blot pattern, small hyperfluorescent spots which gradually increase the size, smokestack pattern, small hyperfluorescent spot which ascends vertically as a smokestack, and gradual spread lateral to take a mushroom shape, or sometimes you call it an umbrella shape. And rarely you get a diffuse pattern too. Yes, nowadays sometimes we do it a lot of contraindications for fluorescent fundus fluorescent angiography. We can go for OCTA, optical coherent tomography. The latest addition in is a non-invasive technique. It gives a quick and non-invasive detection to CNBM. CNBM usually normally we may be detected in the FFA, but it can be detected in the OCTA. Yes, ICG can be done if you have got all the facilities of ICG. We can go for ICG. It's characterized by the zonal hyperinvariability of the choriocapillaries, telling us that there is the evolutionary stage of the disease of the CSR. It is primarily it affects the choroid, then subsequently it affects the retina. So ICG may be combined with the FFA to give the better diagnosis. Aim management of this disease. The aim of the treatment CSR is to preserve the outer central retina as quickly as possible. That's very important. As early as possible, the retina attaches, the visual improves fully. To achieve complete resolution of the serous retinal detachment and the underlying SRF, as even a small amount of fluid may give rise to some amount of visual loss. Observation and eliminates the risk factor, the very most common treatment for the disease. So assurance, a proper counseling for these patients is very important because majority of patients recover within 1 to 6 months. So observation and lifestyle changes are very important. The patient has to avoid smoking, late night sleeps, stress reduction. All these things are very essential for these patients. We can try some of the drugs, mineralocorticoid receptor antagonist, rifampicin, acetazolamide, melatonin, propranolol, low dose. These are all the drugs have been tried for this disease, and there are sometimes at some point of disease, probably the recovery of the disease is attributed to the drug at that time used. But however, I don't think there's a definite indication for any of all the drugs I have described. Only simple thing is lifestyle change of the vitamins can recover the disease. Intravitreal anti-VEGF agents, yes, they have the role. If they reduce the vascular leakage and operate the light chunks of the pigment. If you go to the pathogenesis, there is definitely pigment epithelial defect is there. If you give anti-VEGF agent, they recover the disease. Lasers are actually the main source of treatment. This method laser treatment target the focal leakage, and sometimes call them the focal fomentation. So laser fomentation is just mild focal laser can be given to just foment seal the blood retinal barrier which have been broken, thus recover the disease and the fluid gets absorbed. Indications, yes, long-standing cases when it's more than 3 months it stayed in the patient with recurrent CSR or patient having permanent visual loss, if you suspect that permanent visual loss is evident, probably you can do the laser. Nowadays, if it's away from the foveal zone, probably you can try the lasers. Then sub-threshold micropulse laser, the best treatment because it gives a very optimum dose of laser for this treatment and it causes less damage to the pigment epithelium, giving us the recovery of the vision. PDT, yes, PDT is now obsolete, but people have tried PDT wherever the facilities are available. One can try PDT. No doubt they are beneficial. Very severe disease and sometimes the refractory disease, PDT can be tried, but nowadays PDT is not available in many centers because of the non-available dye. Okay, CSR and AI. It has been seen that the application of deep machine learning and AI for patients with the CSR can predict which patients can recover very well and which patient can go for the prone for the recovery, the recurrence. So probably the coming days, artificial intelligence can tell better about this prediction of the recovery of CSR. So to conclude, although the pathogenesis of CSR is still incomplete understood, but advances in the imaging techniques and management methods and the continuous study of the CSR guides the treatment to an increasingly confident and promising direction, because the CSR is very common in day-to-day practice. Probably observation, probably lot of vitamins, probably assurance, and proper counseling can give us the good recovery from the CSR. So thank you very much for giving the opportunity. I'm very sorry because a lot of sounds are coming from the surrounding area. I'm sitting in the airport. I'm on way back from Ahmedabad to Bhubaneswar. Thank you very much, my friends, giving the opportunity.
Thank you, sir. Thank you, Dr. Subudhi, sir. Excellent presentation, detailed about CSR. So any questions or comments from the expert panel? Dr. Sunil, sir, or madam, or anybody?
Can I add a comment, please?
Yeah, please.
Yeah, so we've been using a lot of eplerenone now for patients with CSR. In fact, both chronic patients and acute patients do fairly well. We don't have any long-term results, but given the response, I think we are now conducting a prospective study wherein we want to look at the duration of the treatment required and the dosage. So there are people who use 50 mg twice a day, 25 mg twice a day. But for those who are using the medication, one needs to be very careful about checking their electrolytes and their creatinine, because we do see a change in that, especially because we give this drug at least for a period of 2 to 3 months. So the effect is pretty good, and especially in chronic cases where you've tried everything, you've tried lasers, you've tried, of course, PDT is not available now anymore, but for these patients, it's definitely very, very helpful.
Thank you, madam. Nice information. Any comments?
Sir, I have one question.
Yes,
to Subudhi, sir.
Yes, sir.
Sir, does this excessive gymming, which is the habit nowadays, does it have any role in the pathogenesis of CSR? Excess exercise. Excessive exercise.
Yeah, no. I don't think, maybe the stress may be the factor in those cases. But excessive exercise, I don't have any idea whether exercise has anything to do with the incidence of CSR.
Okay,
What
sir.
happens is these patients, some of them who are working out, tend to take steroids. So when they take steroids, that correlation one needs to make whether they're actually taking any anabolic steroids or not. Because the minute they stop the anabolic steroids, the CSR goes away on its own. So since that's a young population, predominantly males, we tend to miss asking this particular history. We assume that it is an idiopathic CSR. But when you probe, you won't believe the number of replies that you get from using steroid hair creams, to multiple things. They don't even realize that it is a causative factor. So unless you probe and ask them history, many of these patients don't really come out. And the treatment is very simple in these patients. We just need to stop whatever the instigating factor is. So I think history taking in CSR is very, very important.
Okay. Thank you, sir. Thank you, ma'am.
If there are no questions, we will move on to next topic. I welcome Dr. L.M. Kumaran.
Thank you, sir.
Please start your topic, sir.
Yes, sir.
Monofocals.
Is my screen visible, sir?
Yes, sir.
Thanks a lot, sir. At the outset, I would like to thank Andhra Pradesh Ophthalmic Society, the president, Dr. G.R. Reddy, sir, secretary and lead, the program lead, Dr. Gopal Raju, sir, treasurer, Dr. Vishnuvardhan, sir, and my dear friend, Dr. Madhu Gudaraju, for giving me this opportunity. I also thank the chairman of the session, Dr. VVL and Narasimha Rao, sir, and all other expert panel. Dr. Ramesh is not here, I think, for giving this up. My topic today would be cataract, premium IOLs and difficult scenarios. That's the session. And I'll be talking about enhanced monofocal IOL, role of enhanced monofocal IOL today. When we look at the IOL spectrum, right from the monofocal, which we all use initially, which was also discovered, the first IOL to be implanted, till the trifocal, we have a series. I've just removed the multifocal because most of us are not using multifocals now. So it would be monofocal with EDOF properties, something which we would be talking about, EDOF hybrid IOLs and trifocal IOLs, of which we will be concentrating today on enhanced monofocals or monofocals with some EDOF properties. Thank you once again for the opportunity provided. As regards vision, a person is happy if he has a very good near, intermediate and distant vision. But also, he should, not only this range of vision is important, but he should have minimal dysphotopsia. Use the word minimal dysphotopsia because there cannot be no dysphotopsia. This minimal dysphotopsia helps in having highest patient satisfaction. And irrespective of the lens we use, it is the satisfaction of the patient that is most important. Monofocal, yes, patients were very happy with the glasses we provided, the progressive glasses. Bifocal, to a certain extent, the patient was happy, but not the intermediate vision was not great. Trifocals, we could cover all those, but then with the multifocal and the trifocal lenses, we landed up with dysphotopsias, glare, halos, difficulty in night driving, and sometimes a loss of contrast sensitivity. Also to be noted, these are quite costly lenses. Let's also remember that any IOL we use, even if it's a monofocal, have some amount of dysphotopsia. This is what I'm talking about. A monovision IOL has lesser dysphotopsia when compared to a more, that is trifocal or quadrifocal IOL. To a certain extent, technology has reduced this dysphotopsia. But then, how much more to compromise? Just to make sure that the patient is able to see the near, how much more of dysphotopsia can he tolerate? So we have two options. The aspheric IOLs, which works on the principle that the focus is slightly different, and work on this asphericity, slightly increase the asphericity so that the range of vision increases. But on the other hand, we have ringed IOLs. You can see the kind of focus what they have. Multiple foci, but also multiple objects, thereby increasing dysphotopsias. The concept here is to increase the spherical aberration in the center slightly so that the range of vision increases and produces some sort of multifocality. That's all. But then there's a question, why, if this is the case without rings, then why don't we keep on increasing that spherical aberration? If we happen to increase the spherical aberration, again, dysphotopsias happen in these lenses also. Our safe bet is somewhere in between this 1 and 2 range. So somewhere in this 1 and 2 range. Now, having just an addition of +1 or 1.25 or 1.5 is not enough for the daily needs of a patient. So herein we combine the concept of monovision. Now, monovision, we all know the traditional monovision, wherein one eye is corrected for distance and one eye is corrected for near, is not as good. Why is it not as good? You can see patient sees distance clearly, near clearly, but then there is a blur zone, the intermediate zone. Most of us nowadays use the intermediate zone, be it for a computer work, mobile work, or any other day-to-day activities, except for book reading, which comes in this near range. Now, then came the concept of mini, micro, and blended zones, wherein both eyes, one eye is corrected for distance, no doubt. The second eye is corrected not completely, to a certain extent for near, but both these IOLs have that increased spherical aberration in the center. So there is a blend zone. This sudden jump or this blur zone is not there. Blur is converted into a blend zone. This is the concept we were using even in the laser refractive surgeries called presbyond, or any kind of those presbyopic laser corrections. Now with this, the lens, as I already told, with the increase in the spherical aberration, gives around 1.25 to 1.5 diopters of addition. Thereby, something at around 66 to 80 centimeter is seen. But then combining these enhanced monofocals with mini or micro monovision gives us something like this: 2.25 to 2.5 addition, which reduces to 44 to 40 centimeters. So basically, all the activities the person does is covered in this range of vision, if we can go in for that. So a traditional monofocal, both eyes when corrected for monofocal, the near and intermediate is blurred. When you use a traditional monovision, there's always a sudden jump. When you use a blended monovision, there's a smooth transition from near till distance. And I say near, that cannot be less than 30 centimeters, but most often we don't use less than 30 meters for any of our activities nowadays. So it not only provides a continuous vision, a continuous range of vision, it is cost effective. And when we look at the defocus curve, we come to know that. A monofocal, single foci, and we have to use glasses. Trifocal, triple foci, multifocal, two foci. EDOF again has two foci, but then there is again a zone which cannot be seen properly. In an enhanced monofocal, there is a smooth transition, and also the range of vision is increased. This concept used as giving a very good results. There were three such lenses available in the international market. These were the first three to come into the market. I'm using one of them predominantly. And the comparison of the defocus curve, almost all three are same, except the much spoken about VVT, where the amplitude is lesser, while the other two are doing well, as well as in amplitude as well as in range of vision. So this use the concept. I'm using one of them. Again, when we compare the blended vision or the mini micro monovision with the trifocals, in case of a trifocal, the vision starts from around 20-25 centimeters. That is the only defect when we use a blended vision, where it starts relatively lesser. Now, one way to counteract is just using that offset. I normally use a plus 1.25 or plus 1 offset. If someone uses a plus 1.5, it can be brought back to around 20 centimeters. And the most important thing is this: there is some dysphotopsia accepted, but it's as good as a monofocal lens, and it's definitely cost efficient when compared to the other lenses. These were the five lenses that are available when we started off, 2 Indian and 3 imported. There are many more available now, of which I've used extensively these 2 lenses. These were the first few cases which I had studied. Total of 44 patients, 84 lenses. It's a long back. I'm not able to collect the data, but still this data is enough. Proof is there in this. Ray-1 IOLs, only 2 patients were unhappy. The problem that we were facing here was the biometry. Once I started adding plus 0.5, it became all right. Nowadays, most of my patients are happy. When the Indian lenses were used, it was much better than the imported lenses. Most of this patient for distant vision had 6.6 or 6.9. And the near vision, most of them were happy, except a very few who had N12 or N18. N6, N8, N10, most of these people, when we give bilaterally, they were very comfortable. Most important was this intermediate vision, wherein almost all the patients, except probably one, had very good vision. To conclude, if you have to be successful with these enhanced monofocals, there are multiple things that are required. Number one is, of course, the biometry. Best is to use an optical biometry. If that's not available, then an immersion biometry can be used. Always rule out any corneal pathologies, and then look out for the dominant eye. It's a very simple test. All I do is ask my patients to just keep a finger like this and look at the 6/60 number on the vision chart, and then find out which eye they are looking at. There are multiple other ways. You can do any one of them. Find out the dominant eye, and in the non-dominant eye, use an offset, meaning make that eye slightly myopic. Rule out any other pathology, particularly the retinal glaucoma pathology. Glaucoma I have still used. Retinal pathology, usually I do not use these things. Communicate with the patient that you're using monovision. We don't want a surprise patient to come back tomorrow and then complain to us that one of his eyes is not as good as the other for the either distance or near. And finally, money is very important, both for us as well as the patient. So instead of paying the company, we can save some money as well as get the patient to have some. That provides the refractive success as well as a satisfied patient. The more time you spend on the chair explaining to these patients, particularly for all these advanced IOLs, It provides more satisfaction, in turns helps you and the patient make more money. Thanks a lot for providing me this opportunity. Once again, I would like to thank Andhra Pradesh Ophthalmic Society for this opportunity, all the office bearers, the advisory board, the executive committee, particularly this last person in this photograph, who Dr. Lakshmaya sir, I don't know whether he's here, the person who trained me when I was taking baby steps in ophthalmology, both in ophthalmology and in molding my character. Thanks a lot, sir. Thanks a lot once again for the opportunity.
Thank you, sir. Excellent topic. You have excellently covered all the advanced monofocus, enhanced and monofocus. And I got a doubt. You said out of this, Indian lenses did better for distant vision.
Yes, sir.
Do you know the reason?
No, sir. Not only for distant vision. Sir, one problem what we anticipate was with the Rayner lens I was using, initially when we started using it, I was not using that plus 0.5 correction. The surgeon factor was missing in that. Once I started using it, that is as good as the Indian lenses. Considering that the Indian lenses, the other lenses from that company, we have been using for a very long period. Rayner, I started reusing only 2 years back. So initially I had this problem. Once I rectified that, now most of the patients are very happy with the vision.
Nice, sir. Nice. So any questions from the expert panel or anybody?
Which company is the vision lens?
Is IOCare, ma'am. Indian IOCare, IOCARE. I think contact care in some places. Yes, ma'am. Thanks a lot, sir.
If there are no questions, we'll proceed to the next talk. Dr. Chaitra, madam. Madam, please start your talk.
Okay.
So good afternoon, everyone, and thank you for this opportunity, Madhu and the entire team. Today, since this is a session on premium IOLs, I think it's very, very important that we ensure that these patients actually have 6/6 vision post-operatively. And I think one of the most important things that we need to screen for these patients is their macula, because you don't want to be surprised like this particular lady, 58-year-old microbiologist who had 6/36 vision. She was operated elsewhere for a cataract with a toric IOL, and she came to us for second opinion with no improvement. So you see, this is how her OCT is, and you can see the focal loss of the outer retinal layers there. And that particularly means that she's not going to gain back full vision potential. And a simple test such as an OCT would have really helped us pick up this condition and would have helped us, better counsel these patients. So we see several unhappy patients after surgery, and we want to make sure that we're not in this, kind of a soup, because most of these patients expect unaided 6/6 vision post-operatively. So today my topic is going to be on the macular OCT and is it a must before cataract surgery? We've also done a quick study, which I will show you all and elaborate on few important cases. I have no financial disclosures here. So next. Yeah. So now, why is it a challenge? Is because a lot of these patients come in with a media haze, and clinically it's always a challenge for us to detect these macular diseases, which can have contributory factors to less improvement post-surgery. Only clinical examination will miss these subtle changes, and we already spoke about how high the expectations are from these particular patients, and they also have coexisting morbidities. So we want to ensure before, advising premium IOLs or even routine cataract surgery, what is going to be their potential visual outcome. And we've had all these different macular function tests, but it's not really possible to do all of them on a day-to-day basis. What is very, very easy for us and available to us is the spectral domain OCT. And if you see this image, it's a near correlation with the retinal histological layer. Layer by layer, you can actually image and objectively measure, you can prognosticate, and you can follow up using the STOCT. So this is the latest terminology that we're all using based on whichever device you're using. But we need to know these terminologies because if a retinal surgeon is reporting, there is a loss of irregularity of the ELM, you need to know that it's external limiting membrane. Now, OCT interpretation is very easy because everything is visual there. You just need to divide it into pre-retinal, epiretinal, intraretinal, and subretinal. And based on wherever these lesions are, we can actually have a bearing on the cataract surgery outcomes. So these are the normal and the abnormal tissues that can either be hyperreflective or hyporeflective. This table is rather easy for us to remember between the normal and the abnormal. Now, macular pathology is divided into those conditions where you just need to advise observation and counseling and follow-up, because we really can't treat these conditions, whether it's solar retinopathy, geographic atrophy. You just need to tell them, yes, your outcomes are not going to be optimal. Whereas some of these conditions are treatable, like DME, vitreomacular interface disorder, CNVMs. All of them have treatment, which you may need to do either before the cataract surgery or along with the cataract surgery. During the surgery itself, injections can be advised. Some of the common scenarios that you see are epiretinal membranes. Now, very subtle ERMs you may not be able to see clinically because of the cataract itself. Even slit lamp examination can miss these subtle ERMs. They cause distortion of the fovea, and therefore the quality of the vision may be affected. And God forbid there is postoperative inflammation, it can cause progression of the ERM. So OCT is definitely a game changer to not only pick up these subtle lesions, but also to keep a close follow-up. So this is a patient who had a significant ERM pre-cataract. So we planned a combined surgery along with cataract, and we removed the epiretinal membrane, and the patient had near normal vision. So this is another patient, preoperative vision was 618. You can see that thick ERM there. Patient 2 months later presented with worsening of the vision and the ERM. That's when we planned a cataract plus membrane peeling, and then the patient post-operatively is 6-6 vision. So that's what is important, so that there is a team-wise approach here rather than just doing a cataract and then subsequently managing another surgery. Convincing the patient becomes very, very difficult many a time. So VMT or vitreomacular traction syndrome again can cause suboptimal outcomes post-operatively and can be missed. When the underlying VMT is very, very significant, a combined approach is preferable. You can see these are really subtle. If you see clinical examination, you can barely even make out, but on OCT you see how different the picture is. So these are broad-based and focal VMTs, and broad-based VMTs do cause significant visual abnormalities. Now, this is a patient with a high myopia with a vision of just 3 meters. You can see the myopic foveal schisis. The retinal layers are actually split here. So no matter how good your cataract surgery is going to be, the patient's improvement is going to be very, very poor. And given the fact that it's 3 meters, you want to give the best possible vision. So this patient was planned along with cataract for vitrectomy, ILM peeling, and gas injection. And this is post-operatively 1 month and 2 months. And then the patient is now at least achieved a vision of 660 now. Macular hole almost missed when the cataract is significant. We do need to do the OCT. You can see here the different types of hole configurations that you can see. Full thickness macular hole combined surgery should be planned. These are the different stages that you can see in macular holes, and these are lamellar holes. You also need to differentiate them from pseudo holes that you see in patients with ERM. Macular edema, very, very important condition because most of these patients are diabetic, so they could have coexisting diabetic macular edema, which can even worsen post-cataract surgery. So we've had multiple discussions on how non-center involving diabetic macular edema can become center involving post-cataract surgery because of the changes in the cytokine levels. So either we plan treatment just before the cataract surgery or during the cataract surgery. So this is what the paper that speaks about increased risk of developing center-involved macular edema at 16 weeks. Pseudophakic CME, I think all of you all, deal with on a regular basis. Many patients come back even despite an uneventful cataract surgery. We need to monitor these patients, and it's very, very easy to pick up even early pseudophakic CME on the OCT. So rather than waiting for the patient to tell you that my vision is dropping, if clinically you suspect that something is wrong, best to monitor them closely. Wet AMD, a common condition that coexists in this group that undergoes cataract surgery. You can see this patient had a coexisting CNVM with cataract. So along with cataract, we gave an injection and there is good resolution. This is as far as wet AMD goes. This is dry AMD, and those patients with atrophy, which the yellow arrow is pointing, the visual outcomes are going to be pretty poor. This is photic retinopathy, just like the first patient that I showed you. Again, this prognosis is not very great because there's no treatment for these conditions. So lastly, this is the study that we did on, whether we should include STOCT as a screening tool or not. This is our experience. We wanted to see how many macular pathologies that we can identify in those patients undergoing cataract surgery. Basically, what we saw was that at least 24%, it is a quarter of them had macular pathology that was detected only on STOCT. What were these findings? Well, the different kind of macular pathology, the most common of them that we saw was, clinically detected versus non-clinically detected. These were the ones that were detected only on STOCT. And what were the different macular pathologies? The most common that was seen was AMD, followed by ERM and VMT. And we know how bad they can be on the visual outcome. So this was the total number of eyes and the number of them that were affected, and how many of them actually required a change in management was 11% of them. When you look at large numbers of cataract surgery, I think that is very, very important. This is in concurrence with several other studies where they have seen macular pathology picked up on abnormal OCTs itself. So these are the number of eyes that we have actually screened, and we have seen again a 24% of them having macular pathologies, and the treatment was altered in close to 300 eyes. So when should we image? When vision does not correlate with the amount of cataract, if the patient complains of metamorphopsia, suspicious lesions that you see clinically, but you're not sure what it is, documentation of conditions that are likely to progress. Suppose you see a macular edema, which is not clinically significant. You want to document it so that later on you have an explanation to the patient that, this is probably pseudophakic CME and not a pre-existent condition. Vision loss following a phase of improvement, again, pseudophakic CME or progression of ERMs or macular holes. So mandatory pre-op macular OCT for premium IL patients when the grade of cataract does not correlate with the vision. When one-eyed patients, definitely you should. Myopic patients, because you cannot pick up lesions because of poor contrast. And finally, patients with uncontrolled systemic illnesses and known macular conditions. So it helps us in all these three very, very important indications. Thank you so much.
Thank you very much, madam. Excellent presentation regarding examination of macula preoperatively, which is very much beneficial to the younger generation and postgraduates. So I have a question. So if you give preoperatively, you found that there is some macular abnormality and the patient has chosen a premium IOL.
Yes, sir.
How would you proceed?
So it depends on what kind of macular pathology it is, sir. If it is a progressive macular pathology, we prefer to defer premium IOLs. Like a patient has a macular hole which requires surgery. If it is a patient who has like chronic macular edema, then we will defer it. But suppose it's a non-progressive macular condition, wherein you have a little bit of scarring extrafoveal, or you see one or two, drusen's here and there, or a PD. We know that some of these conditions don't progress. So I think it is fairly okay to go ahead again with premium IOLs in these patients. But the one thing that we would require is that we counsel them very well, because they're paying very, very high for these IOLs and they don't want to be disappointed post-surgery. And I think a well-aware patient or a well-counseled patient is more accepting of even some shortcomings which happens post-operatively, because everything is not under surgeon's control. Because you don't know whether that same patient who had a normal macula developed pseudophakic CME. I mean, how can you really predict that? So I think that is something that we need to tell these patients that we have done whatever screening from our end, and this is the condition that you have currently. But after the surgery, if there are certain changes, it is difficult to predict.
There is another doubt, madam.
Yes, sir.
Will the multifocal IOLs, will there be any problem to the retinal surgeon during surgery if he needs to do any retinal surgery?
Not really, sir.
Visibility.
No. The rings really don't bother us. Clinically also, when we see a lot of, fundus examination when we do IDO, now we've all become used to seeing it through multifocals, because a lot of patients come to us with multifocal IOLs. Initially, I used to find it's a little strange, but now I know that I'm seeing through a multifocal IOL, and we have certain adjustment techniques. Even during surgery, like I recently operated on a patient having a macular hole multifocal lens. It was quite okay. I used to wonder whether it would be difficult, but not really, sir.
Okay, madam. Thank you.
Can I add a point here?
Yeah, please, sir.
Dr. Chatra, very nice talk, and I think it's very essential that we do a preoperative OCT. So as a protocol, we always do in all our cataract patients, not only patients who are, suspicious or premium. It's a protocol for last many years, because you definitely pick up some subtle changes which are there, like, VMT, mild VMT or something like that. And even if patient has a mature cataract, we make it a point that on the next day, first post-op day, we see OCT again, because it's very easy to make them understand on the next day that, see, this pathology was there. And so we tell them, if patient has a mature cataract, that we'll do your OCT tomorrow. So it's very important.
Yeah. So we're doing it as part of the cataract workup for all our patients. So initially we were worried about the cost, but when you look at the, the results of the study that we've done with 16,000 patients, it is scary, Harshul, because, we've seen patients where very important conditions like PFT were missed on clinical examination. PFT is such a subtle lesion clinically, and the outcome is so poor post-cataract. So, I mean, we are now doing it as a routine, and I think the patients are also okay, and we don't take printouts. So I think that is the biggest cost limiting factor. When you take out, OCT glossy printouts, it's not required. We are viewing it on the system. We're able to educate the patient on the system, on the monitor itself. So all patients are quite okay with it.
Any more comments or questions?
Yeah, I have a point. Like, you have to show it before the surgery, because after the surgery, see, if it is a mature cataract, then we have to do it the next day. But if you show it after the surgery, the patient has a lot of suspicion on the doctor. So we have to do it before the surgery. If it is a white cataract, then we can do it the next day.
Yes. That's what many times, ma'am. Many times the eye also changes. Like both the eyes have similar grade of cataract, but one eye had some VMT changes, other doesn't. So first we go ahead and take retinal opinion. So we change the eye also in this same sitting.
And yes, another thing is, I mean, I don't know whether one of you all mentioned it. Always try to do the both eyes OCT at the same time. That's a very important.
That's what I was about to.
That's what we do.
So you should do both eyes OCT when you're screening, even if it's one eye surgery plan, because a lot of these conditions are bilateral. So after cataract screening, you won't believe the number of patients that get referred to retina because there's an early macular hole in the other eye, or early CNVM that we have missed clinically because the patient has not come for early screening. Diabetes has been picked up. So, so good to do both eyes.
And regarding the cost, what you told, Chaitra, definitely it's not a high cost, because a simple cyst removal, skin cyst removal elsewhere, the investigations done run into 5,000 to 6,000 rupees. We are giving vision to the patient, extra 1,000 rupees. That's what most of us charge for OCTs. I think even Narayana charges 1,000, 1,250 for a OCT for a cataract patient. Should not be a deterrent.
Yeah, but the cost you pay if you have not detected pre-operatively is much more higher. So.
Huge.
Actually, we have made it in a package. The package of cataract surgery includes OCT
also.
Unless and until it is an Ayushman Bharat case.
Any more suggestions? Dr. Gopal Raju?
Sir, Chaitra, that was an excellent presentation. So we have done one study doing OCT in patients where clinician diagnosed it to be a normal macula. So among those patients, we could pick up around 10.45% of the patients having the macular pathology in all the patients where we thought it was a normal macula.
Yes, sir.
So from that day onwards, we incorporated OCT. We published that also. Thank you. That was a nice presentation.
Thank you, sir. Thank you for the opportunity, and thank you for including me in the session. I had another ongoing meeting, so I couldn't be there in the previous session. Thank you, sir.
Thank you, madam. In spite of your busy schedule, you participated in our program. Thank you, madam. So next we will proceed to Dr. Harshal Tak's topic. Sir, please, you start, sir. FACO and difficult situations. Different situations.
Thank you very much, Dr. Rao. Yes. And at the outset, thanks to the entire Andhra Pradesh Ophthalmic Society, especially Dr. Gopal Raju, Dr. Madhu, for giving this wonderful opportunity. Is my screen visible here?
Yes, sir.
Okay. So I'll be sharing a few videos which are really difficult for any phaco surgeons, and let's see how those cases were managed. Okay. So this is the first case. This case underwent penetrating keratoplasty, I think 6 months back. And after that, few sutures were removed. And patient had just 1.25 or 1.5 diopter of astigmatism, remaining astigmatism, and came up with this white cataract and posterior synechia, as you can see here. And this is the graft post junction which is there. So in these cases, it's very important that you make incisions posteriorly, not to disturb the graft post junction. And either you can make a clear incision or a posterior limbal incision. And here I'm not putting OVD because I need to stain anterior capsule. Is a white cataract. So I go ahead and put irrigation cannula, maintain anterior chamber, and going from the side port, I'm releasing posterior synechias here first, so that dye can percolate easily through the iridectomy and through beneath the pupillary margin, and it can stain anterior capsule well, because it's very crucial to stain anterior capsule nicely in white cataract, we all know. So after that, after releasing posterior synechia, I go ahead and make main port incision also, and then put a dye there, stain anterior capsule, and wash away excess dye. And after that, we need to put any expander device, because there's a small pupil case here. We all know that already there is a compromised cornea which is there. So we need to be very careful that we don't put much stress on the corneal endothelium. So we need to use appropriate device. So this is another way of using the Mulligan ring. This is the cartridge of the micro incision lens, which goes through 2 mm incision. So in the same way we load the IOL, the Mulligan ring is compressed in the tube like this, and you'll see the first scroll, it goes and engages the pupillary margin. Lateral scrolls one by one comes out nicely and engage the pupillary margin. Because of the peripheral iridectomy, there is a stretching of the iris tissue there. So you need to be careful and use a bimanual technique. Go beneath from side port, I go beneath the arm of the Mulligan ring and push the iris towards the incision, and then push the proximal scroll to engage the pupillary margin. So once you have this ring in place, as you can see, we maintain good pupillary dilatation of 6.25 millimeter, and then rhexis is easily completed. It was not an intumescent cataract, just a white brittle cataract. And I go ahead and do echo. You need to use in between dispersive viscoelastic, which is chondroitin sulfate base, to protect corneal endothelium. And here I separate these nuclear pieces into smaller pieces and take all these pieces one by one. And this finishes the nucleus emulsification, and do cortical matter irrigation aspiration. And after that, you can enlarge the incision to the desired size and put the IOL. So another advantage of using pupillary expanded devices is that you can nicely see the size of the capsulorhexis and how much overlap is there. Here, the overlap was a little more. So I go ahead and give a small cut there with the micro scissors and enlarge the capsulorhexis to the perfect size. If you want to have a look, you can just push the ring on one side and make the capsulorhexis of perfect sizing. And to disengage this ring, you just release all the scrolls one by one from the pupillary margin. And either you can use the same injector or just use this dialer. Just rotate it in the upside down position, and this ring comes out. And you hydro stitch all the incision, and this finishes the case. So this was the first case. Another case is a case which had subluxated cataract, as you can see here. So this is the traumatic subluxation, and the area of zonal dialysis was more than 6 clock hour here, as we can make out. And another problem was of the fibrotic capsule here. So it's very important that you don't try to pull through these fibrotic areas. So whenever you reach these fibrotic area, you need to cut through them. And whenever you are in the clear area, you try to make capsulorhexis with microcapsulorhexis forceps. I go from opposite side and trying to create capsulorhexis here. Remember that you have to change your hands again and again. Here I'm reaching the fibrotic area. So using scissors from my left hand, pulling on again changing my hands. So you of course have to improvise a lot in these kind of cases. But remember that in the area of subluxation, you have to have 2.5 millimeter margin of the anticapsular axis, because area of subluxation is more, and I'll be using the capsular hooks there. So I go ahead and cut through again through this area. And once I reach here, I again have to make another side port so that, my area of cutting is perfect. And this is the way I complete capsular axis, put a dispersive OVD there so that there is no anterior vitreous phase disturbance. And these are the capsular hooks, which are the right device to act as artificial zonules there. So these capsular hooks, depending on area of subluxation, you can use 3 or 4. And this was a brittle cataract, so nothing great in emulsification. But once this nucleus is out, remember that you always have to avoid fluctuation in anterior chamber. So before withdrawing phacoprobe, always push viscoelastic in the capsular bag and then turn off infusion and come out. Now, you can easily take off these capsular hooks because their role is over. So you need to put a CTR to give capsular the equatorial expansion to the capsular bag. So CTR ring goes in from side port and use this Cugelin hook to guide this CTR ring into capsular bag. And once this CTR ring is there in capsular bag, you can see it expands equatorially and causes centration of the bag. And after meticulous irrigation aspiration of cortical matter. But for long-term stability, you need to use a capsular tension segment here. So this is a segment made of PMMA. I tie a knot using double arm 90 proline suture on this eyelet. And these 2 arms, they are put in the capsular bag. This segment is put in capsular bag. And either you can use a Hoffman pocket or this is scleral glue, which I've used. Use a 26 gauge needle to railroad both the needles out of the scleral wall. And once you've railroaded these, both the arms, you tie this knot and titrate the tension so that you have perfect centration of capsular bag. Now, instead of 90, we have started using Gore-Tex suture, which is non-degradable. And because this was a traumatic subluxation, you can put a single piece foldable acrylic IOL, or if it's you feel that it's a progressive zonulopathy, you can use a 3-piece IOL in those cases. So at the end of the surgery, the patient has stable capsular bag and IOL in the capsular bag, and hydro stitch all the incisions. I think my time must be over, so I'll finish here. Yeah, thank you so much, sir. You're muted, Dr. Rao.
Thank you, sir. Nice presentation, nice surgeries. I have a question, sir. So you have kept the CTR after doing phaco.
Yes.
What is the difference if you put it before the phaco or after the phaco? How do you feel which is better?
So I feel it depends on the grade of cataract also, and the amount of subluxation also, and it also depends on the comfort level of the surgeon. Because the earlier you want to put the CTR ring, the more messy everything becomes. So depending on the situation, you have to decide. So you have to put it, you have to delay it as much as you can, but you have to use it as early as it's required. Because you see, I can show another case which has a very weak zonules. And if you start doing phaco in those cases before putting CTR or before putting capsular hook, you will land up damaging zonules further and the lens will dip down. So you have to decide on case-to-case basis that what you should do. But yes, usually, yeah, Dr. Madhu wants to add something.
Yeah. In the morning, Dr. David Chang was also emphasizing on the same, because for zonulopathy, I think what you have done is perfect. Like putting the capsular tension rings early and then CTR at a later point.
Yes, of course, because you just need to anchor the capsular bag because they act like artificial zonules.
Yeah.
And depending on the area of subluxation, you may use 3-4 capsular hooks. so that you don't put stress on the capsular bag and damage further zonules.
Exactly, sir. Yes, very
Sir,
practical.
Dr. Sunil, sir, your opinion, sir.
Yeah, I agree with everything what the speakers have said. But the most important point is, don't go back home and say, this is the only way to do this. As Dr. Mitchell was saying, you have to decide on the table. You have to decide on your ability. You have to decide on that specific case. So sometimes you have to put it early, sometimes you have to put it late. Don't go back with the message that you have to do it only this way. There is not one right way. It depends on the case. That's what I would say.
Yeah, and moreover, it depends on your chopping technique also. Like, and in the I said on the grade of cataract also. If had this been a Brunescent cataract, I would have placed the CTR ring also, because that also puts another stress. So I do phaco chop, direct phaco chop. So I take all the stress away from the capsular bag toward the center. So it all depends on how do you approach the case. Yes.
And the first case you showed where you stained the capsule under irrigation. Very, very important. Don't put the viscoelastic and then stain, because then you may not be able to stain. The other problem, sometimes with these post-keratoplasty cases, you can have a fine membrane over the capsule, which you will not see. And you think you have stained it. And when you put the viscoelastic and come out, there is no stain actually. And then you can have a problem.
Yeah.
So doing it under the way you showed it, doing it under irrigation, very good, very nice.
Yeah, and had this been a cataract not mature, and we can see easily in red glow capsulorhexis, so there's no need to put irrigation. So as Dr. Sunil said, you decide depending on the case, what kind of case is, yes.
Yes, sir. In the first case itself, sir, if the cataract had a more brunescent nature, would you have preferred to do an SICS there?
No.
Okay.
Yeah, I prefer phaco in all my cases. Yeah.
Okay.
Another problem with SICS, if the graft is big, then it's very difficult to take the incision.
No, sir. Here the graft is quite central.
Yeah, if it is small, you can still do it. Yeah.
Because I was just worried about the ring going in phaco energy for
If your incision should not go into the graft host.
Being a corneal person, I'm more worried about the endothelium.
Yes.
Even you can do ACC.
So. No. So you need to, control the amount of energy which you are using. And of course, you need to use dispersive OVD in these cases.
And also, sir, the continuous irrigation itself can cause some endothelial damage.
Yes. So you need to put it, not towards the endothelium. Your irrigation cannula should be towards the angles or something like that. Yeah.
Excellent cases, sir. Excellent cases as usual.
Excellent surgeon.
Thank you so much.
Ordinary surgeon.
Thank you, sir. Excellent presentation, sir.
Thank you so much for giving this wonderful opportunity. Thank you.
Thanks. So shall we move on to next speaker? Dr. Anaga is here. Madhu?
No, sir. I think we'll go on to
Dr. Sabisachi.
Yes, sir. Sir is there.
Sir, please start, sir.
Is my screen visible?
Yes, sir.
So, respected BVL sir, and at the outset, I must thank Andhra Pradesh Ophthalmological Society, Dr. Gopal Raju and Dr. Madhu for giving me this wonderful opportunity to be a part of this very nice program that is being continued since morning. So my topic for today is cataract surgery in diabetics. As you know, we are seeing a lot of diabetics nowadays. So they are 2 to 5 times more likely to develop cataract and also at an earlier age. So the challenges before us is how to handle those cataract cases in diabetics. The risk for developing cataract increased with increasing duration of diabetes. So now up to 20% of all our cataract surgeries are performed in diabetics. The cataract surgery in diabetics may lead to relatively rapid progression of diabetes. It was earlier studied and found out that, but with progress in type of surgeries and minimum injury to the ocular tissues, the progression has come down. There is also chance of precipitation of vitreous hemorrhage that may induce iris neovascularization subsequently. And also macular edema, which is also a very important complication in diabetics itself. And it is added in case of cataract surgery in those diabetics. And all these will ultimately lead to decrease or loss of vision. So what is the reason? In non-eventful cataract surgery also, there is increased inflammatory cytokines. There is increase in VEGF, hepatocyte growth factor, interleukin, pigment epithelial derived factors, everything. So it takes at least 1 month to decline to preoperative level. So these factors may induce clinical or subclinical worsening of diabetic retinopathy in macula. So increased inflammation and breakdown of blood retinal barrier plays a role in development of macular edema and progression of diabetic retinopathy. So the study, ACCORD study, was done to see the visual outcome after cataract surgery and identify predictors of good visual outcome in individuals with diabetes. So they found out 67% of cases had good visual outcome. Still 33% have bad outcome in diabetes. So people with diabetes continue to achieve less favorable visual outcome relative to the general population. So what are the predictors of good visual outcome? As per their study, they found out preoperative visual acuity was a significant prognostic measure. If the preoperative visual acuity is good, then chances of good postoperative vision is there. Reasons are absence of diabetic retinopathy and severity of retinopathy, especially macular ischemia, edema, CSME, are poor prognostic factors. HbA1c is not significantly associated with good visual outcome. And social determinants of health influence clinical outcomes. That is, they said that education level and socioeconomic status also predict good visual outcomes. So basing on that, what is decided is to have early cataract surgery in diabetics. This contributes to improved visual outcome. Risk of diabetic macular edema is decreased. So visual outcomes are likely to be worse in patients in whom surgery is deferred until late, when it is not possible to identify or adequately treat diabetic macular edema before cataract surgery. So diabetic retinopathy, presence of diabetic retinopathy or macular edema need not be an indication for delaying surgery when it is clinically indicated. So the approaches has to be preoperative, perioperative, and postoperative. Coming to preoperative consideration, same preoperative evaluation as done in non-diabetics applies to diabetics also, but with more emphasis on presence and extent of diabetic eye changes have to be evaluated, starting from dry eye or corneal, endothelial, epithelial lesion surface, ocular surface. Then people will expect little bit of small people in diabetics. So proper preoperative counseling is very crucial when dealing with diabetics to predict about the postoperative visual outcome. Good glycemic control and no evidence of ocular or periocular infection has to be there because diabetics are more susceptible for infection. And degree of cataract should correspond to the visual acuity. If it is not corresponding, then proper thorough examination, fundus examination with OCT and FFA were needed, as has already been emphasized by previous speakers. It has to be done to find out that there is no macular pathology before proceeding for cataract surgery. Then in case of pre-existing retinopathy, it's more likely to progress and develop retinal complications rapidly. So significant diabetic ocular pathology should be treated before cataract surgery is considered. This involves a multifaceted approach. PRP in cases of PDR before doing cataract surgery, focal laser in case of CSME or intravitreal VEGF or steroids. So macular edema should be adequately treated before surgery, and pre-existing maculopathy may aggravate post-cataract surgery. The impact of cataract surgery during treatment with ranibizumab in patients with diabetic macular edema study they have done to determine what impact, if any, cataract surgical intervention had on visual outcome in patients undergoing intraocular ranibizumab before therapy or DME. So ranibizumab does not influence any progress of cataract in diabetics, but patients treated with ranibizumab had good improvement in vision after cataract surgery. So diabetic cataract, snowflake cataract is seen in type 1 diabetics, but most frequent type of cataract seen in diabetic is senile cortical cataract. Posterior subcapsular cataract also can be seen in significant number of cases. There are certain intraoperative considerations to be taken care of during surgery. Poor pupillary dilatation due to damage to pupillary parasympathetic supply. So we should be prepared with pupil dilating devices if required. But still we have to be very careful because chances of intraoperative hypema can be there due to presence of rubeosis. Anticapsular phimosis is more common in diabetic eye. So larger capsular access should be done, but smaller than IOL optic diameter to prevent IOL displacement and phimosis. Large diameter optic also facilitate diagnosis and treatment, post-treatment in retinal pathology post-operative. Longer duration and complicated cataract surgery, there is great risk of progression of retinopathy. So mere presence of diabetes does not increase the risk of intraoperative complications like PCR, jonular dehiscence, or vitreous loss. This is as common as in other cases. So diabetic eye is more prone to keratoepitheliopathy. There is greater predisposition to corneal endothelial cell loss in people with diabetes. So routine specular microscopy also should be or can be done to evaluate the corneal endothelium before proceeding for surgery, and we need to have greater care to protect the endothelium during surgery. Then multifocal IOL should be avoided. Acrylic IOLs are preferred for patients who are likely to undergo vitrectomy, whereas silicone IOL is a reasonable choice in well-controlled diabetes and without or mild retinopathy. A diabetic patient with non-clearing vitreous hemorrhage or tractional RD, cataract surgery can be combined with pars plana vitrectomy by our retina colleagues simultaneously. Post-operative consideration, all patients diagnosed with NPDR should undergo detailed retinal examination within 3 months before cataract extraction. We have to evaluate properly. Then patients with diabetes and PDR with inadequate view of retina before cataract extraction should be evaluated closely after surgery for monitoring the retinal status. When the lens opacity recruits preoperative ERP, then we have to do indirect PRP laser delivery immediately following the cataract surgery or within a week after cataract surgery, because there is chances of progression of PDR. Prevention of macular edema in diabetics, topical NSAIDs are beneficial for treating macular edema. They block cyclooxygenase enzyme responsible for prostaglandin production. Out of the NSAIDs, nepafenac has a better review. So 3% or 0.3 or 0.1% nepafenac can be used, while nepafenac 1% is used 3 times a day. Nepafenac 3% is used once daily, starting from pre-operative period to the entire post-operative period. The topical steroids combined with NSAIDs are prescribed for prevention and treatment of macular edema. Systemic blood glucose levels should remain under control. Most of the time after surgery, the patient becomes complacent and do not take care of the blood glucose status. So development of PCO and persistent inflammation are more common in diabetics. So diabetic retinopathy can be exacerbated in post-operative period. So patients should be monitored very closely with dilated fundus examination. We cannot leave them as such because post-operatively they have good outcome. So to conclude, diabetics with cataract pose unique challenges during surgery, may be prone to a more difficult post-operative recovery. 2/3 of eyes achieve good visual outcome, but still certain factors limit visual potential in diabetics. So careful pre-treatment of retinopathy, minimally traumatic surgical technique, and appropriate post-operative medications. Patients can do very well and recover excellent vision, just like other cataract patients. So thank you very much for the opportunity. Again, once again, I thank Andhra Pradesh Ophthalmological Society, Dr. Gopal Raju, Dr. Madhu for this wonderful opportunity. And a small request, I am contesting for the post of member ARC East Zone. So please help me in getting your support. Thank you all. Thank you. Any questions, sir?
Thank you, sir. Excellent talk on diabetics, cataracts. I have a question, sir. So patients on high dose of systemic steroids on some other disease, they came for surgery and are diabetic. What your line of management? Will you continue that high dose of systemic steroids while doing surgery, We advise the systemic steroid dose to be reduced or monitored by physician.
It depends, sir, for which the patient using steroid. Because if that is absolutely indicated, then we have to continue with the dose as per actually the advice of the physician. It is better to take an advice with physician whether the steroid dose can be compromised or can be adjusted. Otherwise, there is no such problem in doing cataract surgery. Those who are using high dose of steroids.
Any experts, any comments, questions?
Just a comment, just whenever you're doing diabetics, especially diabetics, expect, if you think it's a grade 2 nuclear sclerosis, it's actually grade 3. If you think it's grade 3, it's actually grade 4. It's always worse, and it is always very leathery. The nucleus is extremely leathery and so very difficult to chop. So you expect these complications, and that is why the surgery can become really prolonged. So you have to expect these complications. And dealing with the diabetic cataract is completely different. So it takes a lot of experience. It takes a lot of skill in some of these cases. They can be very irritating cases to operate. Very, very irritating cases to operate. So you have to remember that. Do not go by the red reflex and stuff like that. You will be surprised on the table. So that's one of the only comments. And about the steroids part, yeah, it depends on the physician, I think, completely. And frankly speaking, if the patient is on steroids, I'll be very happy because my post-op outcome is very good. They're totally white eyes. It's no problem.
Right, sir. This is also mentioned in the literature that cataract, diabetic cataract should be handled by experienced surgeons rather than by the novice.
So any experience of using ranibizumab once you do the cataract surgery and then immediately give your intravitreal on the table?
No, it is also nowadays it is also given on the table.
Yeah.
When there is edema, macular edema, and it cannot be treated pre-op, then it can be given intra-op also.
This is done irregularly in our hospital.
Yeah.
There is definite indication that macular edema progresses in cataract surgery, not EDR as much.
Sir, it should be differentiated from the cystoid macular edema, which is more common in diabetic eyes, rather than the increase in the macular edema due to diabetes. In cystoid macular edema, peribulbous steroid will suffice or nepafenac drops, whereas in diabetic macular edema, you have to give anti-VEGF. So you have to differentiate between these two forms of macular edema.
Sir, one more point. If we can make out that macular edema is there, that means there is some amount of visibility. So my question to the retinal experts or whatever, should we give it as a first injection, then after a month or so operate along with the second injection, or how to?
So if the macula is dry, you can operate. But if you are operating in a pre-existing macular edema, it will.
Vishal garu అయిపోయాక అనగా గారిని చెప్దాం. Yeah. Next, we will go to next topic, Dr. Vishal. Acknowledge Dr. Anaga, madam. You will speak after Dr. Vishal's topic.
Yes, sir. Yes, sir. Yeah. Sorry to join in late.
Thank you, Andhra Pradesh Ophthalmic Society and Dr. Raju for inviting me for this wonderful midterm conference. I'll be speaking on all roads lead to Rome. That is different shades of doing secondary IOL. So as we all know, the best place for an IOL is the capsular bag. But due to intraoperative complications, subluxated lenses, and congenital conditions, often we find insufficient capsular and bag support. Of course, historically, we all used to do AC IOL or sutured SFIOL still in vogue. But secondary IOL implantation has come now a long way from SFIOL and AC IOLs to glued IOL, Yamane technique, and other innovative techniques. So I'll be, just going through a few of the videos. and the common procedures and their complications and what not to do actually. So this patient had a retinal detachment, and you can see there is a subluxated 3-piece IOL, and a corneal wound has been sutured. So we decided not to externalize the IOL, and we tried to internally fixate the IOL here. So first you make the scleral flaps at 3 o'clock and 9 o'clock. It has to be marked with the marker. As you can see the blue marks here, they have to be absolutely diagonal opposite, and you have to have a sufficient depth. And then you make a interscleral tunnel, a long enough tunnel with a 26 gauge needle, and you can mark that tunnel with a dye so that you don't forget where it is. And then you go with the glue dial forceps, and with the help of a dialer, just catch hold of one haptic and gently exteriorize it in this case. And it's always a good idea to first, just to visualize that haptic, you take it into the anterior chamber, and then when maneuver it outside the sclera. And once it's outside, you just tug it inside the tunnel which you have made and marked with a trypan blue. And as you can suture it, or you can have a glue in place. It should be well secured, and you can see the stability of the IOL here. Now we are proceeding with the second surgery, the retinal detachment, which was the primary surgery. And I'm just showing this video. I'm just showing this video just to highlight the stability of these procedures. The band has been put, a VIA surgery has been done, and this picture at the end of the procedure is under air, and you can see the stability of the IOL here. Coming to what not to do in glued IOLs, of course, there are things to remember while you are in the learning curve of these procedures, and a superficial tunnel is not desirable. The flap should not be very superficial, as in this case, and the entry should not be very anterior, otherwise you will drag the iris root and cause a lot of bleeding, and which can make the case a little messy, like in this case. Once you catch hold of the IOL, this was a dropped IOL case. I'm trying to maneuver it while it is dangling in the vitreous cavity. These were very, this is a 10-year-old video. This was the, first few cases. And although I got along well with this case and the results were good, but, this can create a break. The dangling IOL, the haptic can create a break. So it's always a good idea to bring the IOL in the anterior chamber and then reposition it and then exteriorize it, exteriorize the haptics. And that is a much more safe technique. So for the past few years, now we have been exclusively doing this needle fixation technique called Yamane, and a lot of modifications have been described in literature. So first, I'll rush through a few videos, the initial few videos where we did mistakes and we learned from them. So this is a video in which the 3-piece IOL has been opened in the anterior chamber, and now we are making the intrascleral needle tracks. And the needle track is of sufficient depth here. And first we go horizontally and then we go vertically, and it should be of sufficient depth, and it should be exactly biplanar, otherwise it will leak. And we are, needling the haptic into the 26 gauge needle shaft. But now you see what the mistake I'm doing here is that the needle, the other needle for the other haptic is not diagonally opposite to the first needle. So when I try to, thread that haptic into the needle, it causes a lot of torsion of the globe. And that is the, recipe for a breakage of the haptic and dislocation of the IOL. So the lesson learned from this video was that both the needle tracks should be diagonally opposite. This is one more video, and the same thing has been done. The IOL has been put in the anterior chamber. This time, both the needle tracks are diagonally opposite, and there is no torsion. First, the leading haptic is exteriorized in the needle, and secondly, the trailing haptic is being done. The torsion is much less than the previous video. Now look what I'm doing. I'm forgetting about the first haptic which has been exteriorized, and inadvertent pull is being done on that. And finally, what happens is the needle gets disengaged from the optic part, and as the 3-piece IOL, it becomes messy. You have to remove the whole IOL and enlarge the incision. So you have to keep track of the first haptic when it's out. So the original Yamane technique was described with a simultaneously exteriorization of the haptics. Now what we have been doing for the past few years, we have found a safe way of doing it. First, we marked to 0 to 180 degree. Then 2 mm by 2 mm, we mark the entry point for the needle track. We use a 27 gauge or 26 gauge needle and does not leak. We shift the conjunctiva and make a good long biplanar tunnel. You can use a AC maintainer, you can use a pars plana infusion. The globe should be, taught while doing all these maneuvers. Otherwise, there's a chance of probable hemorrhage also sometimes. The other needle is going down. So we have left that needle, first needle in situ, and the other needle is also now inside there. Now what we do, we directly thread from the injector, the 3-piece IOL, the leading haptic into the 26 gauge needle. We are not opening it into the anterior chamber now. From the injector system, the assistant just screws it, and the haptic is threaded into the 26 gauge. And we keep it there. And the second needle, the second haptic, the trailing haptic, is now maneuvered inside the 26 gauge needle shaft. And then, one by one, the haptics are extruded. It is not simultaneously as Yamane originally described. This is a very safe way of doing it. The second thing which we have innovated is we just heat up the 24 gauge needle. You don't need a heat cautery for that. And it works beautifully to make a flange. And those flanges are then tucked in the subconjunctival space. This is one more video of the same technique of our modifications. So we are opening the IOL, threading it directly to the haptic, to the 26 gauge needle. We come out with the haptic and we make a flange in the first go. So when you make the flange in the first haptic, it does not go inside the eye. It is very stable, so you can maneuver freely the second haptic. And when the second haptic is out sequentially, then you make a flange of that also. So I'll skip this one. And we have published a paper in Indian Journal of Ophthalmology of flange making techniques. So if you don't have that heat cautery, you can just warm up the 24 gauge needle. Or if you have an endo laser, as I'm a VR surgeon, even a small, short burst of the endo laser near the haptic create a beautiful flange. And not everything needs to be sutureless. So this was a 4-piece Acryos haptic lens, and it was subluxated because of trauma. And we tried to internally fixate it. So it required some acrobatics. So we went through a trocar cannula system from one side and created a scleral flap from the other side, and railroaded the 10-0 proline from the optic haptic junction, including the bag, and fixated. We just tied a knot. We just did not secure the knot at that time. And the same maneuver was attempted from the other side. The cannula is from the incision, and the 26 gauge needle was inside, and we reloaded the 10-0 proline from the other side also. The other side optics were also included. And then when all the 4 suture ends were out, we tightened, and we had a beautifully centered lens. Of course, when things are not working, and this is a very elegant and a very short acting technique we are all doing now, that is the iris support, that is the iris fixated lens. You just go with the iris fixation forceps, constrict the pupil, just rush through it, and with the iris hook or with the Sinskey hook, you can just enclave the iris. Just make sure that you check the enclavation clause before inserting it inside the eye, because sometimes that malfunctions and then it can be difficult inside the eye. And the other side, the iris tissue is also enclaved in the haptic, and then it's all done. You might get a slight cat eye, but then it's okay. Of course, you have to make your decisions wisely. This was a monocular patient. This is the last video, in fact. This was a monocular patient, 82-year-old gentleman with pigmented retinopathy and a bad pars plana, and there was a subluxated IOL. So we just took out the IOL first, and there's no need of heroism there. The specular count was good in this gentleman. We put the good old ACIOL safely into the anterior chamber, and the patient had an excellent cornea and excellent vision in the post-op period. So you don't have to try maneuvers, because all these maneuvers have certain risk of complication. And ACIOL, I think, if the specular count is good, is a very safe technique. So to conclude, sutureless IOL fixation techniques are the future of secondary IOLs, and reduced morbidity and decreased operative times and excellent long-term safety are the major advantages. A definite learning curve is present in every technique. So young surgeons who are trying this should have a backup plan for the initial cases. Thank you so much. And a humble request for my candidature, your support is needed. I'm standing for members ARC Central Zone. Thank you so much. Thank you again.
Thank you, sir. Excellent cases presentation. I have a doubt in the last case, instead of ACIOL, if it was iris enclaved lens, what would have been?
Yeah, I use that also, sir, frequently. But I had a ACL and the specular was done in this gentleman. So I just thought that ACL would be a good option. You could put an iris fixated lens also.
Okay. Welcome, Dr. Bobili.
Sir, thank you, sir. Thank you very much.
So,
Sorry for the delay.
Any comments?
Yeah. Dr. Vishal, sir, among all these techniques, which one is your favorite? How you will be doing what technique you will be doing most?
Sir, my favorite technique is now Yamane because I have had a long learning curve learning that technique, and I have modified my way of doing it, and now I'm very comfortable doing Yamane. And the post-op results, now we are having 4-year post-op results of Yamane, and the IOL is really stable and without any major complications. The second preferred technique would be iris fixated because it's a very short procedure time.
Yeah, right.
But there's a problem in iris fixated because if you have done an adequate amount of vitrectomy, sometimes the iris lens diaphragm, it moves. There's a lot of oscillopsia in some patients, especially if there's a lot of vitrectomy done in the patient. So I would reserve it as a second option. The first is Yamane if you're comfortable with it.
Yeah.
So
Thank you.
Vishal, I have a question for you.
Yes, sir.
Now, since you're a retinal surgeon, there are many countries where all these secondary procedures, these SFIOs, are exclusively done by only posterior segment surgeons because they are of the opinion that you need a complete, I don't know how complete is complete, a complete vitrectomy before you do these procedures. Do you agree? Do you subscribe to that opinion?
If you had asked me this question a decade earlier, when I was doing my fellowship in Shankar Nethralaya, I would have agreed with you because still I still think the norm there is a complete vitrectomy with a PVD induction and do a secondary IOL. But somehow or the other, over the past few years, I myself am doing a limited anterior vitrectomy and doing this procedure with relative safety and good post-op outcomes, and no case of retinal detachment because of that has occurred. So I disagree with the point that a complete vitrectomy has to be done in every case of secondary IOL.
Yeah, that's not my opinion. That is the opinion of some retinal surgeons.
Still agree, sir. There are two schools of thought. I don't agree with that.
Yeah.
And I think in our practice, most of the my anterior segment colleagues are doing these procedures very nicely, even better than me. And they are doing just anterior vitrectomy. And they don't have any problems in the post-op outcomes.
Exactly. At least in our country, most of the anterior segments are doing this.
Only thing, the vitreous should be cleared very nicely, and there should be no tags in the wound. So
and especially your anterior area in the pars plana, where you are inserting your needles and the glued forceps, that area should be free of vitreous. Ashul sir, you were saying something?
Yeah, Vishal, very nice videos as usual. What are the chances of infection? Because some surgeons have reported that there may be chances of infection in Yamane technique. So many surgeons love to, first do some peritomy and then use this technique. So any experience of this?
Sir, no experience of any infection in the post-op period. But if you're doing a peritomy, it will defeat the whole purpose of doing the Yamane, because it will cause a leakage. Of course, if you are using a 30 gauge TTK needle, which is not readily available in India, then you can do a peritomy. I use a 27 gauge needle, which has a slight amount of leak. I use it because intraocular maneuvering, the threading of the haptic into the needle becomes very easy rather than 30 gauge. That leaks a little bit. But then that is suffice if I'm keeping the conjunctiva closed. And if you're doing a peritomy for that, it will leak and it will cause a post-op hypotony. That is my take on it.
I agree with Vishal. I've been doing M&A for the past almost 5-7 years, I think. 30 gauge, definitely better. But even in 30 gauge, I want to do a peritomy. It's not easily available. 26 is as good. It depends on how you create this flange. If you have not created a flange properly and if you have not inserted it properly, then high chances of infection. There was 2 or 3 cases reported by one particular surgeon. He himself acknowledged that it was the flange. It was disproportionate to the.
Right. Okay.
Thank you, sir. Thank you for the nice discussion. Next, we'll move on to Dr. Anagha, Madam's presentation. Cataract in post-RK eyes. Please, Madam.
Yes, sir. So can you see my slide?
Yes, ma'am.
Yeah. Thank you so much. At the outset, I would like to thank the organizers for giving me an opportunity. And I would be speaking on cataract surgery in post-RKI. So be ready for the surprise. So status post-radial keratotomy is totally different from a post-LASIK eye. These are patients who have relatively intolerance for diminished vision. They want early cataract surgery, highly demanding, and especially because of the highly aberrated corneas compared to the post-LASIK, especially with the larger number of cuts, decision making in all these cases can be very tricky. Most importantly, we need to understand that optical biometry is going to be different, IOL formula would be different, post-operative refraction would be different, leading to a refractive surprise and a potentially unhappy patient. So which formula, which lens, how would you counsel, all that we would like to cover now. So first and foremost, where and what point of time the surgeon will decide that the patient needs cataract surgery. Yes, one option that you can use is the dysfunctional lens index, which will give you a good idea. Significance of at what point of time you do cataract surgery is how much of the aberrations are coming from the cornea, and definitely a guarded prognosis is given to the patient. So challenges are an inaccurate IOL power, determination, visual quality because of irregular astigmatism, higher order aberrations, and the issues of dry eye also. The first and foremost is how do you capture the data? That whether you're using a manual keratometer, auto K, optical biometry, corneal topography you need to do in all these patients, and a pentacam. So getting reliable keratometric measurements is tricky. And we also need to remember that not all of these K readings are created equal. In fact, each of these instruments will use different principles of keratometry, will measure at different points. And that is why it's very important to know how and what to take. Closer to you go to the center, the more accurate you will get. Now, especially in post-keratorefractive and in RK, you have a very small optical zone. You're going to measure the K reading from, say, the paracentral 3.2 millimeters. You're ignoring the central flat region. And that is why underestimation of the IOL power is done. And that is why hyperopic outcomes are usually seen. So you get a very small central optical zone. And in RK, remember, both the anterior and the posterior curvature are affected. Whereas in LASIK, what happens is basically the anterior curvature is affected and the back to front ratio is changed. Also here, using just a third generation formula, where you're using only the AL and the K to estimate ELP, a flat K will assume a falsely shallow postoperative ELP, which will recommend a lesser IOL power, and then that will lead to a error. This was the PERC study, which showed that almost 43% of these patients will have a hyperopic shift. They also show a diurnal fluctuation. If you repeat the biometry in the morning and in the afternoon, you might get a different reading. So ideally, it is better to repeat it 2 or 3 times and see whether you get a repeatable reading or not. And this post-operative transient hyperopia can also occur due to stromal edema around the incision. So the challenges are not only in the inaccuracy, but also you have to account for the long-term hyperopic drift. So it is better to target little myopia, greater little myopia for the greater number of incisions so as to account for the post-cataract hyperopia. Again, try and take your incisions between the RK cuts so as to not cut them directly so that you avoid the opening of these incisions. Now, the use of premium IOLs is very controversial because of you can have irregular astigmatism, higher order aberrations, and already reduced contrast sensitivity from multifocal IOLs can cause greater glare and halos in these patients. You need to counsel them thoroughly because you might have a hyperopic surprise. You might need to use a piggyback. You need to do an IOL exchange. Not only a residual refractive error, but also higher order aberrations and night vision issues. Now, let's see a few cases. This was a patient, 8 incision RK. You can see a cylinder of almost 1.62 and 2 diopters in the other eye. And you can see what the different IOL formula will give you a different reading. Now, for example, the SRKT in the right eye has given you a plus 15, Holiday 2 plus 16, Barrett plus 16. And we use the ASARS online calculator, which is a combination of multiple formulae, where you get the average, minimum, and maximum. And we have taken a slightly myopic target. So 17.5 was used in this patient. So here you put in all the data in the post-RK ASARS online calculator, and then you finally go on to the, you give a myopic target. The better thing about this is you can also put in the readings from the Atlas Zeiss topographer in the 1, 2, 3, 4 millimeter rings. So more data you put, the greater accuracy you will get. It's also better to use the holiday EKR report to see what is the keratometric variability, which will differ from patient to patient. Now, this was a patient where we did a toric IOL, and yes, it's basically the surgery is the same as any other toric IOL. And once the surgery is done, you put in the toric IOL and then align it. Now, in this patient, we got initial, as you can see, second day post-op, a plus 2.5. But this was just a transient hyperopia. The cylinder was around 0.5 residual, but 1 month post-op, the spherical power reduced. So you need to be patient in these patients and then monitor them thoroughly. The rule of twos is you need to plan for an IOL exchange or piggyback not until at least 2 months have passed and 2 consecutive refractions 2 weeks apart are stable. These are the various online calculators and Barrett True K with the total K and intraoperative aberrometry also. It is different from a post laser correction. So it's not the same. So the Hague is L, etc. You'll use only for the post LASIK and not for post RK. This is the ASCRS online and the use of the total K, TK with the Barrett True K. This was another patient with a 12 cut RK. You can see how the topography is showing the typical flower pattern in the center and a higher order aberration. You go and see the holiday EKR report. And this was the IOL master. This was the ASCRS online calculator. And you can see the 7.11 was maximum. We went ahead with a 7.5 toric. And this was the result. Even later on, we rechecked the position. It was good and the patient did very well. Now, this was another patient, 47-year-old, 4 cut RK only. And these were the higher order aberrations were not very significant. And you can see this very tall peak on holiday EKR, which shows that there is not so much of keratometric variability. This patient wanted a trifocal IOL. So guarded prognosis was given not only for residual refractive error, but also for the glare and halos. And ASCRS online calculator was used. And this was the surgery. And we put in a trifocal. Patient did very well with a very good post-operative refraction and 6.6 and 6. This was another patient, 18 cut RK, one of the flattest case I've seen, 27 and 28 keratometry. This was the online calculator, 26.8, but we used a 28 diopters because it was a 18 cut RK. Now, when you have multiple cuts like this, it is ideal to take a scleral incision so that you don't open up the incisions. Here, as you can see, once we take the incision, as we are doing the phaco, the incision is opening up, not only the main incision, but also the side port. So you have to be very careful in these cases and take a suture wherever required. But post-operatively, the patient did well. This was the last case, a patient who was one-eyed. The thing was about this was not only the cut, 18 cut RK was done, but also LASIK was done in this patient. So this was the eye that was lost. And this was the other eye, and he came to us for cataract surgery. You can see the metallic deposits in the interface with the RK cuts. And this was the topography. This was the holiday EKR report. And now the dilemma was, now which IOL power to use? Now we can see here that if we, on the left, you have the post LASIK, and on the right, you have the post RK calculation. And the difference is in the left eye, the Technis lens was 23 diopters. In the right side, you can see the RK is 21 diopters. Even on the ASCRS online calculator, the post LASIK was an average of 24 and maximum of 26, and post RK was average of 20.8 and maximum of 21. So we went ahead with a 25 diopter finally. We took the post LASIK data. You can see the OCT cornea shows those metallic deposits. We also did a flax for this patient, and the surgery went off uneventfully. We took a scleral incision so as to not open up the incisions, as this was also a one-eyed patient. Capsulotomy flap being raised, gentle hydrodissection, phacoemulsification, irrigation aspiration, and then the intraocular lens that was put. Fortunately for us, the patient did extremely well and was 6/9 unaided. To conclude, in today's age where we have access to very good IOL formulae, decision making, yes, can be difficult, but because of the multiple options of calculations, we can get good visual outcomes. Counseling is extremely important in these patients. Monitor them very thoroughly, and one can get excellent results. Thank you so much for your kind attention, and humbly seek your blessings and support for my second term as member ARC West Zone in the oncoming AIC elections. Thank you so much, sir. Thank you.
Thank you, madam. Excellent presentation. All the cases, so complicated cases. It's a pleasure to see the surgeries. I need experts' comments or any questions.
I would like to ask about the trifocal IOL because we never used trifocal IOL.
Yes, ma'am. This was only a 4-cut RK. In a 16-cut, 18-cut, we would never use.
Yes.
The corneal topography was very regular. As you saw, the holiday EKR report was a very tall peak. That means there was no keratometric variability. And the patient was ready to accept a refractive surprise, ready for glare and halos. But he was using computers for a long time, so he wanted a trifocal. In fact, we have done the other eye, and now it's almost 4 or 5 years post-op. He's doing very well.
So is he into nighttime driving?
Case to case basis. At that time, EDOPs were not available. This was done 5 years ago. Today, probably we would go in for an EDOF like a VVT or an iHands.
Yeah, that's what I'm saying, because nowadays, if some patient comes for RK, so naturally we will, if the patient wants a computer, we will go for the non-diffractive IOL. And even in the non-diffractive EDOF IOL, we have to consider if it is 4-cut, you can, but then if it is
not in multiple cut, no.
Yes, not at all.
Not at
And
all.
what about the halo and glare thing? The patient is satisfied, nighttime driving?
Very satisfied. Because it was only 4-cut, ma'am. It was only 4-cut. And
so he is not experiencing any halo glare?
No.
He's not experiencing?
No, he's not.
Okay.
That is why I presented this case, but it is that does not mean that we can use it in all cases. You have to look at the case to case basis only, and you have to choose and select the patients with caution. The general message is obviously you cannot go in. At the most, you can use things like iHands, which are an extended monofocal, which will not add to the glare and halos.
So I will ask the faculty here to share their experience. Have they used the non-diffractive in RK, and what is the result? Because even in as far as non-diffractive EDOF is concerned, the precaution has to be exerted if it is a case of RK, post-RK. So any faculty here who is present has used this non-diffractive, not trifocal, non-diffractive EDOF in post-RK patients? I would like to know.
We haven't used, but would you consider the optical zone that was used for the original RK if the optical zone was large? So you may not get the problems. Is that what happened in your case, Dr. Angana? What was the optical zone used for the RK? Was it a wide optical zone?
Yes.
Optical zone?
Yes, sir.
Okay, and wide optical zone.
Yes, that is why we went ahead.
Yeah.
We did the pentacam, we did the topography, and we did the holiday EKR report also I showed you. So the patient was, and the vision was quite stable. Vision was 6 by N6. We did an aberrometry also post-op, and the higher order aberrations were not high. And that is why probably we got away with it. So that is why the message across is that if there is a greater aberrations on the cornea, then we should not go in for a multifocal IOL. It is best to go in for a monofocal IOL, which will give excellent distance vision, and definitely you can ask the patient to wear glasses for near as well as intermediate. But in today's world, with a good EDOF lens or an extended monofocal, for example, like iHands, we can go in for, because it's basically not adding to the glare in halos.
Because nowadays, even nowadays, nobody is using even non-diffractive EDOF for post-RK patients. Maybe people can use iHands, but usually people are going for a Clarion, some monofocal, nice focal lens. So if anybody has used in...
Ma'am, can I add to this, ma'am? I think Anaga was clear. EKR report, when it says that the central cornea is good, we can still use the enhanced monofocals.
Yeah, that's what I'm saying. Enhanced monofocal.
Enhanced monofocal. If
the message should go like that.
If the central part of the cornea, that is a visible area, is good, that is indicated by the EKR report which she showed. Now, if there is any difference there, even an enhanced monofocal should not be used.
Yes.
In fact, even the aberration neutral lenses we try to avoid in RK if the cornea is not good.
Yes.
So in the interest of time, can we go to the last topic? We have reserved the best for last. We have Dr. Bharati Kashyap, ma'am, the scientific committee chairman of Jharkhand Ophthalmic Society, a powerhouse of energy, as you can see. Ma'am, please go ahead and share your screen, ma'am.
Okay. So first of all, thank you so much, Andhra Pradesh Ophthalmological Society, Dr. Madhu Raju, Dr. C.V. Gopal Raju, for giving me this opportunity. So my talk is my experience with novel non-diffractive EDOF IOL. This is cutting. Wait, I cannot see the screen fully.
It is visible to us, ma'am.
Okay. So is it not changing?
You can stop sharing and reshare again, ma'am.
Okay, okay, I'm doing. Am I visible?
Yes, madam.
So again, it is cutting. How can I present? इसको इधर करो. So the need for an optical problem-free IOL is very much needed for a tension-free surgeon. So an IOL which should have an optical disturbance similar to monofocal IOL, distance intermediate and some functional near vision. Patient can read mobile text at 66 centimeter, can be clubbed with a monofocal lens in the other eye. So the need for an extended range of vision IOL is much felt because presbyopia is a pain. 60 is the new 50 or 40 because we have longer active working life. Because of the diabetes, steroids, and trauma, the cataracts are happening in younger patients. The need for intermediate vision has increased because of the invasion of devices and the screen. So are trifocal IOLs the panacea? No. The loss of contrast, it is avoided in diabetic retinopathy, glaucoma, macular degeneration, post-refractive surgery, and it creates visual disturbances, halos, starbursts, and glare. So are EDOF IOLs the answer? Let us see. So I cannot see the full screen. So novel non-diffractive EDOF IOL with 6 mm biconvex aspheric non-diffractive wavefront shaping technology, elevation and curvature change uses complete proprietary X-wave technology. So the X-EDOF are defined by both range of visual acuity and absence of visual disturbances associated with conventional EDOF. So the wavefront shaping and next generation optical principle has an X-wave technology, has two surface transition elements, stretch and shift the light, and it results in continuous extended focal range. Now you can see the 7x magnification. The surface transition 1 is a slightly elevated smooth plateau. It stretches the wavefront, creating a continuous extended focal range. Surface transition 2 is a small curvature change to across 2.2 millimeter region. This shifts the wavefront to utilize all the available light energy. Now you can see the delayed and the advanced wavefront. The monofocal IOLs only focus the rays on the retina. The transition element 1 of the non-diffractive EDOF stretches the wavefront. The transition element 2 shifts the wavefront. You can see here So what is XWave technology? This is a next generation optical principle called wavefront shaping, continuous extended range of vision, flexible and forgiving the focus curve. And the company says that the binocular mesopic contrast sensitivity is compared to axis of IQ. But I'm going to present you a research which we did conducted in our hospital, and we found that the mesopic contrast of VVT is significantly lower than the IHANS. ICBU. This is a 60-year-old guitar teacher of my son. He lives in Ranchi. He does a lot of driving and he needs intermediate vision. So he knew everything about panoptic, synergy, VVT, monofocal through the net. He had unilateral hypermature cataract. Now I gave him two options: drive comfortably, no visual disturbance, but use a small reading number for near. Option 2, read comfortably without glasses, but some amount of visual disturbance while driving. And this was a non-correctable problem. Obviously, he opted for option 1. Now, the patients, whenever we used to give for a far intermediate reason, spectacle-free vision, we always opted for the monofocal plus IOL. The monofocal plus IOL takes some of the light energy from peak, that is 0 defocus point, and distributes it to a wider range. ICBU, but both the lenses, IHANS and VVT, does the same. IHANS does it to a far intermediate range, that is 1 meter distance, and VVT takes more light energy and distribute it to a wider range, that is up to 2 diopter. So number of photons, remember, is constant. So different IOLs just shift the energy to different positions. We cannot have the same high quality vision for distance intermediate and near at a time. So ICBU distributes the energy a little more to far intermediate, taking some of the energy from 0 defocus as compared to JCBU. And now you can see that DF215, that is VVT, distributes the energy to intermediate zone, taking some of the energy from 0 defocus to as compared to the monofocal. Implanting the ICBU targeting monovision with the dominant eye emmetropic and the non-dominant at 1.25 expands the effective defocus. But you can have the same effective defocus range by just making the non-dominant eye minus 0.55 after myopic. And this is this study is also published in Eurotimes. So, but most patients which are implanted with non-diffractive novel EDOF IOL experience some loss of contrast sensitivity as compared to the monofocal IOL. Therefore, it is essential that prospective patients be fully informed of this risk before giving their consent for implantation of axis of IQ VVT. In addition, patients should be warned that they will need to exercise caution when engaging in activities that require good vision in dimly lit environments such as driving at night, in poor visibility conditions, especially in presence of ongoing traffic. So professional pilots, trifocal is absolute no. And for hypercritical, genius, ingenious, mathematicians, anxious patient, you can consider the VVT. And VVT, the precaution has to be exercised when we are considering VVT in case of in patients where there is ocular pathology, macular pathology, there is advanced glaucomatous defect, pterygium, corneal opacity, post-RK eyes, irregular astigmatism, kappa angle more than 0.6, severe dry eye. So this is it is also pupillary dependent. So if pupil size is 2 millimeter in the resting room light, then you can go for we select the IOL with emmetropic target. And in this case, we have done, you can see the post-op eye trace, and the refraction is near emmetropia. Here the pupil size was resting room condition 4 millimeter. So here we select the IOL with slightly myopic target. And when we did this, we found that in this case, the post-op aberrometry, you can see the diffraction is near emmetropia. So my experience with VVT is axis of VVT provides high quality uncorrected vision for far and intermediate with a good function near vision. The visual disturbance profile are similar to a monofocal aspheric and quite well superior to those obtained with a diffractive IOL. Axis of VVT reduces a spectacle need for near with a high satisfaction rate. But what we found that mesopic contrast sensitivity of VVT DF215 is significantly less than IHANS. So we did a study to compare a clinical outcome of ICBU new monofocal plus IOL with the enhanced intermediate function with non-diffractive new EDOF IOL DF2. And we found That is a prospective non-randomized comparative study, single center, tertiary eye care center. The group 1 and group 2 both have to 40 eyes, 20 patients. These are the inclusion and exclusion criteria. I'm forwarding few slides as time is less and everybody is now tired, want to go back. So we found that distance visual acuity has a comparable result in both the case, group, but the intermediate visual acuity uncorrected and distance corrected at 66 and at 50 was significantly better in group 2, that is DF215, and then uncorrected and distance corrected near visual acuity at 40 centimeter was also significantly better in DF215. But as far as mesopic contrast is concerned, it was significantly low in VVT as compared to ICU. Again, we all know that defocus curve was better, significantly better at 1.5 to 2.5, and the proportion of patients not at all bothered by starburst halos and care were comparable between the two groups. The proportion of patients having post-op reading speed and intermediate distance were significantly more in group 2, that is VVT, DF215 in bright and dim light. So, my take is, it is a welcome addition to a spectrum of different IOL options. We can customize the surgery and visual outcome for each patient and each individual eye by elongating the depth of field by 1.5 diopter. But there is a compromise in mesopic contrast, that is the quality of contrast, especially at night. Good news is that there is no diffractive ring. So we avoid glare and halo that comes with diffractive technology. Thank you. Thank you for the patient hearing when the session is ending. Thank you, Dr. Madhu.
Excellent, madam. Excellent talk as usual. I think we'll have a quick panel discussion. I request all the panelists on their camera, and we'll be finishing this session over the next 10 minutes.
This society is very active society. Since day-long webinar and everybody's here.
Yes.
Madam, the one thing that I found out about all these premium IOLs, very important is the counseling, where you have to tell the patient, you are not as young as before, where you can shift the defocus curve across the range of vision, and you cannot do that anymore. And you are going to compromise somewhere. There is, as you said, only a set number of photons. You cannot increase the number of photons. So you have to distribute it along that defocus curve, and he is going to lose out somewhere. And the company does not lose out. They make a lot of money. We have the problem. We have to counsel the patient. We have to break our head with the patient, but they make the money.
So VVT is not an absolute answer. Not at all. I have seen many presentations showing VVT is so good, VVT is so good. Yeah. I find VVT is the ultimate answer. It's not the
Good evening, ma'am. Good evening, Bharti madam.
Good evening. Dr. C.B. Gopal Raju.
Same energy, I can see you. North and south, east and west, Bharti is the best. Thank you, madam, for participating and also excellent presentation.
Actually, since my study days, I always have the liking for South Indians. Because I always say that study from RP Center to Coimbatore, Arvind Eye Hospital. The down south I went, the better people I found. I always say.
Thank you, madam.
I appreciate you people a lot.
See, coming to the VVT, that is more forgiving, madam, for the
forgiving, but it is not as forgiving as it is anticipated.
Yeah, if you compare the cost and other things, definitely, but our expectation should not be compared with the trifocals. So it is altogether suitable for a different set of people, right? When they are not very worried.
Yeah, we put it regularly in our hospital routinely, but then it is not the answer, ultimate answer. VVT has a lot of issues.
Yeah.
Problems. It cannot be given still better than others.
Yeah, still we are in the evolving stage. Still we are not yet to reach a perfect replacement of a natural vision.
And the other thing is that it is very costly. VVT told patients, most of the patients in India, they are not middle class. So they always say, Madam, itna paisa kahan se layenge? So we always look for a lens, another lens, biotech, which is cheaper.
Yeah. In focus also, I have used a few patients.
Yes.
We are also doing quite well.
Yes,
So,
in focus.
Yeah.
That is Appa, na? Appa.
Yeah, Appa.
So what is your experience of in focus? This is a equivalent to VVT?
Yes. Yes. Equivalent, madam. Almost as good
And the
as
company says that 40 centimeter, of course, it is significantly better than IHANS at 40 centimeter. But then patients are not reading, and my 6 centimeter patients are reading mobile at a distance of 50, 60 centimeter. That's good. But nearer, this lens is not capable of making them unable to read a 40 centimeter. Not at all.
No, N6 cannot be with the VVT, and then EDO, any EDO for that matter is not for N6.
The company says, and the company says that its mesopic contrast is good. Its mesopic contrast is not good.
Yeah.
Swaruprani, any final comments before Dr. Reddy sir and Vishnu sir come in?
तो मेरे को लास्ट में चुन लिया.
Madam, we
You
wanted
are the
to
best.
end it with a blast.
With a blast, yeah, right.
Swaruprani, ma'am.
Raju and CV Gopal Raju kept me in the last.
No, ma'am. If you see, you are the only non-contestant.
No, generally, any meeting chief guest will speak last.
Madhu, shall I add one point?
Yes, sir. Please go ahead.
Yes.
Yeah. There is one lens that is Swiss Active Vision lens, manufactured by Swiss company. We can choose the EDY factor. We can choose the bifocality in that one. We can assess the patient by asking him to read and make him to sit into the system. We can measure the distance from the eye to the near vision requirement and intermediate vision requirement, so that accordingly we can order the lens. That might be the best solution for all these things. Probably we don't have that vision in India. Hopefully some company makes that one. Hopefully Alcan or some other company should bring to the technology. That definitely it's probably it should be wonderful. That's what I think.
Can I just add a point, Dr. Ramesh?
Ellen,
yeah, sure,
Ellen,
sir,
yeah,
sure,
please go ahead.
Sure.
See,
Yeah.
the EDOF factor, if we keep increasing, again, dysphotopsias are very common. So a safe EDOF factor, I don't know the exact number of that EDOF factor, but is something which gives an addition of around 1.25 to 1.5 only. So any of these lenses, if you see all the international or the Indian lenses, we have an addition of 1.25, 1.5. So 25 to 30 centimeters, we cannot read. How do we do that? We have to do a mini or a micro monovision, play around with the other eye, the non-dominant eye, and then bring in that factor. That would be the better step.
But sometimes the problem is the patient has bilateral cataract. How you will see which eye is dominant or non-dominant?
Agreed, ma'am. In that case, we can take his history, which eye he was using predominantly, say for any of his recreational activities or even day-to-day activities. Or operate one eye and then go ahead with the...
Yes, Ellen. Thank you very much for sparing your time.
Thank you, sir.
Thank you, Anaga. Also, Anaga on one side is conducting a similar midterm MOSCON, and she was quite busy, but I'm thankful to her sparing her time and then logging here and then sharing her knowledge here. Thank you, Anaga.
Vishnu sir.
Madhu, is it over?
Yes, sir. Yes, sir. Vishnu sir and Reddy sir, final comments and we'll close it, sir.
Thank you all. I'm Dr. Vishnu Vardhan. I'm the treasurer of APOS and the previous secretary. Actually, I appreciate Madhu and Gopal Raju for conducting a very well conducted midterm APOS conference, today's virtual conference. And
this was the vision of our Vishnu. Since long time, he was saying midterm virtual, midterm virtual. You are the main man behind this, sir.
Virtual is the future, no? Virtual is the future. Otherwise, we cannot bring all these galaxy to the webinar.
Yes.
That's the future, no doubt about it. And I appreciate both Madhu and Gopal for conducting very well conducted conference. And I appreciate all the Galaxy faculty, national, international, for sparing their time and expertise and giving great lectures. It's a very quality webinar. Today's webinar is very quality webinar, and I appreciate all the Galaxy faculty. And of course, we appreciate at one point of time, I think the audience in YouTube and FaceTime is around 2,200 or 300, Madhu?
Yes, sir. Around 2,300 it was there.
Yeah. So that is the range of this webinar. And appreciate all the audience for sparing their time and patiently hearing to the this webinar. And before that, before I end, a small appeal. Both me and Gopal Raju is contesting for Joint Secretary for AIOS elections, and I posted my nomination for Joint Treasurer. Since then we thought I was burdened with other responsibilities, both in APOS and personally. So I decided to opt out of the race, but I cannot withdraw in time. So, but my name will be there in the ballot paper, and more than my opting out, we thought to have a good representation in the AIOS from APOS. Last time executive, we were not having any representation, so we are bent upon having our representation. So we decided our meritorious candidate Gopal Raju to contest and ask only one vote for APOS from all over India. So please cooperate and make Gopal Raju as a Joint Secretary for the next AIOS. And it looks very odd to say, don't vote for me. Yeah, and not to waste your vote. And as a Joint Treasurer, Alan Kumar is there in the race. So in the interest of this one, I support Alan Kumar, and I request all of you to transfer your vote to Alan Kumar instead of me. And all the contestants, I wish you best of luck. And APOS, whoever is friendly with APOS will support you, all of you, and best wishes to all the contestants. Yeah, we'll meet in the Kochi. Thank you all. And once again I repeat, Gopal Raju is paramount for us.
This time in Jharkhand, we are doing bulk voting. So one candidate we are choosing.
Yes, sir. Gopal Raju, sir. Yes.
As a Joint Secretary.
Only one vote we are asking, madam.
So this time we are organizing a Zoom meeting. We will do a meeting, and then we will do a bulk voting for a set of people.
Yes. Thank you, madam. Thank you so much.
Definitely South will be the priority.
Yeah. Bharti madam, please do consider.
Please include my name, madam.
Sir, I want to thank
they are very sweet.
Nadella sir a lot. Thanks a lot, sir. And we are fully in support of Gopal Raju sir. Definitely.
Yes. Thank you so much, Gopal Raju sir, and thank you so much everyone for this.
Thank you, Anaga.
Your state should also do a bulk voting. Same set of people.
Yes.
State has a power. Otherwise, if you are scattered, there is no power. United, you have a power.
Absolutely, ma'am.
In continuation with, I'm audible, Madhu?
Yes, sir, yes.
In continuation with what Vishnuvardhan told, the most important for us is Gopal Raju. I request all the faculty to vote for Gopal Raju, because we are actually want Gopal Raju to be in the executive of the AOS. And who is exactly told by Vishnuvardhan, we are always with the people, best wishes of us. We will be a vote for all those friends of APOS. Always APOS is always known for its unity. And if you think we will support one person, definitely we will see that that person should win. And not only we try in our state, we tell to other friends also outside the state and see that the votes will be given to our friends. So my main request is you all please support
Gopal Raju, and Gopal Raju should win with a maximum majority.
Thank you.
Thank
Thank you.
you.
So much.
Thank you.
Thank you all.
Definitely, sir.
Raju is our joint secretary, right?
Yes, yes,
Gopal
madam.
Raju
Yes,
is
madam.
standing
for joint secretary.
Odisha
And
State is with you, sir.
And Dr. Ilan Kumar.
Thank you, sir. Thank you so much.
Joint treasurer, ma'am.
Ilan has to win.
And Dr.
Thank
Anga.
you, sir.
So is
Fighting
the
for
same.
member ARC West
Yes,
Zone.
yes, I know.
Member
Thank you
ARC
so
East
much.
is here.
Thank you.
And Bharti madam for Rajya Sabha MP next session.
Not now, 2032. Not now.
So that's why I'm asking the support now only, madam. Thank you all once again. I thank my wonderful scientific committee team for supporting us in all these endeavors, and the APOS executive for readily agreeing to whatever we wanted to do. And special thanks to Gopal Raju sir for conceptualizing this program and working behind the scenes and putting the program in place. Thank you once again, sir.
Thank you.
Okay, thank you. I think we have to convey our thanks also to Dr. David Chang, who really
Yes, sir.
added the value to.
We have
the
sent
entire
the
program.
mail to him, sir, with all the statistics.
Yeah, convey all
And
that.
we'll be sending that oration plaque also along with Ashok to hand it over to him in ASCRS meeting physically.
We'll thank all the moderators,
Our
panelists,
expert panel from
and the
APOS and
speakers.
moderators and chairman. Yeah. Thank you once.
Thank
It's a
you.
great day, great
Bye.
learning.
Yeah.
Yeah.
Yeah, it will be stored in YouTube. So
Yeah, we can.
visit
Yes, sir. It
that.
should be. It should be. And it
Yeah.
was a really great learning today. A lot of
APOA Andhra Pradesh Ophthalmic Society YouTube channel is there. Please visit and then you can view anytime
Yes,
in your leisure time.
Yeah.
Thank you, Madhu. All the best.
Thank you, sir.
Enjoy the Sunday
Thank you, Madhu.
evening.
Gopal Raju,
Bye
sir.
bye.
Yes, sir.
Thank
Bye.
Thank you. Thank you.
Bye, madam.
Thank you.
Bye. Bye.
Thank you, madam.
Thank you, madam.